systems. Yes, so that was a recap from yesterday, and we hope today will be as fruitful as yesterday. Thank you.
Thank you so much, John, for the quick recap. As I said, we have already lost some time, and we'll try as much as possible to see how best we can gain that back. And so to kickstart today's session, I would like to hand over at this point to our colleague from UNECA, Dr. Riwa Khalifa, to take us through the next session.
Good morning, bonjour, marhaba, as I'm Lebanese also. So I'm Riwa Khalifa, and I work with UNECA, and I'm happy to attend this meeting, and I can see the big enhancement in your report since the last time when we have met in Ghana. So yesterday, we learned a lot of lessons from the presentations from many African regions. Now today we will continue, and we will start quickly since we are running late. So the first presentation, so I invite Cecilia Okeke-Chinyere for COVID-19 vaccination delivery strategies assessment in Nigeria toward achieving equity in vaccine delivery. So you have 20 minutes, and
hi, good morning. My slides, please. Okay, I'm here to present our study. It was supported by USAID, and it was conducted in 17 countries where we looked at COVID-19 vaccination strategies, the delivery strategies towards achieving equity in vaccine delivery. These are my co-authors from R4D organization. And okay. So I'll go through the outline. I'll have a background, state the objectives, the methodology, the results, the conclusion, and then the key messages or the lessons learned from this. It's not working. Next slide, please. So COVID-19 resulted in millions of deaths worldwide with a disproportionate impact on certain population groups, such as the healthcare workers, the elderly, the pregnant women, and those with comorbidities. So as the pandemic continued to evolve, the resilience of health systems and vaccination strategies had to be strengthened in order to address the new target populations, in order to increase our delivery volumes, to achieve diversity of delivery strategies, and then complex vaccine profiles. So this is part of a USAID-funded multi-country study, like I had said. We aim to capture lessons learned from the COVID-19 vaccination delivery strategies and modalities. In this case, we are concentrating on Nigeria, those that are effective in reaching the priority groups, those that are most likely to be affected by future epidemics or pandemics, or even the resurgence of COVID-19 in case it comes again. So next slide, please. Our objective was to identify the challenges for reaching priority groups with these strategies, including equity considerations and reporting of disaggregated service data by socioeconomic groups. We looked at gender, age, urban and rural location of our recipients. Also, we identify solutions that countries have deployed to overcome these challenges. The second objective was to understand the types of vaccine strategies and actually the vaccine types that were successful in reaching these priority groups. And our third objective was to determine the resource items that are essential for costing vaccine delivery strategies in terms of making adequate budgeting and for future planning. So for the next slide, please. For the approach, we used the mixed method approach, where we had to quantitatively identify vaccination coverage data and disaggregate them, like we said, into gender, age, sex, and all those. And then we also had the qualitative approach, where we conducted interviews with key informant interviews and focus group discussion with the recipients. And then we had a co-creation workshop early in the course of planning. Here we had to identify the key stakeholders in order to understand the context of implementation and system conditions that affected implementation of COVID-19 vaccination strategies in order to reach the priority groups in Nigeria. For the interviews, we conducted 39 key informant interviews and then 8 focus group discussions at the subnational level. Next slide, please. So the choice and criteria for selection of sites, we had to use the national here in Abuja because it housed all the major key stakeholders that made national decisions. And then we also chose 2 subnational levels to look at. And those were Lagos State, which was the epicenter for COVID, and it had the highest burden of COVID cases in the country, and it's also located in the south. So we needed to balance it by choosing also a subnational in the north, and Kano had the highest population also of COVID cases. And then we looked at their own delivery strategies and if it aligned with the national intentions and agenda. Next slide, please. So the methodology, we had a stakeholder mapping where we identified the relevant stakeholders that are involved in COVID response strategies, and then we categorize them into governmental and the non-governmental actors in order to reach a wide variety. And then we had the stakeholder engagement after identifying them, where we identify their positions, their interests, and their levels of influence of these stakeholders, more like a stakeholder mapping was done. And then we identified those that we should be interviewed, those that we need to communicate with, and then we scheduled our interviews. At the end, like I said, we conducted 39 interviews and 8 focus group discussions. Next slide, please. So these are some of the people. The list is not comprehensive. I have the government workers. Those are the Presidential Task Force for COVID, which was set up early in the course of the COVID vaccination by the presidency. And then we have the main people that were in charge of vaccination in the country, which is the national and state primary healthcare delivery agencies. Also the counterparts, the Nigeria Center for Disease Control, the state and the national ministries of health, and then the COVID task force, both at the national and state level, and also the NAFDAC, the Agency for Food and Drug Administration, because they gave approvals for vaccines to be brought into the country. And then for the non-government, we also had the NITAG. Sorry, I missed that there. The NITAG was essential in advising the vaccines to be used. We also had the non-governmental people like the CSO, civil society organizations that dealt with COVID. We had the donor agencies, WHO, UNICEF, we interviewed all of them. And then the FGDs were done with the community members, the healthcare workers at the community level to assess how some of the policies and the delivery strategies that we adopted at national played down on them. And then we had the CACOVID, which was the non-governmental partners, private organization that were coalesced to support COVID-19 delivery, vaccine delivery. We also had some mixed actors like the ministerial experts and members of the professional groups who were all part of the advisors to COVID implementation in Nigeria. Next slide, please. So we analyzed our data using a thematic approach where we had employed both deductive and inductive coding methods. The deductive coding, we are guided by themes that were generated from the guide, and the transcripts were coded using the qualitative research analysis software Atlas TI to version 23. And we also had ethical clearance gotten from the NHREC for the study before we commenced. Next slide, please. So our findings, the results. We identified initially the systemic factors that affected COVID-19 vaccine implementation. And most of them, as we can see, were majorly with the presence of a vaccination deployment plan that Nigeria had immediately, even before we introduced the vaccines that were brought to us in early 2021. We had a plan that was used, and it guided a long way in how things will play out. We also had a strong political leadership and commitment, starting from the presidency. They gave adequate attention and also supported with funds for acquisition of these vaccines. We also had effective use of the newly introduced EMID, that's the electronic management of immunization data system. It was introduced in March 2021 as well to capture all COVID vaccination both the rural, the churches, religious, schools, everybody was engaged even before the vaccines arrived. We also had support from the private sector, a very big one, which is like the first time the country is seeing private sector come out fully to support health in terms of implementation, which was seen in this COVID vaccine deliveries. We also had employment of performance-based financing for the vaccinators. So they knew that each team, if you go out for each day, you'll be paid according to the number of people you vaccinated. We found that to be very effective. We also engaged stakeholders, professional associations, religious groups, community leaders, and all these contributed to the effectiveness of the vaccine strategies. At the right are some of the quotes to prove that. Next slide, please. So the key priority groups that were targeted for COVID-19 vaccination in Nigeria were the healthcare workers, the immunocompromised persons, those that are living with comorbidities, and adults that were over 50 years of age. So this was prioritized based on the availability of vaccines at the moment. We all know that the first time we were receiving those vaccines, they weren't enough. So we had to check, so who will receive and who will not receive. So these were the main groups that were prioritized for the first stage recipients of the vaccine. But when hesitancy came in, like we'll see later on, and the groups that were prioritized were not forthcoming, they had to bring in other groups to join in the priority. So it was a phase, it was a multifaceted phased thing. After this first stage, we had second stage, and we continued expanding until we had all adults from 18 years and above. We are eligible to receive the vaccines. Next slide, please. Okay. The strategies that were effective at reaching the priority groups were mostly mobile vaccination units, which were introduced early. So for those mobile units, we had those in the health facilities, but some carried it to an extra length, bringing it nearer to those that are in the hard-to-reach areas and those that couldn't come close enough to the health centers because of distances. So they had to set up mobile units there. Even in any organization that had large population of people in the IDP camps, in the military zones, in tertiary institutions, in government organizations where you have large number of people, the secretariats, they had to carry mobile clinics, mobile vaccination teams to be positioned there daily in order to capture as many people as possible. And then there was also the introduction of campaigns, vaccination campaigns, which happened in many places and parts of the country where they felt, okay, people were not coming out to take enough, campaigns were taken to them. And for university settings, they had to dramatize the thing, go with cards and all, and we call these storms. Those storms, we are highly contributory in increasing our vaccination coverage, because in each of those days, many number of people were vaccinated. And the vaccines that were found useful were AstraZeneca, Moderna, Pfizer, and then the Johnson & Johnson vaccines. These were also approved by the World Health Organization for use in Nigeria, and they were endorsed by NAFDAC and NITAG. So NITAG had to make their inquiries and advise the national primary healthcare agencies on which of the vaccines to purchase and use. So initially we started just with AstraZeneca, but as vaccines became more available, we had to diversify to Moderna and Johnson & Johnson, which is a single dose. And those were found to be quite effective for hard-to-reach areas, so that people don't need to come out 2-3 times or come for boosters later on. So some of the implementation challenges that we identified were communication challenges. And even with the use of the electronic management of immunization data, the new ME that was introduced, some areas didn't have coverage, internet coverage for them to be uploading data. So we found that to be a very big challenge. So you could see vaccination teams, they will vaccinate so many days before they come out to where data is and upload. So it wasn't giving us real-time data for those at the back end in the offices. It was a big challenge. And then there was hesitancy was quite large, especially among the prioritized groups. The healthcare workers were not getting immunized. The first instance, when it was first checked, just 4% of healthcare workers from the data we had received after so many months of making it available to them. Then with all the preaches and all, you now see the numbers increasing 10%, 50%, but we still never got up to 50% of healthcare workers receiving the vaccines that had been prioritized for them to take. And they are the ones that are vaccinating others. So you keep wondering, when you don't receive something and you want people to come and take the same vaccine that you have refused, how will it happen? So that was a very big challenge for us in the country. In fact, at a point at the ministries of health, they had to do, if you do not get vaccinated, you don't come to work. If you don't show your cards, and then that one also had its own challenges. We now saw people go to get cards without taking the jab, but they had the cards. And that also comes to question, how did it happen? So we had a lot of challenges in implementing COVID-19 delivery in Nigeria. There were also socioeconomic factors that most people, the elderly, they couldn't access coming out. Some of them needed helpers. And during the day, all the children would have gone to work and wives. So they're left alone. We had to do some door-to-door after some time to be able to capture the elderly because they were among the priority groups. There was also disruption of routine health services because of vaccination. So when people were now out to get vaccinated, the crowd in the primary health centers were so much. So all the healthcare workers were now concentrating on vaccination and leaving out the other essential services for people that were sick. Other immunization, even for childhood, suffered because of this. And treatment of normal ailments, malaria, and the rest, everybody, all the line was now for only COVID vaccination, which in its own was also not good at all. We also had public misconceptions that affected the acceptance rate. We had identification challenges of individuals that are in the priority group. So some of them, how do we know you're a health worker? Some didn't have badges, some didn't have any means of identification. And then a lot of truancies were played in that effect. There was also the problem with getting a database for these various priority groups. So like the elderly, what they did was just an estimate that this 5% population of the country are elderly. So how do we know who is the elderly and who is not? There was no clear-cut database for the country. Nigeria, you say, if you go here, you see your name, you are an elderly. So we also had incomplete payment of the healthcare workers' incentives. Those were at the later stages. You know, they were told if you meet so and so criteria, it's performance-based, you'll be paid. So at some point in time, we are not receiving all their payments, which, like I said, was also problem of data. So we are not uploading on time. So we are not, there were challenges everywhere. So the workers felt demotivated and at a point even wanted to withdraw from the whole exercise. Okay, then, so what are some of the solutions or innovations that we used to overcome the challenges that we identified? We had to build trust in tackling hesitancy. We had to build trust. We used the religious leaders, the emirs, the cultural leaders. They come to their places of worship and take the jabs, and people see them take and are willing to receive COVID vaccine as well. In some cases, coercion, like I said, for healthcare workers, you had to coerce them to show their cards before they could come to their place of work. We also use innovations in logistics areas. Yeah, we had a lot of logistic challenges. We had to use third-party delivery for us to maintain cold chain and all. We also introduced a lot of other things, combining COVID with other vaccines to deliver to some hard to reach areas, and bringing in experts, technical experts from WHO and the rest to help support in the logistics area, because at a point it was a huge problem. We also recruited ad hoc staff to tackle the shortage of human resources. The volunteers and ad hoc, even retired nurses were redeployed to some places. And then we used vaccine approval and safety assurances, integrated community engagement in all the activities, collaborated and integrated vaccine delivery with other healthcare delivery services. And then we had this data-driven decision-making, all the decision concerning use of vaccine, COVID vaccine had to be based on figures, on what the figure is for the day. And we had continuous improvements and introduction of performance-based financing, like I've said. So what are the key lessons? That there is a need for early involvement of other health programs to leverage on existing data to provide more accurate estimates for these priority groups. And there is a pivot in community engagement strategy, emphasizing the importance of influential voices in showcasing flexibility and adaptability that is required in disseminating critical health information to dispel the hesitancies that we saw. And there is a structured approach to monitoring and supervision that ensured robust system of oversight and quality control throughout vaccination campaign. And we also increased participation of the private sector, that had led to diversified approach and many innovations that came in to help deliver the COVID vaccine. And finally, we utilized data to inform most of the decisions that were made for COVID delivery. And these are some of our references. Thank you very much.
Thank you, Dr. Chinyere. So before continuing our sessions, may I ask you to write down in a piece of paper your name, your country name, and one of your favorite hobby. May I ask you this? And put it in front of you, yeah? And I will ask you just to, from time to time, to memorize name of the country, hobbies, faces. So, and then we will have another activity. Yeah. So please. Yeah. Thank you, Doctor. So let's move to the next presentation. I would like to invite Olayinka Badmus. So the presentation title, From Hesitancy to Confidence, Building Trust and Resilience Among Nigerian Healthcare Workers for COVID-19 Vaccination. Please, the floor is yours.
Thank you very much. Good morning, everyone. And I'll be kicking off from where Chinwe stopped. So Disclosure, I'm not a researcher. My doctor is human medicine. I'm a physician, and I'm here to advocate for physicians. Our research work is on building trust and resilience among Nigerian healthcare workers for COVID-19 vaccination. It's no news that there was healthcare workers burnout. Just like 2 weeks ago, I went back to my alma mater to celebrate our 20 years post-medical school, and we chose the topic, how to stay healthy while saving others. We seem to forget that doctors are human beings, nurses are human beings, and there's a whole lot of pressure on them. And this played out more during the COVID-19, the pandemic. Aside from that, again, there's sufficient data in terms of what's causing burnout. A few data in Nigeria is also showing us, there's burnout, there's demotivation, there are issues with, again, depersonalization, and statistics as high as 400 suicide deaths in the US related to physicians' deaths related to suicide. So it's important that as we think through how we go about this, discussing policies that we can take forward when it comes to vaccination, there's a key need to focus on healthcare workers' well-being. So my project is funded by United States Agency for International Development. I'm work under the Johns Hopkins Center for Communication Program, and we're in 30 countries. Our key goal as an organization is to demonstrate the power of communication in what we do, and we use innovative approaches to achieve this. Specifically, just taking up from where Chirin stopped around healthcare workers. They were prioritized, but they didn't take the vaccine in the country. This data is as of July to August 2021. You can see that the primary health facilities, you understand, they even had more compared to the secondary and tertiary. And the private facility, vaccination, they were not even willing to get vaccinated. But we also know healthcare workers were trusted or are still trusted sources of health information. So there was an issue that needed to be addressed. The key issue remained that the requisite knowledge around COVID. Everybody just assumed you're a healthcare worker, you know. This was a novel virus, and that the capacity to say, this is what I know about this virus was missing. And so healthcare workers will rather protect their integrity, their trust, their friendship than tell anyone to take the vaccine. Anything comes new, my siblings will call me, my relatives will call me and ask me, Yinka, can we do this? And that's the way it is. And if I don't have sufficient knowledge, I will never tell you to do it, because that relationship that I built over time is more important than the new thing that is coming out. So as a project, we focused on what? Improving service communication using a multi-component intervention to enhance healthcare workers' knowledge and attitude about COVID vaccine, improve their communication skills to build resilience against pandemic-induced stress, and overall output was how do we increase vaccine acceptance as well as address vaccine hesitancy. To get us started, we looked at available data, both primary and secondary data. As an organization, we are supporting the government of Nigeria to run monthly perception and vaccine acceptability study, which started as early as 2021, was a telephone-based survey that continued. Again, we changed from monthly to quarterly as the COVID-19 pandemic progressed. We did some rapid qualitative assessment. We were targeting PLHIVs and their healthcare workers. And we did some behavior diagnosis, looking at what could motivate healthcare workers. We looked at available secondary data. There were some from, again, mostly data that were specific to Nigeria in coming up with how do we engage healthcare workers better. Our key decision was what? One, healthcare workers as an audience. We take healthcare workers as a channel, do this, but nobody looked at them as an audience, as a human, as putting the human back to what they do. So healthcare workers as an audience before they can become a channel. As she mentioned, you understand, how can you tell someone to do what what you don't believe in. And so in developing our implementation approach, we took what we call a collaborative learning, which is a peer learning participatory approach for healthcare workers. And our goal was to address the forgetting curve. Forgetting curve is the fact that maybe after training, within 1 week, 20% of what you have taught is gone. That's the forgetting curve. And to address this, we were intentional about our implementation approach in building trust. We had 3 key components. One was facility-based training. The second one was virtual coaching via using WhatsApp. And the third was interactive voice response. Our facility-based training was cascade approach. So we had pool of national trainers, and then we now had pool of state trainers. During the state training, we focused on secondary and tertiary health facilities, which were high volume facilities, and they were the ones that had highest resistance to COVID vaccine. And the facilities nominated staff for the training. And so they now went back to their facilities to train within the facility. So it was cascade approach. We had 6 modules. Module 1 was on interpersonal communication, Module 2 on counseling, Module 3, empathy in practice. But the most important module was Module 6, addressing healthcare workers' well-being. We made it Module 6. By the time we started the trainings, they told us that should have been Module 1, because that was the first time somebody was asking them about themselves. Who are you outside being a healthcare worker? Do you even really know yourself? Do you know, again, what gets you? So we were asked to make it Module 1. Immediately after each training, we enrolled all of them into a WhatsApp group. Again, we're engaging with them. We had things, so Motivation Monday will be like a resilient message that helps you to think through, motivates you. Thought-provoking Thursdays where things around, again, COVID, just, again, what are some of the, and then we finished with an interactive voice response. We had received some resilient messages from Johnson & Johnson. They had a very good resilient profile. We sent that over 4 weeks. Just messages, again, focusing on you, not just really only about the disease or the work that you needed to do. So this was our implementation timeline. The facility-based training ran between August and December. September to January was the virtual coaching and then the IVR. The below timeline was our evaluation process. So during each training, we had pre and post test. We did a follow-up survey 3 months after everybody must have completed, just to see. We repeated part of the pre and post test was what we repeated, and then some additional questions. We did online. The way healthcare workers work, you have to reach them via multiple approaches. We had limited data collection during the online follow-up, so we had to do facility visits to get additional data, and then we did individual stories. And so overall, we trained over 2,000, almost 3,000 healthcare workers. 501 of them completed all the 3 elements, and then 221 completed the follow-up survey. So I'm going to present my findings using the Kirkpatrick model: level 1 reaction, level 2 learning, level 3 impact, and level 4 result. So in terms of reaction, what did the healthcare workers tell us? 85% of them stated that the training was insightful and served as a reminder and motivation on self-care for healthcare workers. Some quotes: I never wanted to get vaccinated. I never wanted to talk to anyone about vaccine, but after the training, all my mentality about COVID-19 vaccine was debunked. Nobody told me to get vaccinated. We're able to convert healthcare workers that were not vaccinated at those training to get vaccinated. We made sure we also brought the vaccines to them to get vaccinated. So that's reaction from the two. In terms of learning, between the post-test and follow-up survey, we've seen an increase in knowledge. Okay, so people now understand that when I'm having a conversation with you, looking at your phone is rude, does not communicate that you're following me. So post-test was higher, follow-up survey, you can see it has come down. They were able to define misinformation. One of the key topics modules was around vaccine hesitancy and how they could address it. So understanding what misinformation is grew from 50.5 to 73.3. They understood that you needed to approach hesitant clients, and they approached to do that. That's pivoting, remaining on course with the facts. You don't argue with them, but you set the facts. So they were able to understand that. They now understood that their own negative perception of behavior also translates to the client. So from 8.6 apostles to 30.8, so they understood that their behavior also affects service uptake better. Of course, fatigue. Again, 100% they know that fatigue. So the total mean score across all was, it moved from 6.7 to 7.66. Moving to level 3, I'm not sure. Are we able to play this video? Okay. Yes, we collected consent. Written consent.
I'm originally from Niger Delta, Edo State, to precise. Since 2016, I've been an alcoholic. I drink a lot. I drink a lot. Or drank a lot. Let me bring into perspective. I was in the north at first, so I really wasn't drinking so much. When I came to my town, I got introduced to some guys who just live life very fast. So since 2015, I think 2016, 2015 just started a little. 2016, I was earning 153,000 naira monthly where I was working in my state. And I could get paid today. By tomorrow, I have spent 180,000 naira on drinks in just the space of one night. My friends would say there's blood in the alcohol stream. Like there wasn't anything again because I was just a walking keg of alcohol. So when I started doing more work when I got here and more tension was building up, I needed more alcohol because the tension was getting too much. I needed to calm down. And I didn't know any other way. In the train, people were telling you how I relax. I listen to music, I eat this, I do that, I sleep. They were all saying different things. Like, what is that? How are you not be listening to? Yeah. Funny enough, I think the second day of the train, I went very late. And why I went late was because I was drunk the night before. It was the third day I had to now open up that, see what happened. It was. And really, like I said before, when I left here to Afiko, I bought a lot of drinks. And that was the only intention of my going for the training, just to drink myself to stupor and sleep through the entire days, But after hearing other health workers talk, the facilitators, the participants, hearing everybody talk. And the highlight for me really was the part where we talked about the welfare of health workers, how we ought to take care of ourselves. And everybody started sharing. And that was what set this training out, above and beyond every other that I've been, hearing fellows talk. And I was like, really? The other thing somebody can do and, ease the tension, really. And then I was still mention Dr. Joe again. How he told me, how he was working somewhere, did 5 surgeries one night, how he was, hearing all those stories, I then realized, no, I'm not alone now. I'm not alone. So why should I take this thing so personal? But when I went home that night and I heard everybody after all they've said, I went to the room. I still had a lot of bottles that had not opened. I just opened them, poured them into the drain. And I said, I bet this year, we don't do. We don't do. There's a better way to live life than living off liquor. We don't do. And I just put everything away. And that is the highlight for me of that training. And in fact, the highlight of my year, because I know what it has cost me financially, and I know what it has cost me in my relations. So being in that setting where I had no expectation of anything, and I didn't have any expectation as I didn't go to Breakthrough Action Nigeria training on trust and building empire. I didn't have any expectation. And a problem that I've had that I knew was a problem, but I had given up hope. Like, how do I even fix it? Have I no need? You just drink till you die. Getting to this, to there, and realizing that no, this was not a spiritual encounter. No, it was just people discussing. I just, enough is enough. And yeah, it just did the magic for me.
Okay. Next slide. So that was our impact. It wasn't just about the focusing on the disease, but on the human. Next. Okay, so what were some of the our results? The 551, right? Okay, so what we've seen is, at least amongst the participants themselves, the pre-training, we had 420 already vaccinated, 46 intend to get vaccinated, 6 no intention, not sure. As post-training, these 35 have moved up again immediately after the training. So that's one of our results. Next, okay. When we also look at client-provider interaction, we also saw an increase, okay? In terms of, although this is self-reported data, they now make sure their clients have enough privacy during consultation, during vaccination. They're able to ask their clients if they have any other questions, and then also try to find out how well clients are treated by other staff, and know that, again, it takes a whole, it's not just one person that attends to a client need. And so we saw also a positive deviance in terms of healthcare workers. Okay, so something was missing. Okay, so what are our recommendations? And this training approach featured inside a global document on operational framework for demand promotion. This work featured inside as one of the champions for how to engage healthcare workers. A key recommendation from our learning is we need to understand the motivation and capability of healthcare workers. We need to make sure that we focus on them as an audience, and for them to function better, we need to recognize their motivation and capability. We also recommend combining modalities to improve knowledge retention and perceived self-efficacy, and then using an iterative approach and participatory approach to deliver training for healthcare workers. I'm focusing or pushing the agenda. There should be no healthcare workers training without healthcare workers' well-being, or life skills being passed to them. Most of the healthcare workers work within a very small space. They don't even have time for themselves. So being able to learn other life skills that can also improve them personally and professionally will be great. Yes, some of our resources are available online. This particular training is also available as an online course. Our organizations, Breakthrough Action, SBC, Learning Central. I'd like to acknowledge my co-authors, all the healthcare workers that participated, the government agencies we worked with, and then the implementing partners, and of course, USAID for supporting the grant. Thank you very much.
Thank you so much for this opportunity to showcase our work on COVID-19 vaccination in Cameroon. So we'll be sharing lessons learned from MTAP's logistics management of COVID-19 vaccination in Cameroon. My name is Mba Cleophas Katita. I'm a doctor of veterinary medicine and an MPH, but I'm presenting this work in my capacity as senior operations specialist for USAID's MTAP's program in Cameroon. So this is the team that contributed to this work. This is the outline we'll be following. To introduce, the COVID-19 pandemic emphasized the need for efficient vaccine supply, and Cameroon reported its first case in March 2020, which highlighted the pressing need for action. Generally, low resource settings, including Cameroon, face additional logistic challenges, which often limits vaccination coverage. So we also have infrastructural and managerial challenges when it comes to such interventions. Okay, so the objective of this presentation is to describe MTAP's logistical support during the intervention during the COVID-19 vaccination campaign. And we will go further to describe, first of all, our usual procedures when it comes to large-scale logistics management, after which we'll highlight the procedural adjustments or innovations that we integrated during the intervention, and then we'll present key vaccination outcomes. This intervention involved three main regions of Cameroon. We had the littoral, the center, and the west regions, representing about 43% of the total national vaccination target. Altogether, 76 health districts were involved, and the period was November 2022 during our fifth national vaccination campaign. It is worth noting that these populations have expressed resistance in the past when it comes to COVID-19 vaccination. So the implementation or the intervention involved three main phases. We had a preparatory phase, we had an implementation phase, and an evaluation phase. The preparatory phase was all about market research, sourcing vendors, contracting these vendors, especially for vehicle rental, and also briefing or training stakeholders. We had to brief them on our internal procedures. Then in the implementation phase, a fleet of vehicles had to be mobilized. We had to also establish a real-time communication platform. And we had to, of course, document, because documentation is a very important aspect of procurement. And in the evaluation phase, we did debriefings daily, and we had an evaluation workshop at the end, a national evaluation workshop. So this, to the left, we have our normal procedure, the normal procedure used for large-scale procurements. It begins with the obtention of validation of the activity. Once it is validated, we have to request for quotations from vendors. Now, when it comes to large scale, we are normally supposed to solicit at least 3 quotes. That's 3 vendors involved. And we have to give them a deadline of 5 to 7 days. That is how the procedure is, for them to provide us with quotes, after which we conduct a vendor selection panel. That means we organize a committee that evaluates the quotes received and picks out the best vendor, and then we go ahead to issue a purchase order. However, given the intervention and the pressing need, we had to adjust this procedure. And how did we do it? Immediately, we got the terms of reference for the intervention. We anticipated by conducting the market research and sourcing a vendor. So we did a competitive call for proposal. We obtained the best quotes and sourced and established a So after we got
Okay, thank you for this opportunity. First of all, I would like to say that my English understanding is better than my speaking. Reason why I prefer to shift in French is my mother tongue. I will be more comfortable, and also I will go slowly to give the opportunity to the translator to translate it. Thank you. Merci beaucoup. Voilà un peu notre présentation. Nous allons présenter les résultats de notre étude Ecova en République démocratique du Congo. Ce sont les contributeurs qui ont travaillé dans cette activité. Next slide. D'entrée de jeu, dans la première diapositive. Next slide, please. Ah, OK. Thank you. Ça, c'est un peu le plan de la présentation. Nous allons parler de l'introduction, de la méthodologie, des résultats, et puis nous allons finir par une conclusion. D'entrée de jeu, j'ai attiré l'attention sur les problèmes d'équité dans la couverture vaccinale dans le monde, dans cette première présentation, où on voit le pays occidental avoir des couvertures qui se rapprochent de 100%. Alors qu'en Afrique, il y en a quand même qui sont bons élèves, qui ont des couvertures qui se rapprochent des 50%, alors que nous, on est resté à la traîne, avec une couverture en 2022 qui était d'environ 3%, et actuellement, des 14%, donc 13%. Mais les 13% en réalité, ce n'est pas 13, c'est moins que ça, la couverture vaccinale. C'est parce que ce sont des données hospitalières. Et ces données ne reflètent pas la réalité, tout simplement parce que ce ne sont pas des données d'enquête de couverture. La source de vérification, c'est la carte. Et comme l'un des présentateurs l'a dit, il y a des gens qui obtiennent la carte de vaccination alors qu'ils ne se sont pas fait vacciner. Tout simplement, c'est pour voyager parce que ça facilitait le voyage. En réalité, la couverture, c'est moins de 13%. Couverture réelle. Dans ces slides, malheureusement, ça ne se voit pas bien. Ça résume un peu l'évolution de la vaccination en République démocratique du Congo. Le lancement a été fait au mois d'avril 2021. Et à ce moment-là, on avait 4 vaccins, notamment Pfizer, JJ, Moderna, mais aussi Sinovac. Et parmi eux, c'est JJ qui était le plus préféré parce qu'il y avait une seule dose. Alors que les autres, notamment Pfizer, il y avait problème de conservation, surtout dans le pays chaud, comme chez nous en République du Congo. Mais c'est plutôt au mois d'octobre que la campagne réellement a été lancée. Mois d'octobre 2021 que la campagne a été lancée. Et vous pouvez voir comment est-ce que cette couverture est allée de manière crescendo depuis le début de la campagne. À un certain moment, on a pu faire l'intégration, notamment en 2023. On a préféré partir de la campagne à ce qu'on appelle la routinisation. On a rendu la vaccination routinière. Et cette intégration de la vaccination COVID en RDC dans la routine, parce qu'il y a un programme élargi de vaccination, a commencé cette année au mois d'avril 2024. Mais selon toujours les données de l'OMS, nous pouvons voir que dans les différentes provinces, parce que le pays a 26 provinces, la répartition de la couverture diffère d'une province à l'autre. Il y a des provinces qui ont des couvertures plus larges, alors que d'autres en ont des couvertures vraiment très, très basses. Ça, c'était juste pour donner la topographie de la vaccination en RDC. Et dans le cadre de cette étude, c'était les 4 objectifs qui étaient poursuivis, et parmi lesquels décrire les schémas d'accès à l'utilisation de la COVID en RDC, décrire les niveaux des réticences à l'égard de la vaccination RDC, décrire le mécanisme de distribution de la vaccination en RDC. Et pour cela, nous avons utilisé 2 méthodes comme dans le projet, les scoping review, et nous avons fait la partie qualitative. Dans les scoping review, nous avons utilisé la méthode Darcy et Mollet. 3 bases de données ont été utilisées, PubMed, Procast et Scopus Data. Et 2 chercheurs, moi et un collègue, nous avons fait cette partie de scoping review. Et il y a une partie qualitative où nous avons obtenu pour l'étude en général l'autorisation du comité d'éthique, mais nous avons fait face à un autre problème, Dany et autres le savent, c'est la deuxième institution, l'Institut national de santé publique, qui exigeait qu'au-delà de l'autorisation du comité d'éthique, on devrait aussi avoir leur enregistrement. Ce qui a retardé un peu le début de la collecte et donné un peu le retard qu'on a connu. 23 informateurs clés ont été identifiés, on a échangé avec eux, et ce sont des gens qui sont impliqués dans la vaccination COVID dans le pays. Et bon nombre d'entre eux, comme on verra, ils sont plus au niveau de la pyramide sanitaire parce qu'au pays, nous avons 3 niveaux de structures sanitaires, niveau central, intermédiaire et niveau opérationnel, où on a des établissements de soins de santé. Et les informateurs clés sont venus de ces 3 niveaux de la pyramide sanitaire. Les entretiens ont été enregistrés, transcrits, et nous avons utilisé Atlas TI 21 pour les analyses des données, et l'analyse a été faite de manière que de cette recherche. En termes de scoping, au début, nous avons eu 340 articles sur lesquels il y avait 255 doublons. On les a effacés. Nous sommes restés avec 175 et nous avons utilisé le résumé et les titres pour la sélection sur lesquels 15 avaient retenu notre attention, avaient rempli les critères. Et sur les 15, nous avons alors téléchargé tous les articles dans leur entièreté et nous avons passé en revue ces articles. Et sur les 15, il n'y a eu que 6 qui ont été retenus dans cette étude. Donc, le résumé que je veux faire, c'est le résumé des 6 articles. Et ces articles qui ont été publiés, sur les 6, 4, la population d'études, c'était des personnels de santé. Il n'y a eu qu'une seule étude qui parlait de la population en général, et l'autre, c'était des parents, pour voir un peu leur intention de se faire vacciner. Et parmi l'intention de se faire vacciner, le nombre de personnes qui voulaient se faire vacciner, ça variait entre 28 et 55%. Les gens qui voulaient se faire vacciner. Bien que leur intention de se faire vacciner était là, mais on a vu que moins de 13% se sont fait vacciner. Et pourquoi alors ces gens-là ne voulaient pas se faire vacciner? Parmi les raisons de la non-vaccination, nous avons retrouvé en premier lieu la peur des effets secondaires du vaccin. Deuxièmement, c'était le fait que les gens n'avaient pas confiance au vaccin parce que c'était nouveau, mais aussi d'autres avaient pensé, comme les autres avaient dit ici, que le vaccin était prévu pour tuer les Africains et stériliser les gens, surtout les femmes et les enfants. Et ils ne voulaient pas alors se faire vacciner à cause de tous ces effets. Et dans la partie qualitative, parce qu'il y a des données où nous avons mélangé, là où ça parle de même point, la partie qualitative et la partie de scoping. Dans la partie qualitative, nous avons pu ressortir 3 points essentiels. C'était des rumeurs qui étaient diffusées sur les réseaux sociaux. Ces rumeurs étaient dues au fait que, il y avait un Congolais qui est venu de la Belgique, il est arrivé à Kinshasa, il est allé se faire vacciner et 2 jours après, la personne est décédée. C'était déjà un problème. On s'est dit, oh, quelqu'un qui paye son argent pour aller se faire vacciner, il meurt. Donc, ce vaccin tue. Ensuite, l'autre rumeur, c'était que l'un des personnes les plus importantes du pays, notamment le prof Muyembe, qui était à la tête des task force, a dit, nous, on va commencer la vaccination. Et les gens ont dit, c'est que le blanc lui a donné l'argent pour participer à éliminer les Congolais. Et ces deux raisons ont fait en sorte que des rumeurs se sont propagées et les gens avaient des hésitations à se faire vacciner. Et cela a entraîné la peur, mais il y a aussi autre chose, c'était certaines religions n'aiment pas ou certaines religions refusent de se faire vacciner. Tout le vaccin dans l'ensemble. Et quand Covid arrive, ça entre dans le lot de vaccins où on refuse automatiquement. Ici, je mets en évidence certaines idées qui sont ressorties de l'analyse de la partie qualitative qui montrent que les gens avaient peur et que cette peur-là était diffusée dans le média. Mais aussi la croyance des religieux, des personnes de certaines religions comme Kita-Walistes qui n'acceptent pas la vaccination. Mais malgré cela, il y a quand même des gens qui se sont fait vacciner. Excuse me. Next slide, is that some work? Et il y a quand même des gens qui se sont fait vacciner. Et quelles sont les raisons de la vaccination? Parmi ceux qui se sont fait vacciner, vous remarquerez que Machako a mis en évidence le fait d'avoir une bonne connaissance sur la vaccination et des groupes prioritaires, à favoriser, à motiver plus de gens à se faire vacciner. La peur que la COVID-19 puisse atteindre un membre de la famille qui est dans les groupes prioritaires, ça a motivé les gens à se faire vacciner. Il y avait aussi un niveau élevé ou alors une connaissance élevée sur la vaccination qui a aidé. Et sans oublier l'histoire de ceux qui se sont fait tester COVID pendant la pandémie. Alors, ce sont ces gens-là qui étaient plus motivés parce qu'eux croyaient à l'existence de la maladie, ils étaient plus motivés à se faire vacciner. Et cette hésitance, cette réticence à se faire vacciner, rappelez-vous que sur 6 articles, il y a 4 qui parlent des personnels médicaux. Or, les populations prioritaires, c'était le personnel médical, les gens âgés de plus de 55 ans et les gens avec comorbidité. Alors, si le personnel médical, lui qui doit donner l'exemple, et se faire vacciner, a fortiori, la population, quand est-ce que moi j'irai me faire vacciner alors que celui qui me soigne refuse de se faire vacciner? Mais dans la partie qualitative, nous avons ressorti aussi certains éléments qui ont encouragé les personnes à se faire vacciner, notamment le fait que le président de la République, pour aider à la vaccination, c'est aussi des survivants de la COVID, la sensibilisation. Sanitaire. Et nous rappelons ici que dans le pays, il y a un programme élargi de vaccination qui s'occupe de la vaccination non seulement de la COVID, mais des autres antigènes au pays, et souvent soutenu par la Fondation Gates, ce qui fait en sorte que, en termes de mécanismes en place pour la vaccination, elle est déjà bien établie et même le mécanisme de distribution et d'acquisition du vaccin COVID a suivi exactement le même schéma classique de la vaccination, où nous avons d'un côté l'acquisition. Pendant la campagne, le vaccin venait en grande partie des dons, notamment des COVAX, Banque mondiale, des Gavi et de l'OMS. Mais la campagne a pris fin, vu que la pandémie est partie. Mais maintenant, nous sommes entrés dans la routinisation. Et dans la routine, c'est plus l'UNICEF, le gouvernement et Gavi qui aident dans l'acquisition des vaccins. Et ces vaccins, dès qu'ils sont reçus au pays, ils sont tous stockés, tous les vaccins, y compris COVID, au niveau du PEV central qui se trouve à Kinkole. Il y a suffisamment de matériel pour conserver. Ils sont gardés là. Et c'est de là maintenant de manière semestrielle, après 6 mois, que ce vaccin doit maintenant être distribué d'abord au niveau provincial, parce qu'on a 26 provinces. Et dans le pays, nous avons au total 44 programmes antennes du programme élargi de vaccination. Et on le fait quitter de Kinshasa jusque dans les différentes antennes au pays, dans le 26 provinces. Une fois arrivé au pays, dans des provinces, maintenant, chaque antenne a sous sa responsabilité ce qu'on appelle le bureau central, les zones de santé. Doivent maintenant distribuer ces vaccins des zones de santé, de l'antenne vers les zones de santé. Et ça se fait souvent de manière trimestrielle. Et une fois que ça arrive au niveau des zones de santé, les zones de santé, à leur tour, doivent maintenant envoyer ça au niveau des établissements de soins qui administrent ou des sites de vaccination qui administrent la vaccination. Et ça, ce sont des codes qui décrivent ce schéma de distribution de la vaccination où tout passe par le programme élargi de vaccination à Kinshasa pour atteindre les différentes antennes au niveau des provinces, des antennes du bureau central et des bureaux centrales vers les établissements de soins. Please, next slide. OK. Alors, quels sont les défis qu'on a pu observer dans l'acquisition, distribution et administration de vaccins COVID? 3 principalement. Le premier, c'est la disponibilité des vaccins. Les vaccins n'étaient pas souvent disponibles à cause des ruptures de stock ou soit à cause des péremptions rapides de ces vaccins. Deuxième difficulté, c'était la chaîne de froid. Ces vaccins doivent être conservés. On n'a pas suffisamment de matériel de conservation avec un problème d'accès à l'électricité. Troisième difficulté, c'est le transport. Ça doit quitter de Kinshasa vers les provinces, des provinces bureau central établissement des soins. On doit utiliser les avions, on doit utiliser le moto, les bateaux et autres. C'était un autre problème, un troisième problème qui a été mis en évidence. D'un autre côté, nous avons parlé de partenariats publics et privés. Nous avons pu se rendre compte que bon nombre d'hôpitaux et d'établissements de soins qui peuvent aider à la vaccination COVID ne sont pas intégrés parce que ce sont des structures privées. La vaccination, ce vaccin n'est amené que dans des structures publiques. Et ces structures publiques, ce n'est pas tout le monde qui y va. Il y a des gens qui ont un peu de moyens, qui préfèrent se rendre dans des hôpitaux privés. Et ces personnes par la vaccination. Et par structure d'établissement de soins, atteindre ces personnes qui sont exclues. Next slide. Alors, ça ici, nous avons résumé les différentes approches qu'on peut utiliser pour pouvoir améliorer cette distribution, notamment les informateurs qui ont souligné le fait que nous devons accompagner la routinisation de la vaccination. Donc, le gouvernement devrait faire sortir de l'argent pour payer des vaccins, mais aussi leur déploiement. Donc, problème lié notamment à l'électricité. Le soleil est là, on peut utiliser les qui fonctionnent avec des panneaux solaires dans la chaîne de froid. Et en ce qui concerne les technologies comme les dons, des propositions qui sont sorties des entretiens. Pour conclure, next slide. OK. Donc, nous avons pu voir les différents défis auxquels on fait face, notamment les différentes raisons de résistance à la vaccination. Et au-delà de cela, nous avons pu voir les défis dans la chaîne de distribution de vaccins. Et il y a plusieurs chemins sur lesquels nous pouvons utiliser pour améliorer l'accès à la couverture vaccinale, mais aussi au déplacement ou alors à l'administration de ces vaccins en jouant sur la disponibilité du vaccin, parce que si c'est produit localement, ça aiderait, ou un pays proche, par les déficits de la chaîne de froid, mais aussi par la couverture en électricité. Je dis et je vous remercie.
Thank you. Who knows Clarice from Cameroon? Who? 1, 2, 3, 4. 4. So who's Clarice? Yeah, do you know her hobbies? Hiking. What's your hobby? What's your name? From Uganda. Okay. Who shares the same hobby, swimming? Wow. Yeah. So the last but not least, John from Botswana. So the title of the presentation, Equitable Access to COVID-19 Vaccines in Botswana, Barriers and Mitigating Factors.
Good morning, colleagues. So this is much similar to the presentation that we just heard from DRC. It's part of the Ecova project. So yes, I'm John. I'm also John Say. From Botswana. I am based at the University of Botswana. And I did this work with some of my colleagues at the university. Okay. Yeah. All right. Next slide, please. So these, we are presenting two studies that we did, one as a scoping review and the other one as a qualitative study, much similar to what was done. Next slide. Point. Yeah. Anyway, it's a way of background while we are dealing with that issue. Botswana is quite a small country. It's quite a small country in terms of population. So when we are talking, we'll be talking about 2 million people. It's currently 2.5 million. So that would have been the target, you know, for COVID vaccines. So despite, you know, introducing all these non-pharmacological preventive measures quite early on in the pandemic,
the health system was quite overwhelmed by those 2 million people. It basically almost collapsed with the number of cases of COVID-19. So we got our first vaccines round about March 2021, and they were basically, the first batches were donations, and then, you know, later on we were able to purchase. I think like any other African country, our worry is that we could not get access to these vaccines because of this, you know, world market issues, right? Where it was said there's not enough for African countries. So while we did, about a year later, we then had at least distributed about 6.4 million doses. Remember that, you know, one person gets several doses, so that's why it would be more than what we expect for that population. The next slide, please. Or should I? Okay. So we here wanted to have a look at the local data in terms of the distribution, the delivery of the vaccines, and you know, we also considered issues of acceptance, uptake, and all that, as you will see in the objectives. But you know, it was quite difficult because for one reason or the other, we were not getting sufficient data regarding vaccines within the country. Sufficient data meaning we are talking about either published data or publicly accessible data, that it was kind of difficult to get for one reason or the other. That is the challenge, you know, for both of these studies that we'll talk about. Okay, next slide, please. Yeah, so the scoping review had mainly the two objectives that were to explore the barriers to vaccine access, and what could be done to improve timely and equitable distribution, especially to vulnerable groups. The second one was to have a look at the levels of vaccine hesitancy and uptake. And then the qualitative review, we looked at the distribution and delivery processes related, and the related barriers, and then the role of different organizations, including the civil society, non-governmental, governmental, in the distribution and delivery of vaccines. So we will look at the results or the methods, first of the scoping review, then the qualitative, and then the results of the scoping review and qualitative in that order. Next slide, please. So the scoping review, after looking at all these databases, Medline, Signal, Web of Science, you know, we could only come up with about 550 articles. And the other articles that were really useful to us were actually gray literature that we got from government offices, WHO. So this is the challenge that I spoke about earlier, that, you know, the difficulty in finding data published, especially related to COVID vaccines in for the country. What you could get actually is things like newspaper articles that show, you know, the president was immunized somewhere and showing him getting the injection and things like that. And what other organizations were doing, they would actually put it up either in their websites or a journalist would write that up. But, you know, for purposes of scoping review, we could not really include those because we have to show, you know, the scientific part of it. I think that's then a limitation, because had we considered that, you know, we would get data from all these various sources, we could have found a way of including that in our report. So anyway, at the end of it, we had to look at 9 articles. 5, I think, were the published, and then 4 from that's the gray literature. And a narrative synthesis was done to collect, synthesize, and map that literature. Next slide. For the qualitative aspect, we interviewed face-to-face interviews for about 18 key informants who were mainly people involved in COVID vaccine delivery, distribution from all sectors. I just wanted to list some of them. Okay, from all sectors. So public health officials, from regulatory bodies, from CSOs, you know, and covering some areas related to vaccine delivery and distribution, such as, you know, surveillance and I think I'll mention the rest of the stakeholders as we go on. And they were based in the capital city. We audio recorded, transcribed, and then analyzed that data for recurring patterns. Next slide, please. So the data collection was between May and August, which was not the intention. Again, as a challenge, it was difficult to secure interviews with these individuals based on their you know, work in government, and you know, people did not really want to come out about COVID vaccines for one reason or the other, as we said. So that's, you know, we took longer than expected. Some interviews lasted 30 minutes, while others lasted up to 90 minutes, depending on what the participant felt like giving out or not giving out. But at the end of the day, we got sufficient data to analyze on this. Right, the next slide, please. So from the review, as we said, the data that we got was categorized into these 3 main categories, I would call them. So patterns in access and uptake, barriers to access and uptake, and then what is needed to improve these barriers for disadvantaged and vulnerable population. Next slide. So we'll quickly run through what we found in those. So in terms of patterns of access and uptake, we spoke a little bit about where we got the vaccines from, and the first batches were from China. Were donated by India, and then we ended up you know, getting some from China. I think it was Sinovac. And so we prioritized the 55-year-olds and above, as well as healthcare workers and those with comorbidities as the first group. So we kind of phased out the vaccine rollout. The second phase was then those 30 years of age and above, so between 30 and 55. And then the third phase would go down 18 and 30. And then the fourth phase were the children. So the delivery of vaccines was through the health facilities. That's really the COVID vaccine distribution and delivery took the form of the usual immunizations that we give out in the country, the childhood immunization. So it kind of rode on the extended program on immunization, that's the EPI, and used all its structures. So the additional facilities that were used would probably include, visit to schools and to farms as outreach, which may not usually be the case. And you see, by December, we had vaccinated about 80% of the target, which was initially 1.3. See, 1.3 out of 2 million, and we had gone to about 80% in the same year of 2021. It was not a bad achievement, though it could be much better. Next slide. In terms of the barriers, according to the literature that we had, the acceptance rate was about, yes. Oh, okay. All right, I'll go a little faster. Okay, so I have 5 minutes. So we had an acceptance rate of about a rate of about 73.4%. And yeah, let's go to the next slide. We didn't have much in terms of hesitancy. There were no studies on hesitancy that we came across. So the other issues relate mainly to the EPI, which always delivers vaccines. So structural issues, cold chain problems, inadequate healthcare workers, just the vaccine management issues where they're out of stock, that sort of problems that affect the normal delivery. And then the weak surveillance system. Next slide, please. Now we will have to fly a little bit. Okay, all right. So let's go to the next one where we talk about the next one again. Next one, please. Yes, where we talk about the qualitative, the median age of the participants, 47 years old, half male, half females, and they had master's degrees. So these were people of high positions in government and non-governmental organizations. Next. So some of the themes that came out related to, roles and in the distribution of vaccines, which related to, who is to do what when you have so many stakeholders that you could use as government. And some of the stakeholders felt they were not so engaged at the beginning. And so there were those clashes of roles. But anyway, the private sector, the CSOs had a lot to do and they played a critical part. The mechanisms of delivery, the demand creation strategies, the social and cultural influences on uptake were a little bit there, issues of gender and vulnerable populations, and then stakeholder engagement practices, and then the public-private partnerships that were useful. So these were the main themes that we focused on, or that came out of the data. We can go to the last but one on recommendations. Again. Okay, from here. So the main recommendations relate to strengthening that collaboration between government and other sectors, because we realize that actually get a lot of help from the CSOs and the private sector in terms of logistics, transport and cold chain for vaccines and for healthcare workers. The other thing was to engage local leaders and influencers at the local level in terms of breaking these cultural barriers to vaccine uptake. The next one was to include issues of vulnerable populations like the disabled, who we talked to and felt they were excluded. Similarly, to look at issues of gender because they were not particularly raised as issues in the distribution of vaccines. And then capacity building, to improve the logistics, of course, the infrastructure. Next slide. The other thing that we recommended was to do with research, and we said we don't have articles on hesitancy of and how people uptake vaccines in general. We need that sort of research. We also need research towards developing our own vaccines locally. The other thing was to talk about monitoring and evaluation, since whatever resistance to vaccines or hesitance was related to the side effects. So concerns with side effects, so that, as people go along delivering vaccine, they can quickly pick out this and address them as they come. I think that would be the end. The 5 minutes is gone. Thank you so much.
Thank you, thank you. Thank you, John. What's your hobby?
Hobby. Yeah, I'm a teacher too.
Flying. I know that you fly, but other than flying.
No, actually, I wanted to say I'm a teacher too, and so that's why I talk so slow and I end up over-explaining to students. So that's a hobby, teaching, but I do like visiting new places. I still enjoy that. That's all.
So, who knows Nyacha from Zimbabwe? Just Jane? Oh my God, no. 1, 2, 3. Okay, so Nyacha is here, is there. So I know one of his hobbies, but I don't know the other. But let me share with you one of his hobbies is to accompany his wife for shopping. Wow. but let me, yeah, but let me ask him just to confirm with him. So Nyacha, please. Sorry? Your hobby. Your hobby. Yeah, that's good. So let's move to the. So I will invite Cecilia, Olayinka, Cleophas, Janez, and John. Please share. Danny, can you put that? The cardboard. And I will share Okay, so let's be serious now. So thank you very much, dear colleagues, for your presentation. I can see, and we are like saying, let's say the same, or having the same results as yesterday. So acceptance rate, access to the vaccine, I mean equitable access, hesitancy, manufacturing of vaccine in Africa, and so on. So before open the floor to the other colleague for the questions, I would like to ask each one of you 2 questions. Please briefly respond to my questions. The first, if you want to write a policy paper, yeah? So to whom you address this paper, and what would be the content considering your research? Yeah, so you have a lot of interesting results. You say a lot of recommendation, but choose one, just one, okay? And the second questions, so you talked a lot about the vaccine manufacturing in Africa, yeah? And each country is saying, I would love to manufacture vaccine in my country. So I don't think it's feasible, yeah? So if you wanna talk about this, how do you see this? Where, how, what's your thought about this, this issue? No, it's not an issue, about this, let's say, this results from your research. Okay, so maybe who would like to start? Who's ready? John, are you ready?
Yes, I can start.
So please.
Okay. Okay, thank you. Thank you very much for the question. So the first question about what would be the main recommendation to a policymaker, and I'm thinking, you know, in this case, policymaker from my country would be somebody in the Ministry of Health, has, you know, most of the power. And for me now, it is the Secretary of Primary Health Care. Really, my recommendation is to establish a system within the current EPI program that deals with you know, if emergency vaccines or vaccines in pandemics. So in that way, when you have a system already established, you know who the stakeholders are. So when this happens, a pandemic happens, you need to procure vaccines. You know the stakeholders, you know the channels that the vaccines take to be delivered, and we keep on building and improving on those on that particular system if it's in place. The next one about manufacturing, yes, I agree. We had a promise. Somebody said they would come and manufacture in our country. In fact, they set up a factory. We actually produce vaccines, but for animals. So the Botswana Vaccine Institute. And the idea was, since you already produce vaccines and you sell them to most of Southern Africa, we could, leverage on this and then, move it to human. But it didn't go through. I know human issues are much different. And then the investor also, left the country. But I think it's about coming together and making it a regional, manufacturing hub instead of a local, country thing. So, for instance, SADC, ECOWAS. I think that would make more sense in this case. Thank you.
Yeah, thank you, John. So, Dr. Chinian.
Okay. Thank you for the questions. I would like to address my policymakers through a policy brief, and I'll concentrate on the need for adequate engagement of all stakeholders before we embark on any national implementation with regards to health, especially those at the grassroots, the frontline health workers, those at the grassroots local governments who are usually not carried along when such decisions are made at the national level here in Abuja. So I would also like them to strengthen the collection of disaggregated data now, and not when the need arises. We keep running health asceta as we did the last time. So this is the time to start collecting disaggregated subgroup data for Nigeria as a whole. And then with regards to manufacturing of vaccine in Africa, I would, like he said, collaboration is key. I would prefer some countries, let's say those in East Africa or those in West Africa, they could come together, form a hub, and at least start from there and get the expertise that are needed, invite them from the current South countries that are manufacturing for now, and then take it up from there. Later, other branches in other countries can as well be opened up. Thank you.
Thank you, Dr. Shinyera. Yeah, so please.
Okay, thank you. First of all, I think that the person to whom the recommendation can be laid first is the president, because he's the only one who leads the decision and so on in the country, especially in my country. Secondly, it will be the Minister of Public Health. That's public health because he carry out the decision from the president. And lastly, I think to go ahead, it will be the parliament. Those can decide some laws that can allow to reach the decision come from the president and even to support the Minister of Public Health. About manufacturing, I don't think that my country is able to now to produce it locally, but we can produce in the South African country or in north of country, but it will be easier to bring it in my country rather than to have it from in Europe or American and so on. And if it's produced locally in Africa, African population will be the first population target population that can benefit on it, not only waiting for if the vaccine will be expired. In that case, we can send it to African. That's because we have the problem with the channel of distribution and supply. This also will take the time. If the vaccine have enough time, is way of expirations that can be used safely until to be used in the establishments, the workplace. And also about the recommendation is that to improve the confidence in vaccine in population and a good communication plan of communication, not only during the outbreak, but also out of the outbreak. That's the problem. If we are just to wait for the outbreak to strengthen the confidence in vaccination, most of the time the population is seeing something behind this. Okay, and also to improve the transportation of those vaccines from Kinshasa to others province, and especially to the establishment where they use this vaccine. Thank you.
Okay, so if I were to prepare or propose a policy brief today, first I would address it to the Prime Ministry and the Presidency. And the content would be One Health advocacy, because the error many people commit today is that they feel One Health, when we talk about One Health, it's human health, animal health, and they forget about the others. They forget about the community. They forget about civil society. So my policy brief would bring out the need to involve the civil society in decision-making, from planification to implementation to reporting to evaluation. Because like we see, there's a lot of vaccine hesitancy because there is very little community engagement in these activities. So if we engage them from the very beginning through a One Health intervention, I think it's going to increase acceptancy. Regarding the second question on vaccine manufacturing, it's true that in Africa, I think I'll speak for Cameroon, generally things that come from elsewhere are considered by many to be better. We think that exotic things are things they are more expensive. It means they are good, they are better than what we do, we prepare at home. But I think preparing or manufacturing vaccines, homemade vaccines would be easily accepted, because people will not feel like, because one of the myths that came during the COVID vaccination was that it's the white man's thing and that they want to try it on us. They want to see if it works on us, then they can use it. But if we produce it here as our own thing, then it would be accepted more. And I also think for now, if we don't yet have the means to do that, we can start somewhere. We can start by maybe investing in trainings, training our personnel, or I don't know, maybe funding anything that has to do with training for vaccine production. And then after the training, we start looking at maybe coming together, like someone has mentioned, countries coming together to manufacture different vaccines with regards to the needs that are in place. That is not only going to increase acceptancy, but it also, it's increased employment for our fellow Africans. That's what I think. Thank you.
Thank you. So if I'm going to make a policy brief, it will be to the Coordinating Minister of Health for Nigeria, and letting him know the alignment with the President's goal to train 120,000 healthcare workers. So there's a plan and how focusing on healthcare workers well-being in terms of understanding that they need to stay alive to be able to save a life. So again, that kind of campaign on stay alive to save a life, and positioning it in a way that shows alignment to what the government had already planned and how it would be an easy fit in the existing plans, just saying, oh, maybe a module on this added to what needs to happen. Because when we look at our health indices and then we keep on saying quality of care is poor, and then you expect healthcare workers to provide patient-centered care and they themselves don't even have the system that supports their own care. So that would be how I would tailor my policy brief. I also agree with her on One Health, because I also work on One Health. That, again, coming together to address issues collectively. When it comes to manufacturing, also in alignment with most of our colleagues' thoughts, it should be a collaborative process, and every, like we said, maybe regional, and every country contributes to it. So again, equal share so that there is equal ownership of the product that comes out. So it will require some level of consensus building in terms of which part of Africa, or which part, within the maybe like West Africa, which country it stays in, what are you bringing on board? But there should be some criteria. So something like, again, electricity raise or something that is easier to pivot from. So there should be some selection criteria in terms of where it needs to be domiciled, and then it needs to have equality across board. Everybody contributes same amount, same resources, and then employment across the different countries. Thank you.
Yeah, thank you. Thank you very much. Please applaud our colleague for. Yeah, maybe for the time constraint, we will have 3 or 4 questions. Do you have any questions? Yes, please. Please.
You have mics? Okay, the one in front of you.
Yeah, thank you very much. I would like to just ask maybe every person on the panel to maybe help us reflect on who should be the community leader influencing behavior. Should it be community, should it be religious leaders or chiefs and all the other influencers, or should it be healthcare workers or scientists? I ask this because one of the main objectives, if not the second objective of this workshop, is to make us advocates for, to roll back vaccine hesitancy. Thank you.
Thank you. So do you address your question to any specific researcher?
Not to all, to all.
To all.
Yeah.
Yeah.
I think we should take all the questions.
Yes, please.
Okay. I'm thinking maybe we take all the questions and then we pick on what.
Can like speak to the other colleagues and the.
Okay, so she was asking who should we focus on when it comes to community leaders that can influence behavior? Is it healthcare workers? Is it community religious leaders, healthcare workers, or scientists? Because one of the key objectives for this conference was how do we address vaccine hesitancy? And then, so who should be like a community influencer? My response would be it would differ. If you call me as a person and then you tell me it's the religious leader that needs to advocate to me, you can't win me. If you say you're going to promote the information on TV, I don't watch TV. So everybody differs. Think religious leader will continue, and religious leader, the emirs would work. Communication is not one cap fits to be data driven. So you do your research, you find out what's happening, what's the reason for hesitancy, what are the key barriers in those, again, your specific area. But one cap can never fit all. One form of communication can never fit all. One person can never reach all. So we just need to contextualize. It's more expensive, it's more difficult. We like to do same thing everywhere, but it never works. And we will not achieve much if we continue to use one approach. Your communication needs to be adaptable to context, to community, to reality. Key issue also is the fact that communication does not happen in silo. There's also a need to make sure that when you're communicating, you're looking at the social determinants of health. So you're coming in, bringing me vaccine. I've not seen water in my area for months, for years. I wouldn't listen to you. So again, when we're advocating, we need to understand the contextual issues and adapt our communication to context. It can never be only I personally, I'm tired of people always saying the religious leader. You could see that young man might be the most influential person. He will walk his village and you will get what you need. It's to, again, contextualize.
Okay, so maybe just to add to what she has said, from the presentations we've had so far from different countries, we realized for Nigeria, for example, they mentioned religious leaders as enablers. And on the other hand, they said religion was also a barrier. I'm assuming that within a country, we can use different people based on the audience. For example, where religion was a barrier, we would not use religious leaders. And where we saw that religious leaders were helpful, we are going to use them as enablers. So I think she's from Cameroon. I think even within the context of Cameroon, we have areas where religious leaders would tell them they would preach against vaccination, but we have areas where they would rather help. So I think it's really all about the audience. If we see that in schools, for example, we can use scientists, then we are going to use scientists in that case. If we see that elsewhere, community leaders, influencers, especially the youths, they're always on TikTok and social media, we know that they listen to this particular champion or star, we use that person in that case. So it's really about targeting the audience and picking them with respect to that.
Thank you. In my side, I think that the problem is holistic. It's not just one category of a community that can help to improve or to reduce COVID-19 hesitancy. The leaders community could help. Even though the religious leaders can help, everyone can do something to reduce this one. And we have just to contextualize the place and also the problem we face in this kind of country, or if kind of part of the country. That will help everyone, and also to improve the knowledge of about COVID-19, and also the fact that COVID-19 vaccination is true, is safe, that can also help to reduce this.
Okay, just to re-echo what they've said, that we use different influencers for different groups. So for the youths in Nigeria, like during the storm, in the universities, the campaigns, they went with celebrities, the musicians. They are playing their songs and they were present, and people are coming out in masses to take up the vaccine. So that worked for that group. Then if you want to target like the women, we could use the governors' wives forums. So the wives of the governors and all the female politicians, when they come out and gather, and they don't just come out for the sake of coming out, they go with gifts, you know. Whenever you invite such people, you have things that are being given out in return, and all those are also attracting people to them. So you, like she said, check your crowd and know what works for them. Thank you.
Okay, thank you. I'll just agree with my colleagues. I mean, that's the stand I take. I think they have said it 100%. I think what I can add is that for me, I prefer existing systems in place. So, for instance, in a village or in a district, there will be committees where there are all these different leaders, whether government, the traditional leader, so there's a representation of everyone. So I think, go and expand from those committees and fit the current situation. But if you have those committees in existence already, things become much easier for you. Thank you.
Yes, thank you. Jane, do you have any question?
Yeah. Okay, thank you. Thank you. My question is to Botswana presenter. We are neighbors. And we sometimes compete on who has the best beef. So, and he didn't bring biltong, so I have to say something. I know you were talking about, if I heard you right, you talked about there was no vaccine hesitance in Botswana, and there was also an issue of, I think your population, you said it's 2.5, but I know that there is also a lot of migrants in Botswana, and being Zimbabwean, I can safely say maybe another 2.5 is Zimbabwean, and that makes your population about 5 million. But did that have an effect when you talk about vaccine hesitance, but also uptake, and how did you manage those issues? Thank you, and over.
Thank you. Please, John.
I'm sorry, I didn't get the first question. The second one was about migrants in relation to the vaccine rollout, where the target was 1 point something, but based on 2.5, which is the official population. Yes, so being that the vaccines were scarce and it was difficult to access them in the beginning, they were said to be expensive. I think initially we went out to vaccinate only citizens, so you would have to come and show your papers. You actually had to be a citizen. Even if you were there legally, the advice was please go to your country and maybe you can get it that side. But as we started getting more and more vaccines, and because we do realize this, it's similar to HIV, TB treatment, where we say it doesn't help for you to focus on a few people who you say are citizens, where we know they live with others who are not. And so that infection will keep going on and on unless you treat everybody the same. So we have done that for HIV. We have been doing it for TB. So with COVID, I think later on, as we had enough vaccines, that's when we now included everyone, including the migrants. But still, sometimes it's up to the healthcare worker. You go to a facility, you don't have an ID, you don't have any document, they can decide to call the police or to help you. And most of the time, the stance our healthcare workers has taken is that, no, we do our best, we help you, unless there's some criminal offense going on, we do not need to call anybody. So we help as much as we can and let them go. The first question, okay. Okay, thank you.
Okay, thank you. Another questions, maybe the last questions, please, Emmanuel.
Yes, thank you, the presenters, for your questions, for your presentations and insights. I am talking to the Nigerian researchers. In your interaction with the stakeholders when you were doing your study, did anyone complain about how the Nigerian government officials, as it were, contributed to the hesitancy we noticed when the COVID-19 vaccines came? I'm just asking again because some pronouncements at the initial time, for me personally, was anti-people. And so the people reacted against the vaccine proposition. But I want to know whether you elicited such information during your data collection. Thank you very much.
Thank you. Wants to start? Doctor, yeah, please.
Okay, we came across lack of trust in any government issue. Not necessarily what they said or didn't say, but the general attitude of the government to the people. So when they came and said they were introducing this, the first instance was that barrier. People said no, they were suspicious of the agenda of the government towards bringing this free product that is scarce elsewhere? Why are they forcing it down on us? So during the interviews, we saw most of them saying they want to use us as guinea pigs, as experimental animals. That was why there was the initial high hesitancy and then the complete lack of trust in any government initiated interventions or implementations in the country. It was stuck clear in our own intervention. Thank you, sir.
Same thing here, lack of trust in government at all levels. Again, even from, some people visited treatment centers that were empty. So there were so many things that, there's general lack of trust in government. Even if they saw the government official take the vaccine on TV, most people still didn't believe that those vaccines were actually taken. For someone like us, because we're running a nationwide campaign, when doing our campaign, we never mentioned government. Because again, there was another insight that was done by Johnson & Johnson Global Public Health, and they said they wanted to hear directly from doctors, from nurses, WHO. They didn't want to hear from government officials, or they didn't want to hear from celebrities. So that guided how we communicated. Every material we developed did not have, this is from government of Nigeria. It was a real turn off. So it was important that we keep on listening to what data is telling us and use that to make informed decision.
Yeah, thank you. Maybe we are running out of time. We can go to the break. We can have one other. Okay, one more question. Yes, please, James. Please, can you speak to the micro just to hear your question?
Yeah. You say your population was 2 million, but you brought in 6 million vaccine. And even 2 million, 18 class will be lower. So I thought you may be bringing too many vaccines that may not be used.
Thanks. So, as you know, with COVID, people would get, so one person would have so many vaccines and boosters on top of that. So the population is 2.5, and the vaccine doses that we had at that time was 6.4 million. So it's because, yes, one person gets more than one, and then others, get, I don't know, lost and wasted and all sorts of issues. But there was an issue there where there was quite some wastage. I think that's why we are saying we didn't have things written out and published on our vaccines and the management of vaccines per se. But yes, there was quite a lot of wastage. Even some expired way after, and you try to donate to another country and they don't want it, and all those issues. But here we are.
Yes. Jane, do you have the question?
Yeah, I think I remember the second question. I think I asked whether you said in your paper there was no vaccines extent in Botswana. Was that correct? And if so, why?
She said, I read in your presentation that there was no vaccine hesitancy in Botswana.
Oh, there was no vaccine hesitancy.
Is that right?
Okay.
It is right. What was the reason behind it?
Oh, okay. No, it's not that there is no vaccine hesitancy. I think what we said is that there were no studies that showed vaccine hesitancy, and but we do know of certain populations, groups, that these ones are hesitant. It doesn't matter which vaccine it is. We ran into issues of the youth in terms of COVID vaccines, where the youth said we don't want that thing, versus adults who thought it was safer. You know, I think so. So those issues were there. It then took, like colleagues have been discussing, those community engagement tactics based on what the situation was in the particular community, using leaders, influencers, and politicians and all. But there is hesitance. We just haven't measured it. Yeah, thank you.
Yeah, thank you. So I would like to thank all the colleagues for your hard efforts and for the great presentations. And maybe I will ask Danny to have some hints, but I would like to encourage you to get in touch with other colleagues because there is a quiz after the coffee break.
Thank you so much, Dr. Riwa Khalife, and the great discussion this morning. Can we please put together our hands for them once more? And so at this point, as I said earlier, we started late today. We managed to catch up at least somehow. We've gained some minutes, and so can we use the next 10 minutes, please, to have some snacks and reconvene? And leave your write-ups. I understand you were asked to write up your name and your hobby. Can you please leave them with on your tables? We'll pick them up, and when we come back, we'll play some game. So the next 10 minutes, let's try as much as possible. So our time is up. Can we all get back to our seats, please? So in the process of this session, as I said, we are going to play some game. I have all your sheets here with your hobbies, and I'm going to distribute them randomly. And in the process of the meeting, we will do it row by row, and then yes. So we'll ask you to pick your sheet and then look at the name on top. And if you know the person, whether you know the person or not, just ask for the sake of everybody. And then the person can mention the name. You actually have to then say what the person's hobby is and let the person confirm whether it's true or not. Is that right? Okay. So, but we won't start that for now because of in the interest of time, but we'll do it in the process of the presentation. The moderator perhaps will facilitate that along the process. And we are still glad to have our colleague, Dr. Riwa Khalife here with us, and she will be taking us through this session again. So in the interest of time, and please, can we all come back to our seats? I will hand over to her now and allow her to take us through this session. Our first presentation is going to be online. And so the person is ready. And so at this point, Rewa, can you please take over? Thank you.
Yes, so hi again. It's me. Yeah, again, also, again and again and again. I don't know, because maybe Danny loves me, so he assigned me 2 sessions to moderate, so I don't know. So just, I would love to share with you something interesting that I've discovered now. I don't know if you are aware of it or no, but let me share with you. So yesterday I asked Clarissa, so what's your name? My name is Clarissa. So I said, yeah, okay, Clarissa. So today I was like reading the paper here. I saw Mba Clarissa. I said, oh my God, her name is Mba. How come that? She told me yesterday, Clarissa, and I was all the day saying Clarissa, Clarissa. Yeah, then also I discovered that Mba Cleophas. So I say Mba and Mba. So what does it mean, Mba? Yeah, so what does it mean? Yeah, who knows? It's not just me.
Context. Depends on the perspective.
Which context? Which perspective?
In Igbo language,
No. Yeah, it's not Mba. It's not Mba, no. No, no. No at all, no. Yeah, who knows? Oh my God, so I'm sharing something very important, let's see. So, do you know that Mba? So I will let maybe Clarissa clarify this better than me. So it's the name of the village. So Clarissa and Cleophas are from the same village. That's why they use the Mba. Yeah? It's something to remember. Yeah, it's something very interesting to know about Cameroon. Right? Yeah, maybe we can ask him, what's your name? Yes. It's Mba? No, Mba? So yeah, what's your name? Is? Mtom. And what's other than Mba? It's? No. Yeah, so, and also to say that they were very happy to know each other here. Yeah, so they get together here and they knew each other more here. So let's applaud them, and we learned something, yeah? Something new other than research and study. Yeah, so let's start our second sessions for today. And we have someone online, Brahima Gaye. So the title of the presentation is Cross-Sectional Study on Intention to be Vaccinated Against COVID-19 in Benin and Senegal, a Structural Equation Modeling. Yes. Is she or he online?
Yes, I'm online. Hi, everyone.
Hi.
Bonjour à tous.
Yeah, so Brahima, what's your hobby?
Could you,
yeah, it's
could you
something
repeat,
not
please?
familiar, but yeah, just we are getting together, and we would love to know what's your hobby.
My hobby?
Ah, sorry. OK, so désolé. Donc tu parles français, donc on va un petit peu. Donc c'était quelque chose qu'on a joué aujourd'hui pour faire la connaissance des collègues. On a pris comme une petite feuille, oui, et on a écrit là-dessous notre nom, le pays et notre loisir. Donc, on a fait la connaissance de beaucoup de personnes là. Et il y a des loisirs communs si on peut le dire, entre plusieurs personnes. Mais j'aimerais bien savoir quel est votre loisir.
Ok, ok. Bon, moi, en tout cas, mon loisir préféré, c'est le football, en fait.
Ah, le football. Il y a quelqu'un watching football. That's Chijoki.
Ok.
Le loisir de Chijoki, c'est de regarder aussi le football. Tu savais ça? Non, c'est quelque chose de nouveau. Tu vois, on apprend toujours à tout âge, dans n'importe quel pays, on apprend toujours. Donc, à vous la parole et pour la présentation, si tu es prêt, donc on vous entend.
C'est bon, vous voyez mon écran?
Oui.
Ok. Je vais vous présenter les résultats d'une recherche que j'ai effectuée dans le cadre de
Oui, mais si tu peux mettre les slides en mode de présentation, comme ça on peut voir le slide affiché en gros.
Ok. Je pense que c'est bon?
Oui, oui, très bien, merci.
Ok. Donc, je disais qu'en fait, je vais vous présenter les résultats d'une recherche que j'ai effectuée dans le cadre de ma thèse en santé publique. C'est une étude transversale sur l'intention de se faire vacciner contre le COVID-19 qui a été menée au Sénégal et au Bénin. Et nous avions utilisé une approche par équation structurelle, c'est-à-dire les modèles SEM. Donc, pour le plan de la présentation, donc la présentation va se dérouler comme suit. Nous allons d'abord faire une petite introduction pour rappeler le contexte dans lequel l'étude a été menée. Ensuite, nous allons vous faire un bref résumé de la méthodologie et des méthodes qui ont été utilisées pour pouvoir aboutir à ces résultats, avant de vous présenter les résultats et de vous faire quelques conclusions. Donc, par rapport à l'introduction, il faut rappeler qu'à partir du 11 mars 2020, l'OMS a fait une déclaration pour déclarer, en tout cas pour dire que la COVID-19 est maintenant une pandémie mondiale. Il s'ensuit dans beaucoup de pays des mesures qui ont été effectuées allant du confinement, de la distanciation sociale jusqu'à l'interdiction des rassemblements, notamment au Sénégal. Et rapidement, on a vu que l'OMS a autorisé, en tout cas, le développement rapide des vaccins. Et on a vu quand même une succession de vaccins autorisés. Et cela part du fait que l'OMS était convaincu que l'importance de l'immunité collective pourrait réduire la transmission de la COVID-19. Et la troisième étape était en fait d'assister au sein des pays à des lancements de campagnes de vaccination. Au Bénin, la campagne de vaccination contre la COVID-19 a été lancée en février 2021. Au Sénégal, la campagne de vaccination a été lancée en mars 2029. Mais quand même, après 1 an ou 2 ans de mise en œuvre, au moment où nous faisions cette étude, on s'est rendu compte que, en tout cas, le taux de vaccination complète était toujours faible dans ces pays. Parce que l'OMS avait fixé un standard de 70% minimum pour chaque pays. Et alors, le Sénégal était toujours à 7,6%, c'est-à-dire que bien en dessous des 10%, et le Bénin à 21% à peu près. Et plusieurs études quand même ont prouvé que ont mis en évidence des obstacles à l'adoption des vaccins. On pourrait aller à la préoccupation sur la sécurité et l'efficacité, mais également sur le manque d'informations fiables sur les vaccins, mais surtout aussi sur la désinformation par rapport à ces vaccins. Et
Désolée, Ibrahima, tu m'entends?
oui, je vous entends.
Oui, tu peux y aller plus lentement parce qu'il y a ici l'interprétation, s'il te plaît.
D'accord, ça marche.
Merci.
Bon, nous les Sahéliens, on a l'habitude de parler trop vite, quoi. C'est bien de nous rappeler alors. Donc, je disais que plusieurs de ces études avaient montré qu'il y a un certain nombre d'obstacles à l'adoption des vaccins. Il y avait d'abord la préoccupation sur la sécurité du vaccin, mais aussi sur l'efficacité du vaccin. Il y avait surtout aussi un manque d'informations fiables sur les vaccins, mais aussi la désinformation sur les vaccins. Maintenant, la difficulté principale qu'on avait constatée avec ces études-là, avec notre revue documentaire, notre revue de littérature, c'était que ces études avaient juste mis en évidence un modèle multivarié. Donc, on ne voyait pas les interactions entre les différentes dimensions. Par exemple, la sécurité et l'efficacité. Est-ce qu'il y a un lien? Est-ce qu'il y a un lien aussi entre l'accès à l'information et la sécurité du vaccin et à l'efficacité? Ça, les modèles qui ont été utilisés ne permettraient pas de répondre à ces questions-là. OK? J'active ma vidéo. Donc, voilà tout l'intérêt de l'approche qu'on avait utilisée, c'est-à-dire l'approche des modèles d'équation structurelle, qui sont une approche avancée pour analyser des processus complexes de décision. Par exemple, ici, comment la sécurité ou bien comment l'information sur le vaccin, en tout cas, influence la sécurité, la perception sur la sécurité, influence la perception sur l'efficacité, et donc tout ça, comment ça influence sur l'hésitation vaccinale. Voilà en quelque sorte, en tout cas, l'intérêt de l'approche qu'on avait adoptée, qui permettait quand même d'analyser des processus complexes de décision. Ça permettrait aussi d'explorer des relations causales en réduisant les biais, mais également la capacité confirmatoire qu'on va voir. Donc, pour la mise en œuvre de l'étude, donc il s'agissait d'une étude transversale, descriptive et analytique. Et la période de collecte au Sénégal, l'étude a démarré le 24 décembre 2020 pour finir le 16 janvier 2021. Au Bénin, l'étude a démarré le 29 mars 2021 pour finir le 14 mai 2021. On voit que quand même, globalement, les études ont été menées presque sur la même période. Maintenant, qui était ciblé par rapport à cette étude-là? Il s'agissait de la population âgée de 18 ans et plus. Parce qu'il y avait en tout cas, il y avait en tout cas ce principe-là qui consiste, comme c'était des enquêtes téléphoniques, à ne pas avoir l'autorisation. Donc, on avait décidé de limiter la population à 18 ans et plus, c'est-à-dire les adultes. Et surtout, c'était une population qui disposait d'un téléphone portable. On va revenir surtout après sur le processus de collecte de données pour pouvoir quand même comprendre pourquoi ces critères d'inclusion-là ont été sélectionnés. Donc, par rapport à l'échantillonnage, nous avions adopté une approche par quotas marginaux basée sur un échantillon de 1000 personnes âgées de 18 ans et plus. Et les critères de quotas, les variables de quotas qu'on avait utilisées, c'était la région de résidence, l'âge et le sexe. C'était des variables qui étaient pertinentes et liées aux variables d'intérêt parce que beaucoup d'études ont montré que la région, la catégorie d'âge, mais surtout le sexe, c'était des éléments qui étaient liés à l'adoption de la vaccination contre le COVID-19. Ces variables aussi, on pouvait facilement avoir la structure de ces variables-là pour définir les quotas. Parce que c'est des informations qui sont accessibles à tous et qui sont disponibles auprès des instituts nationaux de statistiques, que ce soit l'ANSD ou l'Institut national de statistiques du Bénin. C'est également des informations qui sont aisément identifiables au début de l'interview. Parce que comme on a mis en œuvre la méthode des quotas marginaux, il fallait quand même, dès le début, savoir si cette personne entre dans les quotas ou non. Et enfin, on a effectué une stratégie de post-certification parce qu'en fait, quand on définit les quotas marginaux, on peut par exemple avoir besoin de 100 personnes qui habitent à Dakar et qui sont âgées de plus de 25 ans. Si on a 99 personnes, pour respecter cette structure de population, il faut forcer quand même les quotas à suivre cette représentativité. C'est ça qu'on appelle un calage sur marche. C'est une technique de post-stratification qui est facile à mettre en œuvre, qu'on avait utilisée pour être sûr que notre échantillon dans les deux pays est représentatif de la population. Maintenant, pour la collecte des données, nous avions utilisé l'approche de Random Digit Jalling plutôt, l'approche RDD, qui consistait d'abord à générer aléatoirement des numéros de téléphone. Et ces numéros de téléphone étaient générés pour chaque opérateur qui est disponible au niveau du pays. Par exemple, pour le Sénégal, nous avions 3 opérateurs. Nous avions le Orange, nous avions Tigo et nous avions Expresso. Nous avions généré 1000 numéros pour chaque opérateur. Ensuite, à l'aide d'une application, on vérifiait la validité de ces numéros parce qu'on envoyait des SMS. Si ça passait, on savait que ces numéros-là étaient valables. Et ensuite, on a fait la sélection de ces numéros qui étaient valables. Et la troisième étape consistait à mener des appels vers ces numéros-là à l'aide d'un centre d'appel. Et que tous ces appels, toutes ces 3 étapes-là étaient automatisées. C'était informatisé. Donc, toutes les 3 étapes à gauche, les enquêteurs ou téléopératrices n'intervenaient pas. Maintenant, c'est le système qui générait aléatoirement les numéros. C'est le système qui envoyait les numéros, qui envoyait des SMS. Mais une fois que le système avait un accusé de réception pour dire que ça, c'est un numéro qui est valide, le système composait automatiquement ce numéro-là. Et dès que la personne décrochait, le centre d'appel fait la mise en relation entre la machine et la téléopératrice pour pouvoir administrer le questionnaire. Donc, dès que la mise en relation est effectuée à la 4e étape, ce que la téléopératrice fait en premier, c'est de donner des informations sur le projet, sur l'enquête et de demander le consentement de la personne. Et si la personne consent à participer à l'étude, il y avait un formulaire ODK qui s'ouvrait automatiquement. Et ce formulaire ODK, ce n'est rien d'autre que le questionnaire qui a été digitalisé. Donc voilà en quelque sorte le système de collecte qui a été adopté. Je rappelle le contexte dans lequel l'étude a été menée, parce que dès le début, je vous parlais des mesures qui ont été prises par les pays. Par exemple, au Sénégal, on avait l'interdiction de déplacement, on avait le confinement, on avait pas mal de mesures. Donc, il était impossible de faire des enquêtes de terrain. Donc, ce qu'on a fait, c'est vraiment l'approche du RDD, le Random Digit Dialing, qui consistait à générer ces numéros-là et ensuite tester la validité de ces numéros et de pouvoir émettre les appels et de faire la mise en relation entre le système informatique et l'opératrice de collecte. Donc, maintenant, le questionnaire qui a été digitalisé, c'est un questionnaire qui a été conçu sur la base de 2 modèles théoriques. Le premier modèle théorique, c'est la théorie du comportement planifié, qu'on appelle le TPB. Et l'objectif de ce modèle, qui a été testé et c'est un modèle récent également, c'est qu'il analyse les attitudes, l'influence sociale et le contrôle comportemental sur l'intention vaccinale. C'est un modèle également qui étudie l'interaction entre les croyances personnelles, l'influence sociale et le contrôle perçu. C'est un modèle qui offre une compréhension des facteurs déterminants, déterminant les choix comportementaux en matière de santé. On a combiné ce modèle avec le modèle des croyances en santé, qui est également un modèle récent qui ont été utilisés de manière peut-être séparée par plusieurs chercheurs dans le cadre de dans le contexte de Covid. Mais nous, on avait jugé nécessaire de combiner ces 2 méthodes pour offrir plus d'informations et plus de valeur ajoutée à notre étude. Donc, le modèle des croyances en santé, c'est un modèle qui offre une évaluation des perceptions, mais aussi des motivations qui sont liées à la décision de santé. Et ça explore également les perceptions de gravité, les perceptions de susceptibilité par rapport à un problème de santé qui est ici la COVID-19. Et enfin, c'est un modèle qui permet d'identifier les bénéfices perçus, les actions préventives et les obstacles potentiels. Et en combinant ces 2 modèles, ça nous permet de capturer multidimensionnellement des processus décisionnels liés à la santé. On va le voir tout à l'heure. Quand j'ai montré l'ensemble des dimensions qui ont été considérées dans le cadre de nos recherches, vous allez voir que c'est vraiment des dimensions qui sont vraiment très larges pour couvrir le maximum d'informations possibles. Des facteurs de motivation cognitive qui influencent les comportements en santé, et c'est un modèle également qui renforce la profondeur et la précision de l'analyse, comme je vous ai dit tantôt. Et ce sont des modèles également qui sont robustes et qui sont prouvés, qui ont également fait leurs preuves pour examiner des facteurs qui influencent les décisions en matière de santé. Voilà, en fait. Ces modèles nous ont permis de travailler sur ces dimensions-là. Ces 8 dimensions. C'est-à-dire l'attitude, les attitudes vis-à-vis du vaccin, que vous avez, les bénéfices du vaccin COVID-19, c'est la deuxième dimension, sécurité du vaccin. Quatrième dimension, le contrôle comportemental. Cinquième dimension, c'est l'accès à l'information, tout ce qui est la recherche d'informations liées à la vaccination. Septième dimension, c'est tout ce qui est la perception de l'efficacité du vaccin. Et enfin, en dernier, l'influence sociale. Maintenant, on ne s'est pas arrêté à définir uniquement ces vaccins et à regrouper ces variables. On a testé à l'aide du alpha de Cronbach, que vous voyez ici, la consistance interne. C'est-à-dire que la capacité de ces variables-là à mesurer la même dimension. Et l'alpha de Cronbach nous dit qu'en fait, dès que l'alpha de Cronbach est supérieur à 6, on peut considérer que c'est ces variables-là, en tout cas, sont acceptables des cas. On a des alpha de Cronbach de l'ordre de 7 et plus, de 0,7 et plus. Ce qui montre que quand même, que les variables qu'on a constituées en termes presque la même chose. Donc, par exemple, il est important de se faire vacciner. Et aussi, je pense qu'il est utile de se faire vacciner pour se protéger contre le COVID-19. Je pense qu'il est responsable de se faire vacciner contre le COVID-19, ainsi de suite. Ces variables-là mesurent en gros la même chose qui est l'attitude vis-à-vis de la vaccination. Maintenant, concernant l'analyse des données, nous avons adopté la consiste en 2 étapes. À d'abord faire une analyse factorielle exploratoire. Mais l'analyse factorielle exploratoire va nous dire quelle est la relation entre ces dimensions-là. Est-ce que les attitudes sont liées au comportement, sont liées au contrôle comportemental, ou est-ce que les attitudes vis-à-vis du vaccin sont liées au bénéfice du vaccin, et ainsi de suite. Ça, c'est l'analyse factorielle exploratoire qui nous permet d'avoir ces résultats-là. C'est pourquoi on dit que l'analyse factorielle exploratoire nous a permis d'identifier et d'explorer les relations initiales entre les échelles. Ça veut dire que vous allez voir après des relations qu'on a ajoutées en dehors du modèle, parce qu'il y avait ces résultats de l'analyse factorielle exploratoire qui nous avaient montré qu'il y a certaines dimensions qui sont liées entre elles. Ça nous permet également de formuler des hypothèses sur la nature de ces associations. Nous avons également utilisé l'indice de Kaiser, le KMO, sur le tableau, les 2 premières colonnes. Toutes les valeurs du KMO sont supérieures à 0,7. Ça veut dire que l'analyse factorielle exploratoire est pertinente pour ces dimensions-là. Nous avons également effectué le test de spécificité de Bartlett pour vérifier la présence d'une structure de corrélation significative. Parce qu'avant de faire une analyse factorielle exploratoire, il faut vérifier pas mal de choses. Il faudrait d'abord que ce soit pertinent pour ce qu'on a vérifié avec le KMO. Il faudrait également que le test de Bartlett nous donne qu'il y a une présence de corrélation, il y a une structure de corrélation significative. Tous ces deux-là ont été respectés. Aussi, l'analyse factorielle exploratoire nous donne ce qu'on appelle les charges factorielles. Et quand on regarde les charges factorielles, on voit que les charges factorielles révèlent des relations différentes entre les pays selon les échelles. Parce que les charges factorielles, ce qu'elles disent, c'est quoi? Toutes les valeurs supérieures à 0,7 sont liées entre elles. Et comme vous pouvez le voir sur les 2 dernières colonnes, il y a des relations qui sont différentes entre les 2 pays. C'est ce qui nous a permis d'aboutir à ces modèles théoriques-là. Donc,
tu as encore 5 minutes.
OK, d'accord, je vais accélérer. C'est ce qui nous a permis d'aboutir à ces modèles théoriques-là. Donc, nous avons l'attitude vis-à-vis du vaccin qui influe sur l'intention vaccinale, toutes ces dimensions qu'on a définies. Mais ce que vous voyez ici, les échelles, c'est que l'attitude vis-à-vis du vaccin est liée au contrôle comportemental et liée également à la perception des bénéfices du vaccin. L'attitude vis-à-vis du vaccin est liée également à l'influence sociale.
C'est pas... c'est pas d'y aller vite parce qu'il y a l'interprétation ici, mais si tu peux un petit peu résumer ce que tu vas parler dans les slides suivants.
OK, il n'y a pas de souci. Donc, c'est juste pour vous montrer à travers ces deux modèles-là que l'analyse factorielle exploratoire que nous avions fait nous a permis d'établir des relations différentes entre les pays. Vous voyez ici la nature des relations au Bénin est différente de la nature des relations au Sénégal, même si on utilise le même modèle, mais les données font qu'il y a des perceptions, il y a des relations qu'il faut définir avant d'aller au résultat. Donc, nous avions enfin la deuxième étape de l'approche Lomax, consistait à dérouler le modèle d'équation structurelle qui permettait de tester et de valider le modèle théorique qu'on a vu tout à l'heure, d'examiner les relations causales entre les dimensions, mais également d'identifier les chemins causalité potentielle et d'évaluer l'ajustement du modèle. Je rappelle que pour la mise en œuvre du modèle, nous avions utilisé la méthode des moyennes carrées pondérées en diagonale, parce que la revue avait montré que la méthode des moyennes carrées avait des limites pour ce qui est des variables catégorielles, des variables qui sont conçues sur l'échelle de Likert. Et la plupart de nos variables étaient conçues sur l'échelle de Likert. Et comme vous le voyez ici, les indices d'ajustement du modèle montrent que le modèle a un bon ajustement. Parce que les valeurs élevées des indices, quand vous voyez le CFI, le TLI, ce sont des valeurs qui sont très faibles, c'est-à-dire inférieures à 0,9. Et les valeurs élevées de RMSEA et le SRMR montrent que le modèle a une adéquation qui est satisfaisante. Donc, pour en venir rapidement sur le modèle, comme vous le voyez ici, on voit qu'au Bénin, le premier facteur explicatif de la vaccination, c'est l'influence sociale vis-à-vis du vaccin. Nous avions ensuite des valeurs comme le contrôle comportemental, qui n'a pas un impact significatif, mais c'est juste pour vous montrer que vous avez des résultats, on voit que l'influence sociale du vaccin a joué un rôle fondamental dans la décision de se faire vacciner. Il y avait également les attitudes vis-à-vis du vaccin. Il y avait également la perception de l'efficacité du vaccin. C'est-à-dire que ce qu'on montre ici, c'est que plus la perception était élevée, plus la personne avait une mauvaise perception de l'efficacité du vaccin, moins la personne était enclin à se faire vacciner. Et les résultats ont permis également de mettre en évidence des relations entre les dimensions, comme vous voulez voir ici. Donc, nous avions l'attitude vis-à-vis du vaccin qui est significativement liée à l'influence sociale. Ça veut dire que plus une bonne attitude vis-à-vis du vaccin COVID-19 augmente l'influence sociale vis-à-vis du vaccin, qui impacte également la décision de se faire vacciner. Exactement la même chose. Un bon contrôle comportemental impacte, en tout cas, améliore l'influence sociale, qui améliore la vaccination, et ainsi de suite. Donc, je pense que c'est à peu près les mêmes résultats que nous avons ici au Sénégal comme au Bénin, avec des relations différentes. Mais je vais peut-être, comme le temps est assez court, insister sur les similarités et les disparités entre les deux pays. Dans les deux pays, les résultats nous montrent que les attitudes positives envers la vaccination contre la COVID-19, mais également les perceptions des bénéfices des vaccins sont significativement associées à une plus grande influence sociale sur la décision de se faire vacciner. Et naturellement, une plus grande influence sociale sur la décision de se faire vacciner pousse la personne à adopter la vaccination. Ces résultats similaires entre les deux pays mettent en évidence deux choses. La première, c'est l'importance d'une communication efficace sur les bénéfices du vaccin, mais également la promotion d'attitudes positives envers la vaccination pour encourager l'adoption du vaccin. Aussi, nous avions trouvé des disparités entre les pays. On a vu qu'au Bénin, l'influence sociale, qui est le facteur fondamental de la décision du vaccinant, de se faire vacciner, était accentuée par le contrôle comportemental. C'est-à-dire que le contrôle comportemental était la dimension qui pousse plus la personne, l'influence sociale, et donc la vaccination. Alors qu'au
Brahim,
Sénégal, oui,
le temps est terminé.
d'accord, ok, je termine sur ce point. Alors qu'au Sénégal, la vaccination était, en tout cas, l'influence sociale était étroitement liée à la perception de la vaccination. Donc voilà, ça, c'est les conclusions qu'on avait vraiment, qu'on a un peu passé en revue. Donc, je vous remercie vraiment de nous donner l'occasion de présenter les résultats de nos
Brahima.
recherches dans le cadre de cette conférence. Merci.
Donc, Brahima, tu restes avec nous ou tu quittes?
Je vais rester un moment.
Oui, parce qu'il y a les questions à la fin. Je ne sais pas si tu peux rester parce qu'il y a 3 présentations maintenant à faire et puis on pose les questions. Est-ce que c'est possible?
Oui, il n'y a pas de souci, je pourrais rester.
D'accord, très bien. Merci, merci bien.
Merci.
D'accord. So we will shift to the second presentation, but maybe before inviting Anton to the presentation, I would like to ask you, the lady. Yeah, what's your name? Yeah.
Maulo.
Mauno.
Maulo.
Maulo. From
Ghana.
your hobby?
Swimming, reading, and baking.
So what was your last book?
It's not a book, this done. I read on safety measures when we are staying in a hotel.
So Mawulu, look, I have here all the papers.
Okay.
Yeah.
Okay.
So I will choose one randomly and I will ask you to, we will see if you know this person, yes or no. Yeah? It's someone in the room, of course. Yeah. So hope it's not your name. No. Do you know someone who has a hobby like exercising? No?
No?
Try.
I should try, yeah.
Yeah.
I can do. Let me look at the faces.
Yes, look at the faces. And then I will give you another hint just in case.
Okay. Please.
No.
No?
No.
You
So the
You like
second,
exercising?
please do some exercise. It's something very important for the health. It's healthy, so yeah, we can do with you. So just yeah, exercise. Yeah. Let's upload him. Yeah, just encourage her. Yeah, please go. Yeah. Yeah. Wow. Amazing. Yeah, thank you. So he's from Ethiopia. Yeah. Do you know someone from Ethiopia here? Oh. So what's his name? Ah. Look, he's sad. He's upset now. What do you think? The first letter is T. So just try.
Okay. Can you give me some tips?
Oh my God. So T and Tess. It's not Tesla.
No, it's not coming.
It's not coming. Oh my God. So, do you know another person from Ethiopia here? Do you know that we have like 2 people from Ethiopia here?
Yes.
Oh my God. Do you know her name?
No, I know her title.
Title. Oh, that's good. What's her title?
Doctor.
Yeah. So his name is Tasfai. Yeah? Is it okay?
Yeah.
Yeah? Is it something that you will remember after 1 hour if I ask you again?
Yeah, please say it again.
That's fine.
That's fine.
Yeah.
That's fine.
Yeah, do you know I can consider myself and also maybe Jane that we are from Ethiopia, since Jane has been there for more than 13 years, me for 5 years. But yeah, we can consider us from Ethiopia. That's okay. Yeah, so let's move to Tom. We are not asking you for exercise, yeah? No worries. So, the title of the presentation, Effort de vaccination contre la COVID-19 renforce la prestation des services de vaccination pour un accès équitable aux vaccins de routine dans les zones d'accès difficiles au Cameroun. Donc, on vous entend et à vous la parole.
Ok, merci beaucoup de nous passer la parole. Donc, je fais cette présentation en français, unfortunately. Alors, je suis le docteur M. Tom Sebde, je suis médecin santé publique, option épidémiologiste. Je suis conseiller technique en renforcement des systèmes de santé à USAID MTAPS Cameroun. Donc, je vais partager ici l'expérience du Cameroun sur la vaccination au dernier kilomètre pour les populations qui n'avaient pas physiquement accès au vaccin COVID-19 pendant la pandémie. Donc là, c'est l'équipe de rédaction. Nous avons travaillé en collaboration avec le Centre des opérations des urgences de santé publique et puis le Programme national de vaccination du Cameroun. Donc ça, c'est le plan que nous allons suivre. Donc, il faut le dire qu'au Cameroun, les premiers cas de COVID-19 ont été confirmés au mois de mars 2020 et nous avons obtenu le vaccin à partir du mois d'avril 2021, donc pratiquement 1 an plus tard. Depuis l'obtention du vaccin, nous avons organisé 5 grandes campagnes de vaccination de masse, y compris pendant cette période aussi, nous avons organisé la Coupe d'Afrique des Nations de 2022, où nous avons aussi organisé une grande campagne de vaccination. Mais il faut dire qu'à chaque fois qu'on organisait les campagnes de vaccination au Cameroun, il y avait des zones où on n'avait pas accès parce que ces zones demandaient un déploiement plus gros en termes de logistique et de ressources. Donc, lorsque le gouvernement organise des campagnes de masse, il y a des zones où il préfère mobiliser les ressources ailleurs pour capitaliser les résultats et laisse une grande partie de la population sans accès de manière générale aux soins de santé primaires et en particulier aux services de vaccination. Donc, voilà pourquoi, lorsque nous avons eu l'opportunité d'un financement avec USAID MTAPS, nous avons ciblé ces zones dont l'accès était très difficile pour pouvoir renforcer en termes de logistique et de ressources afin d'atteindre cette tranche de la population. Donc, il faut dire ici que l'État ayant des difficultés à mobiliser beaucoup de fonds pour pouvoir mobiliser la ressource nécessaire pour atteindre ces zones dont il faudra défier souvent les forces de la nature. Et il faut dire aussi que dans cette zone-là, le besoin reste très important parce qu'il y a une très grande population. Bizarrement, lorsqu'il faut faire des campagnes politiques pour les élections, on arrive facilement dans ces zones-là. Mais quand c'est pour déployer en termes d'infrastructures ou de soins de santé primaires, là-bas, c'est très difficile d'avoir la ressource. Donc, l'appui que USAID a donné pour mettre en place, pour approvisionner le vaccin dans ces zones d'accès difficiles, nous a permis de faire une mobilisation des ressources logistiques, un déploiement des professionnels de santé sur le site. Nous avons aussi fait une dispensation des vaccins. Au-delà de la vaccination, nous avons aussi apporté les autres offres de services de vaccination et puis les soins procurés aux femmes enceintes et aux enfants de 0 à 5 ans. Et nous avons aussi fait assurer la logistique inverse pour la gestion des déchets et des périmés. Donc, l'objectif général de cette activité était de renforcer la couverture vaccinale intégrant la COVID-19 d'une part, et puis les autres offres de vaccination de routine pour les enfants de 0 à 5 ans et les femmes enceintes. Donc, de manière plus spécifique, nous avons pour objectif d'améliorer la couverture vaccinale de la COVID-19 dans ces zones dont l'accès est difficile, et puis de faire le rattrapage des vaccinations de routine chez les femmes enceintes et les enfants de 0 à 5 ans. Donc, pour ce faire, la méthodologie que nous avons utilisée, il faut dire que nous avons sélectionné les zones dans lesquelles nous avons travaillé. Le pays compte environ 205 districts de santé. Nous avons travaillé dans 47 districts de santé, dont 3 régions sur les 10 qui existent. Nous avons couvert 291 aires de santé et nous avons identifié 752 localités d'accès difficile. Nous avons fait ce travail sur une période de 7 semaines, entre avril et août 2023. Il était question ici pour chaque équipe de vaccination de descendre au moins 2 fois par semaine sur les sites de vaccination afin de pouvoir procurer des soins de santé primaires. Pour faire ce travail, il a fallu mobiliser pas moins de 1000 acteurs pour réaliser cette activité, dont 248 équipes de vaccination pour chaque équipe qui était constituée d'un enregistreur, d'un vaccinateur et d'un mobilisateur social. Nous avons aussi travaillé avec 47 gestionnaires de données et 94 superviseurs. Nous avons mobilisé 15 véhicules, 15 pirogues, 7 hors-bord et 283 motos pour pouvoir accéder dans ces zones. Alors, nous avons fait ce travail en 3 étapes. Nous avons d'abord fait une micro-planification. La micro-planification nous a permis d'identifier les localités d'accès difficiles, de faire une estimation de la population cible pour la vaccination afin de préparer la logistique et puis de faire une estimation en termes de besoins logistiques. Une fois les localités identifiées, nous avons passé à l'étape du briefing des acteurs qui devaient faire le travail de vaccination. Donc, nous avons composé les équipes de vaccination, nous avons élaboré les plannings de descente sur les sites et puis nous avons fait un approvisionnement en intrants et vaccins. Puis, en 3e étape, nous avons effectué la descente proprement dite. La mobilisation se faisait par les agents de santé communautaire. Ensuite, nous avons opté pour la stratégie de porte en porte dans ces localités-là. Et nous avons aussi ciblé les zones où il y avait un rassemblement de population. À ça, nous avons associé à la vaccination COVID-19, nous avons associé le paquet minimum de services de vaccination complet. Alors, pour nos résultats, concernant la vaccination COVID-19 dans ces zones d'accès difficiles, il faut dire que nous avons administré un peu plus de 100 000 doses de vaccins COVID-19, donc une couverture de 63,8% de la population cible de ces zones d'accès difficiles que nous avons identifiées. Et le vaccin le plus utilisé était le vaccin du laboratoire Johnson & Johnson à hauteur de 81,4%. Nous avons les 76,5% des personnes vaccinées recevaient leur toute première dose de vaccination COVID-19. Et puis, nous avons eu un taux de vaccinés complètement vaccinés de 88,2%. 12% de ces populations recevaient les doses booster. Il faut dire que le sexe ratio est tourné autour de 1, donc autant de femmes que d'hommes ont reçu ce vaccin. Ici, cette diapositive nous montre ici la comparaison de l'activité de vaccination dans les zones d'accès difficiles avec les autres campagnes que nous avons eu à tenir au Cameroun. Lorsqu'on voit ici le tout premier round, c'est lorsqu'on venait d'acquérir le vaccin COVID-19, où la population était très réticente en termes d'acceptabilité du vaccin. Et on se rend compte que la vaccination dans les zones d'accès difficiles a procuré un meilleur résultat sur pratiquement les 3 premières campagnes de vaccination que le pays a organisées. Donc, c'était pour dire ici juste que la demande dans ces zones reculées, elle était importante, le besoin y était, mais il n'y avait pas d'accessibilité à ce type de soins. La particularité est mise ici sur l'organisation de la Coupe d'Afrique des Nations, Parce que ici, la cible, elle était différente. C'était tous ceux qui entraient au pays pour pouvoir participer ou pour pouvoir vivre la fête de la Cannes et les zones de rassemblement où on procurait la vaccination. Et ce pic que vous voyez ici, c'est la campagne de vaccination, le 5e tour que ma collègue a présenté l'aspect logistique et dont elle a présenté les résultats il y a quelques instants. Concernant maintenant les autres offres de services de vaccination, c'est-à-dire le rattrapage, il faut dire qu'une fois que les équipes descendaient sur les sites, on profitait aussi pour procurer le minimum en termes de vaccins de routine. Et il faut dire qu'on n'a pas rattrapé, pas moins de 7000 enfants ont rattrapé leur vaccin depuis qu'ils sont nés. Et vous allez voir, on a dans cette proportion, 3,1% étaient des zéro doses, donc des enfants qui n'avaient reçu aucune dose de vaccin diphtérie, coqueluche et tétanos. 4,4% avaient leur premier contact avec le vaccin. C'est-à-dire qu'il y a des enfants qui étaient nés et depuis qu'ils étaient nés, ils n'avaient jamais reçu de vaccin. Or, la première dose de vaccination qu'on donne chez nous, c'est le vaccin contre la tuberculose et la poliomyélite. 10,7% ont été rattrapés pour la rougeole. Il faut dire que depuis 2019, il y a une épidémie sporadique de rougeole qui va un peu partout dans le territoire national, ce qui fait que même lorsqu'on organise les campagnes de riposte rougeole, on n'arrive pas dans ces zones et ce qui fait qu'on a un très grand besoin en termes de couverture de vaccins contre la rougeole dans ces zones-là. Nous avons rattrapé aussi 4% de la fièvre jaune et celui qui est important, c'est le vaccin contre le cancer du col de l'utérus. Il faut dire que c'est un vaccin qui fait beaucoup de polémiques dans notre contexte. Il cible les enfants de 9 ans et des enfants qui ne sont pas encore sexuellement actifs. Ce qui fait que pour vacciner cette marge de population, c'est très compliqué. Mais lorsqu'on voit cette figure, on remarque une nette adhésion de ce vaccin dans les zones d'accès difficiles. Donc, nous avons pratiquement une couverture de 12,8% de vaccins contre le human papillomavirus dans ces zones d'accès difficiles. Là, c'est un résumé des vaccins de routine en fonction des âges. Comme je le disais, les 9 ans pour le HPV, les polio 0 et le BCG pour les enfants de 0 à 28 jours. Et les enfants 0 dose sont les enfants âgés entre 4 et 6 semaines. Concernant les autres offres de services de vaccination, nous avons la supplémentation en vitamine A, le déparasitage et la vaccination des femmes enceintes. Donc, il faut dire que nous avons rattrapé 323 femmes enceintes qui ont au moins reçu une dose de vaccin antitétanique pendant leur grossesse lors de cette campagne. Nous avons fait une supplémentation en vitamine A de 100 000 unités internationales chez 2300 enfants. Et chez les enfants de plus d'un an, nous avons utilisé les 200 000 unités internationales. Et ce n'est pas moins de 11 000 enfants qui ont été rattrapés dans le cadre de la supplémentation en vitamine A. Il faut dire que ce sont des zones où les maladies liées à la carence en vitamine A sont très récurrentes. Et puis, on n'a pas moins de 13 000 enfants de 6 mois à 10 ans qui ont été déparasités au cours de cette activité à l'albendazole. Alors, en conclusion, nous pouvons dire que l'opportunité que nous a donnée USAID à travers MTAPS pour la vaccination des populations dont l'accès est très difficile dans leur zone, c'est-à-dire la vaccination au dernier kilométrage, nous a permis de mobiliser des ressources logistiques afin de faciliter l'accès dans ces zones et un bon approvisionnement en termes de chaîne de froid, de déployer d'équipes professionnelles dans ces localités-là. Et puis, nous avons impliqué les agents de santé communautaires et les leaders communautaires pour pouvoir faciliter la sensibilisation et l'acceptation de ces populations. Ainsi, ça nous a permis de renforcer non seulement la couverture vaccinale de la COVID dans ces zones, mais aussi de rattraper les autres antigènes de la vaccination de routine, y compris la supplémentation en vitamine A et la vaccination des femmes enceintes. Donc, cette activité nous a démontré ainsi l'efficacité d'une approche intégrée de la prestation des services de vaccination pour pouvoir permettre à certaines communautés, en particulier ceux qui sont dans les zones d'accès difficiles, de bénéficier de l'offre de services de soins de santé primaires. Donc là, c'est quelques images des équipes de terrain pour l'accès. Comme je disais, nous sommes allés jusqu'au dernier kilométrage pour pouvoir vacciner les populations. Nous avons bravé les océans et les ponts caducs pour pouvoir disponibiliser le vaccin à ces populations. Nous avons lutté contre les routes compliquées. Et là, nous sommes jusqu'à un enfant pendant son repas. Nous avons profité pour pouvoir lui administrer son rattrapage de vaccin. Donc, sur ce, je vous remercie de votre attention.
Oui, merci pour la présentation et merci pour les 5 minutes additionnelles. Donc, on peut continuer le jeu. Donc, Senai. Yeah, it's your turn now. Do you know someone who likes writing? Writing. Yeah, writing articles, writing books. I don't know, but something like this. No, Professor Johns likes to accompany his wife during cooking. Yeah? No, look, he's from Nigeria. Yeah. Do you know someone from Nigeria here? You win. Yeah. But please, I would like to know what kind of writing? Articles? Poems? Please, let us know more about your hobby. Use the microphone, please.
Yeah, so I would, okay, let me just put the background. I remember when I was in school, I hate writing.
Yeah.
I hate it. So it became an issue. Writing and public speaking was actually an issue for me. But, you know, as a challenge, you take it up as a challenge, and along the line, it becomes something you like doing. You know, you do it more often. And one good aspect of it, or the part I enjoy most, is when I'm being critiqued.
Oh.
You know, when you say that my work is not of standard and all that, you know, it's also a challenge and all that. So not just article, books, putting things together, reports and all that is something I find very fun doing.
Okay. Yeah. So let me ask Chijoki. Are you ready? Yeah. Okay. Oh, there is a lot of hobbies. Swimming, reading, baking. Do you know someone with multiple hobbies? Yeah. Are you the one who likes swimming, baking, and reading? Yes? Really? Yeah, it's Maulum. Yeah. But how did you recognize her? But you told us to put the thing here. Because she said it before? No, I don't think so. Chijoki.
You didn't get that from me. Yeah, she said it before.
Because she said it before.
Yeah.
Yeah?
Yeah.
Are you sure?
Yeah.
Okay. Yeah, so let's move to the next presentation, Maulu. So it's your turn. The title of the presentation, people will not even bring out their children to be immunized because of the corona vaccine. Measuring the impact of fake news, misinformation on vaccine hesitancy and update of COVID-19 vaccine and the role of community engagement in COVID-19 vaccine acceptance in Southern Ghana.
Good afternoon. My name is Maulom Kwatewo. Okay. From Ghana, University of Health and Allied Sciences. And I will be presenting on this topic. People will be bringing out their children to be immunized because of the corona vaccine. Measuring the impact of fake news, misinformation on vaccine hesitancy, and uptake of COVID-19 vaccine, and the role of community engagement in COVID-19 vaccine acceptance in Southern Ghana. My co-authors are Dr. Matilda Brisiako and Prof. Evelyn Ansah. You all agree with me that when fighting infectious diseases, one area scientists give massive attention to is the development of a vaccine. This because it helps to achieve herd immunity and to curb the spread of the disease. In the case of the COVID-19, just 1 year into the pandemic, a milestone was achieved when a vaccine was successfully developed. However, this success will be marred by loads of fake news and misinformation on the vaccine and on the disease. This is of interest to us because misinformation can lead to vaccine hesitancy. So while the world was facing the pandemic, the world had to fight an infodemic as well. In Ghana, when a vaccine was rolled out, the government made several efforts to sensitize and engage communities toward accepting the vaccine. Despite all those efforts, vaccine acceptance of the COVID-19 vaccine is still low in Ghana, and misinformation still persists in the Volta region of Ghana. This justifies the need to use a qualitative approach to understand the real impact all this misinformation has on vaccine hesitancy and vaccine acceptance. Therefore, the objective of this study was to explore how fake news and misinformation influence vaccine hesitancy and the role of community engagement in promoting vaccine acceptance in Volta region, Ghana. Methodology. This was an ethnographic study. We conducted 36 in-depth interviews and 10 focus group discussions. So it was conducted in the Volta region. 2 municipalities were involved and we anonymized them A and B. We use a multi-stage sampling method. So at the municipal level, we made sure that the Director of Health Service were all included. Then directors of the institution that were mandated to educate on COVID-19 vaccine, National Commission for Civic Education, Information Service Department, and at the sub-municipal level, the health workers were all included. Then at the primary healthcare level, CHIPS compound level, frontline health workers were selected. And at the community level too, we made sure there was a fair representation. So the chief, queen mothers, opinion leaders, even traditional leaders were included. Then those on the field, those support to accept the vaccine, community members were also included. In vivo version 12 was used to support analysis, and data was analyzed thematically. This is the map showing the study site and the table. Our result. One thing that emerged during analysis was fake news and misinformation. All of them reported that they had fake news, they had rumors on the vaccine. And the common one we had during this conference, they heard that it can make men impotent. It can lead to disability. It can lead to death. And many of them were worried about the long-term effect of the vaccine, considering the fact that it was produced during the shortest possible time. This is what a male migrant in one of the municipalities had to say. When they developed the vaccine in the US, they halted its use, but they are telling us to take it. There's no company in Africa that produces vaccine. It is only those from the outside world, and these guys have plotted to make us extend. We are scared of the vaccine. The whites want to take over Africa due to our natural resources, so they want to decrease our population. They are giving us this vaccine to make us infertile or to cause us to die. It may interest you to know that the most common source of this information, misinformation they mentioned, was social media, notably Facebook and WhatsApp. And some few of them says they also heard it from the radio. Now, there is one thing to hear those information, but another thing to believe in them. We try to find out the reasons why they believe so much in them. One main reason was mistrust. They lack trust in the Western world. They lack trust in the government. They think that the government is corrupt. Today, the numbers are high. Tomorrow, they are low. No, it's not possible. They are just using that to raise funds. That's what they reported. So they lack trust. And they lack trust in the health workers too. Some reported that maybe the vaccines are good. Probably the health workers are the ones not giving it well. That is why we are experiencing adverse effects. Here is what a church leader had to say. The cases, as they say, it has increased in Ghana. It is up, it is down. It is a camouflage from the government to raise funds into the pockets of some individuals to use. So that trust was not there for some time. We do not have 100% trust in the government concerning COVID-19. So even though government agencies claim they engage the communities, inquiring from the community shows that they were engaged mainly on COVID-19. They were taught how to wash their hands and all those things. But when the vaccine was coming, they didn't come back and say, the vaccine is coming, we have to go through all the processes again. They just told them that the vaccine is coming, they should take it. And there are some key figures in the community and in the nation who take it to serve as role model. And for them, that one was non-engagement. They also told them that it's the same thing, like immunizing the children with polio, tetanus, and other vaccines. So that limited engagement had impact. One of the impact it had is that majority of them said they will not take the vaccine. Majority. A few of them were indecisive, so they gave conditions that can be summarized like this. If it comes and we are properly educated on it, then we will take it. If the vaccine comes, people take it, nothing happens to them, we will take it. If we are sure that we will take it and nothing will happen to us, then we will take it. Unfortunately, that mistrust was extended to childhood immunization, to the extent that caregivers and mothers didn't want their kids to be immunized again because they are afraid health workers will give them corona vaccine. Here's what a community elder had to say. Even it came to a point where the health workers cannot even go to the houses to give routine immunization. People will not even bring out their children to be immunized because of the corona vaccine. They are afraid that it is the corona vaccine. One thing also that emerged during analysis was the recommendations. They try to give a lot of recommendations. And one of them is that they should be educated properly on the vaccine. And another one was that Africa should also manufacture a vaccine. Please listen to what these participants said. Africa should also set up a company that can manufacture vaccines for its members. Madagascar came out with a herbal cure for COVID-19, but the World Health Organization rejected it because it is from Africa. The God who created us, is it not on the side of Africans? Or the brain or knowledge given to the white? Wasn't it given to Africans? Does it mean that we can only rely on drugs from the white and we cannot manufacture any for them to use? Let me jump to the end of it. African leaders think and come out with their own solution to this disease because it appears it's the same whites manufacturing the cure for the disease again. If Africans get the cure or the vaccine, we will take it. If not, we will not accept. Brief discussion. This was not a study of its kind. Similar studies were conducted in the world and in Africa. And it was interesting to know that they found similar things in Nigeria, Malawi, Ethiopia. But the fact that most of them heard this news from social media tell us that we can use the same social media to promote post attitude toward the vaccine. Also, the fact that this mistrust was extended to childhood immunization warns us that if not properly handled, this can undermine future success of vaccination campaigns should there be another pandemic or an outbreak. In conclusion, information about the COVID-19 vaccine is widespread, which affect COVID-19 vaccine acceptance and can affect the possibility of acceptance of future vaccines if the lessons learned are not well used to correct gaps in the engagement process. To reduce COVID-19 vaccine hesitancy and increase uptake of vaccines, it is important that communities are engaged effectively to empower them to own vaccination programs. Recommendation. Vaccine education should be constant part of health education program. Since this pandemic has revealed that our health system were not really prepared for this, there should be legislation to support constant availability of funds to support engagement and vaccine education. Vaccination campaign message should address communities' concern about safety and efficacy. Communication should be frequent and consistent and be done by qualified health personnel. Health agencies and government institutions responsible for advocacy and education should also have a strong social media presence. And to build public trust, there should be transparency in government processes. And last, African countries will need to devote themselves to building domestic vaccine manufacturing capacity. This will prepare our health system to better respond to future public health emergencies and reduce vaccine hesitancy in Africa. I would like to acknowledge the Royal Society of Tropical Medicine and Hygiene Small Grants Programs who funded this project, and my mentor, Dr. Hilda Abrisiaku, as well as the organizers of the Ecova conference. My reference is, thank you.
Thank you. Thank you, Maulom. So let's have something interesting here. Jane, do you know someone who loves swimming? Ghana, from Ghana.
Okay. Male or female?
Ah, don't know.
I'll start with fire.
No, he's from Nigeria. Emmanuel is from Nigeria, unfortunately. He's a male. Male. Wearing blue. You don't see him. Blue.
Oh, him?
Yeah. And his name is?
From Ghana.
Yeah, from Ghana. His name is Ebelin. Yeah, Ebelin. Do you know Jane?
Yes.
Who's Jane?
Wisdom.
Yeah. Who's Jane? No, no. Oh my God. Oh my God. Oh my God. Oh my God, Ebeline, Jane. How do you do this? Jane.
But you know, I've been
Jane, the famous Jane.
I've been accused of Nigerian, so I'll forgive you. But I'm not Nigerian, but I'm a daughter of Africa.
What's the hobby of Jane? No, Jane. From UNECA. Yes. So what's her hobby?
She settled it.
Yeah. Yeah.
Oh, okay.
Emmanuel. Yeah. Birds told me that you know everyone here. So I was like surprised. Oh my God, Emmanuel knows all the people here. Yeah, why? How comes? So, oh my God, swimming, 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 swimming. From Uganda. You don't know from? No. You can ask someone to help you if you want. Emmanuel, ask someone to help you. Oh!
Because you're wearing this, I thought it's a French.
And why are you wearing this? Ah! Yeah, so the last one, okay? So maybe we can ask Grace. Grace, are you ready? Yeah. So Grace. Oh, that's good. Music and tourism. Oh my God. Do you know someone who loves music and tourism? No, unfortunately. Mba. You have two Mba. Yeah. No, from Cameroon. The one we are like, it's from Côte d'Ivoire. Yeah, Côte d'Ivoire. Danny, come and help. Come So let's have the last one. And maybe we can ask, what's your name? Yeah. Nathaniel, yeah, Nathaniel. Nathaniel, someone who loves watching football. No, no, no. You are so much confident. I don't know. Ah, no, it's not. No, unfortunately. Yeah. Not watching football and tennis ball. Yeah. He's like very, very famous. Everyone knows him. He's like, when we arrived here in Abuja, we can see all the the pancards in the roads saying, "Welcome to Abuja. Here's he's not sitting in this table. No. But he's in this room, but not sitting. But do you know, Danny, that you have a common hobby with Chijotki? Yeah, my brother. Yeah, thank you. So the last presentation. I would like to invite Tesfai Dani. So the title of the presentation, Coronavirus Vaccine Acceptance Rate and Associated Factors Among Pregnant Women Attending Antenatal Care in Public Health Centers of Addis Ababa City Administration, Ethiopia, 2023.
Thank you, the moderator. Good afternoon. I think this is my second presentation, so I'm not expected to explain about myself. So the topic of my presentation will be coronavirus disease acceptance, vaccine acceptance rate, and associated factors among pregnant women attending ANC in Addis Ababa, Ethiopia. So I will go through this outline for my presentation, the background, objective, method, result, conclusion, recommendation. And lastly, I will show you the limitation of the study. So as it is obvious, pregnant women have increased risk and they are susceptible to different diseases due to physiological change, and it's the same for COVID-19. So morbidity and the mortality are higher among pregnant women for COVID also. And pregnant women have more intensive care unit admission, the poor prognosis in relation to COVID-19. They also encounter preterm birth rate, preeclampsia, cesarean section, and prenatal days. So, but vaccine is obvious that it is critical in reversing the morbidity, mortality, and disease burden. The problem is the vaccine hesitancy. The vaccine hesitancy that is evident in the whole population. So the objective of the study is to assess vaccine acceptance rate, the associated factor among pregnant women attending ANC at health centers in Addis Ababa, Ethiopia. So the study was conducted in Addis Ababa health centers. The city administration is divided into 10 sub-cities, having 116 districts and 101 health centers. So we selected 9 public health centers from the available health centers. These are the name of the health centers listed out here. Then we employed institution-based cross-sectional study, and pregnant women residing in the city administration were considered as the source population, and as the study population were selected pregnant women that were attending ANC in the health centers of Addis Ababa city administration. Sorry, what happened? Okay. So we calculated sample size by using single population proportion formula by considering the vaccine acceptance rate of 71%. That was from other paper published before the study was conducted. So we calculated 316 by adding 10% in a response rate. We ended up with 348 sample size. So after selecting 9 health centers, 9 health centers were selected from the available health center in the city administration. Then the sample was proportionally allocated to respective health centers based on the load of ANC they have in the previous months. And all pregnant women who came to the study facility within the study period were included consecutively. So this is the schematic presentation of the sample size. So 9 health centers were selected, namely this, then their load, the client flow, then proportionally allocated to each health center. Then we ended up with 348 sample. These are the variables included under this study. COVID-19 acceptance rate was the dependent variable, and the socio-demographic, knowledge, prevention practice, attitude related to COVID-19 were independent variables. Then data was collected through interviewer administered questionnaire. Mothers were approached in a calm place after they completed their consultation with their provider. The objective of the study was explained, and their participation was totally voluntarily. So the data was collected through, okay, sorry. The data collector were trained for 2 days, and pre-test was conducted in other health centers that were not included in the study. Close supervision was conducted for quality assurance. Data from each respondent were checked for completeness, consistency, and accuracy on daily basis. And data was coded, entered into EP info, then exported to SPSS for further analysis. Descriptive statistics like frequency, table, graph, cross tabulation was generated. Variables that were significant at p-value of less than 0.25 at bivariate analysis were used as a candidate variable for final model. Then the final factor for association were declared at p-value of less than 0.05. So the research protocol was approved, the ethical clearance was obtained, letter of cooperation was written from the city administration. Participation were voluntarily, and the informed verbal consent was obtained from each participant. Confidentiality was strictly adhered. No name were utilized in the data analysis or data collection. So coming to the result, majority of women were within the age group of 26 to 35. Most of them were married, and by education, most of them were diploma and above. And by occupation, majority of them were civil servant or government employees. So when we see history of COVID-19 infection, 30% were infected previously before the study. And about two-thirds or 61.5% of respondents reported that they use mask as a means of prevention. And secondly, they use alcohol-based hand rub for preventing COVID-19. So this is attitude and knowledge related variables. Most or about 80% of mothers believed that they are allergic due to their pregnancy to the COVID-19 vaccine. So as we mentioned, 30% of them had COVID-19 previously. And about two-thirds had friend or family who has been hospitalized previously. About 3/4 do not believe that vaccine reduce infection. These are the other one is the vaccine acceptance rate. The most believe that vaccine decrease infection, and about more than 3/4 or two-thirds believe that vaccine decrease transmission, and about 50% of them believe that totally oppose vaccination at all. So when we calculate the vaccine acceptance rate, it was found to be 58%. 58%. So that means significant number of mothers, about 42%, didn't accept vaccine, COVID vaccination. So when we crossed up vaccine acceptance with having COVID-19, history of COVID-19, 80% of them who had history of COVID-19 accept vaccination, COVID-19 vaccination. So in this study, 58% of mothers do not accept vaccination. So the study was higher actually in comparison to other studies conducted in Ethiopia, like Dabra Bran, Dabra Marcos, which are a bit remote areas compared to Addis. The difference could be availability of alternative medias and the educational status of mother involved in the study. The finding is also inconsistent with a study conducted in other cities of Ethiopia, Gondar, And that the finding is, this finding is lower than the study conducted in the Southwest Ethiopia. The difference may be due to the reason that the study that was previously conducted was during the time where fear of the disease was high at the peak. So the current study actually is lower than the study done in sub-Saharan Africa. It was reported 97% acceptance in Ethiopia, in Nigeria 86, in Uganda 84, in Malawi 82, Burkina Faso 82 something. But this study was conducted through phone survey, phone calling. So it may not represent the real picture in the community. Like it will be biased in terms of selection or response, something like that. That may be the reason for difference. Coming to the factors that affect COVID-19 acceptance rate, mothers who believed that they are allergic to the vaccine due to their pregnancy were less likely to utilize COVID-19 vaccine. They are less likely to utilize. But mothers who believe that vaccine decrease infection were more likely to utilize COVID vaccine. And mother who believe that vaccine prevent COVID infection were more likely to accept COVID vaccination. On the other hand, mother whose age were or older mother were more likely to accept COVID-19 vaccine. This can be maybe usually it is said that the younger population has lower mortality compared to the older one. That may have an impact on the attitude of mother. Mother with secondary and above educational status were more likely to accept COVID vaccination. And in terms of occupation, civil servant or government employer found to be more likely to accept COVID vaccination compared to non-governmental workers. So in conclusion, more than half of pregnant women accepted vaccination, but those who didn't accept were a significant number that may. So the older mothers were more likely to accept COVID vaccine. The government employee and the mother with good educational status were more likely to accept COVID vaccination. So the main factors that influenced COVID-19 vaccination was being allergic to medication due to pregnancy, assuming vaccine as effective treatment for decrease the infection. So for recommendation, health professional should give awareness to pregnant women on safety in the importance of vaccine, because they believe that it is allergic to affect the pregnancy. Awareness creation at public health meeting using mass media is important. Health facility should also integrate health education or health information in the counseling and the health education session. Qualitative studies are recommended to know the attitude and deeply investigate the attitude of mothers. As a limitation, this is an institution-based study. It has its own limitation, so this is not community-based study. Some recall bias may have affected the study. The other one is the study was conducted at time that COVID-19 vaccine were not well known. The information was not available, so there are natural hesitancy. Sometimes people are hesitant to something that is not obviously known. So that may affect the study result. Finally, I would like to thank AFIA Ecova program for supporting and for arranging the opportunity, member who participated in the study, and for study participants. Thank you so much.
Thank you. Thank you, Tesfaye. So before moving, let's continue our game. So, Nyacha, are you ready? Yeah? Some exercises, maybe? No? Yeah. So, she's from Zimbabwe. Yeah, very famous also. She likes running, reading, and the last hobby, I cannot read it. But maybe we will ask after you recognize her or him. Who? Oh, so you are lucky. Yeah, so Nyacha, from the first day, I was telling you that you are lucky. You are lucky. So it's Jane. Jane, what's it?
Oh, hiking also.
Hiking. Oh, running, I'm sharing the same as Jane, running. Yeah, so do you know Jane? Yes? Do you know her well, very well? Can you use your micro, please, just to hear you?
You're messing me up. You have to make my age, this brother of mine. Feel me? You feel music? My brother.
Yeah, but you are proud about it, so.
Very proud, but what is got my age going? Start calculating. I'm missing my market.
You have to do something, Nyacha. Yeah. So, Olivier, c'est ton tour. Oh my God. Je suis sûre que tu vas la reconnaître directement. Oui? Tu m'entends? Je parle en français, tu peux enlever ça. Oui. Donc, un de ses loisirs, c'est le tourisme. C'est une fille. Oui. Elle est belle. Ouais. Elle est belle. D'accord. On reconnaît maintenant le degré de la beauté chez toi. So, tu sais son nom? Tu sais son nom? C'est quoi son nom? Elle est belle, ok, mais autre qu'elle est belle. Elle s'appelle Mba. Mba, ah ouais. Cléopha. Cléopha. Cléopha Mba. Oui. Alors, Cléopha, tu reconnais, do you know, encore que tu parles français, yeah. Tu reconnais Olivier un peu? Qu'est-ce que tu connais à propos de lui? Qu'est-ce qu'il aime? Il aime manger. Comment tu as su ça? Alors, Cléopha, le tourisme. Tu aimes le tourisme? Oui. Donc, c'est quelque chose en commun avec Cléopha. Vous pouvez aller ensemble pour faire le tourisme. Souci. Oh my God. Alors, Cléopha. So, he or she loves traveling also. So there is also a common hobby, yeah, with you. Yeah.
And I guess it's a lady.
Not sure.
Okay. But I think, I don't know her name. The lady from Breakthrough Action, Nigeria.
From Nigeria?
Yes.
Do you love traveling? Really? And you are from Nigeria? And your name is? Oh, bravo. Yeah, so the last person. So let's ask, any volunteer? Any volunteer? No? Are you afraid? John? Yeah, John. So, John. He loves golf and pub quiz.
And what?
Pub quiz.
Oh.
Yeah. It's interesting, yeah?
Interesting, yeah.
Yeah.
It's a he.
I don't know.
You don't
Try. And then we
not,
no, he's not here. Yeah. So
James.
James, no.
Nyasha. Asha.
Nyasha, yes. So do you play golf, Nyasha?
Yeah, he does.
Ah, okay. What do you know also about Nyasha?
What do I know? Nyasha.
Yeah. You know a lot, I mean.
No, not too much.
Not too much?
Yeah. Apart from he's my neighbor and
Yeah.
we're in several committees.
Yes.
Yeah. So
And
no, nothing. He likes golf.
Nyasha, do you know John? How much do you know him? Please use your micro. Cannot hear you.
And the fact that he is from Botswana, my neighbor, from the University of Botswana, and we are together in some committees and are founding fathers of the East Central Southern Africa College of Public Health Physicians.
And what's his hobby?
Well,
Yeah.
I don't know.
No, you have to tell me something about John's hobby.
About?
John's hobby.
No, I have no idea.
You have no idea?
Yeah.
Try.
Yes. Well,
Cooking?
yeah, maybe teaching. Yeah, I think he's in the university, maybe teaching.
Teaching? Is teaching your hobby? Huh? Yeah, so let's move. Ibrahima is still online? Still online. Ibrahima, so Tu es toujours en ligne avec nous, oui? Donc, Ibrahima, je te pose la question après l'avoir posée en anglais, d'accord? Mais tu es avec nous toujours. So, I have first, thank you for the presentations and thank you for the good results. But it's not always like to conduct a study and then to see the results and then to write the recommendation. It's always like this, but the most important is how our results will be reflected, how our results will be, let's say, how we can concretize our results. Yeah. So God forbid, imagine that we are facing now a new pandemic. Yeah. And you are the Ministry of Health in your country. And you have to implement the procedures to counter the pandemic. From the lessons learned from COVID experiences, how do you approach this based on your study, based on the results, based on the recommendation? You have to be efficient, yeah, and to react as soon as possible, to be efficient, to be straightforward, so what can you do? This is the first question. And the second question, so you conducted your study, yeah, and you compiled a lot of information from the stakeholders, from the population where you are living. So do you think that your country is ready to face a new pandemic? Also, I'm saying God forbid, but do you think that your country is ready and you learned from COVID experience? Okay. Donc, allow me just to translate for Ibrahima. Ibrahima, tu es toujours avec nous?
Oui, je suis là. Hein.
Ibrahima?
Vous m'entendez?
Oui, oui. Tu m'entends?
Oui, je vous entends parfaitement.
Donc, je pose deux questions. D'accord?
Oui, allez-y.
La première question, imagine que tu es en face... Oui, tu m'entends?
Oui, je vous entends, allez-y.
Oui. Donc, imagine que tu es en face d'une nouvelle pandémie, d'accord? Et tu es le ministre de Santé dans ton pays. Et c'est à toi de prendre les décisions, les procédures pour faire face à cette pandémie. Alors, qu'est-ce que tu fais? Surtout si tu te bases sur l'étude que tu as fait. Donc, quelles sont les procédures? Comment tu fais et surtout pour agir, pour prendre des décisions efficientes, pour avoir une bonne stratégie pour pouvoir agir contre cette pandémie. Et la deuxième question, est-ce que tu penses que ton pays est prêt pour agir contre une nouvelle pandémie? Est-ce que vous avez appris des leçons de la pandémie de Covid? Donc, est-ce que vous êtes prêt, oui ou non? Je parle de ton pays. Donc, si tu es prêt à répondre, je peux prendre tes réponses maintenant. Sinon, je peux entendre les autres collègues, puis je passe chez toi.
Ok, je peux réagir tout de suite. Hein?
Tu réponds maintenant?
Oui, oui, oui.
D'accord, on vous entend.
Ok. Donc, par rapport à la première question, qui porte sur le fait que si demain je suis le ministre de la Santé et qu'il y a une nouvelle pandémie, comment je vais prendre les décisions et surtout comment je vais me baser sur les résultats de notre étude. Bon, je rappelle que durant la période de la pandémie, on a fait plusieurs études. J'avais fait le choix de choisir celle-ci qui porte sur la vaccination. Mais par exemple, à la première question sur s'il y a une campagne de vaccination et que on se rend compte quand même, avant même la mise en œuvre de la campagne de vaccination, moi, ce que je ferais d'abord, c'est de capitaliser les études antérieures, y compris celle-ci. Parce que cette étude-là nous a montré que le processus de décision de la personne de se faire vacciner ou non était un processus complexe qui n'était pas lié directement à un point ou bien une absence d'information ou pas. Mais par exemple, quand on prend le cas du Sénégal, l'étude a montré que l'influence sociale, c'est-à-dire que ce que les parents pensent, ce que la famille pense, ce que ton entourage pense autour de la vaccination, c'était le plus déterminant. Maintenant, l'étude a montré également qu'on ne pouvait pas agir directement sur ce point-là. Mais en améliorant la perception sur la vaccination, sur l'efficacité de la vaccin, la perception sur les risques, à travers des campagnes de communication ciblées, on peut faire en sorte que ces personnes-là, en tout cas, on peut faire en sorte que l'entourage de la personne ait plus d'informations sur le vaccin, sur l'acceptabilité du vaccin, et ce qui fait qu'en fait, la personne pourrait avoir tendance à plus, en tout cas, adopter la vaccination que les autres. Donc, en fait, si demain je serai le ministre de la Santé et qu'il y a une nouvelle pandémie, ce que je vais faire, c'est de puiser d'abord sur ces recherches, pas seulement sur la mienne, mais sur toutes les recherches qui traitent de la question pour pouvoir rapidement agir sur la vaccination ou bien sur les mesures.
Et ton pays est prêt pour une nouvelle pandémie?
Oui, je pense que globalement, le Sénégal a beaucoup appris sur la COVID-19 parce que nous, au sein de l'université, au sein de l'Institut de santé et de développement, qui est vraiment l'Institut de santé publique phare au Sénégal, on avait mis en place un observatoire. C'est-à-dire que durant toute la pandémie, dès que le gouvernement mettait en place des mesures, on évaluait cette mesure-là. Par exemple, les premières mesures qui étaient prises, c'était sur les mesures d'interdiction, de confinement, ainsi de suite. On a tout de suite évalué ce que la population en pensait. Et à travers des lettres ouvertes ou bien des notes politiques, on avait échangé avec les responsables, y compris le ministre de la Santé, pour l'orienter en tout cas sur ces mesures-là. Il y avait des mesures qui avaient été très mal perçues, comme la fermeture des lieux. Et là, automatiquement, en fait, rapidement, on a vu que quand même, les autorités nous avaient donné oreille, en tout cas pour pouvoir adopter ces. Donc, pas mal de.
Mais merci Ibrahima. Juste pour laisser le temps aux autres collègues de répondre aux questions. Tu peux rester avec nous si tu le peux. Sinon, merci beaucoup. Donc, yeah, so we will move. Are you ready? Who would like to start? Yeah.
So, assuming there is a new pandemic now, if it is a new disease, like the way COVID was new to us,
My role at the Ministry of Health will be to make sure that there's proper communication first. I would like the population to know that we do not know the mode of transmission yet. We do not know a lot of things about the disease, but there are things they can do to be safe for now. Maybe they should be washing their hands. They should wear nose masks until all this is figured out. And in the meantime, there should be the regional offices should help the district level to have a public health emergency management team so that at least they will be tracing the cases, gathering the data while everything is made out. And my country is not ready. The fact is that lessons learned from COVID-19 were just for a time. We quickly forgot them. Even hand washing is no longer people's concern because there's no COVID. Recently, we had some few cases of cholera. So, and for even COVID-19 vaccines, we still rely on funds before we start. So even funds to be ready for the health system and the population to be prepared to handle a pandemic is not there.
Thank you for the question. The questions are a bit broad, not easy to answer in short time, but according to if new pandemic come, maybe based on my study, the factors that affect COVID-19 vaccine acceptance were related with the attitude and the lack of knowledge. I can categorize them into two. So to counterfight these problems, education is critical for me. Education and the involvement of the recipient or the community client, we can say, is critical. So I recommend education, clarifying information, clarifying misinformations are so critical based on my study. These are important. The second question, the broader question, is your country ready? This is so difficult, but it is natural in most countries in Africa that documentation and archiving on the process we pass through is not common. The same is true in our country. So no documentation, no way of learning from the previous pandemic. So this is a problem, but we have strong, we can say strong institutions that was established to work on public health emergency. The institute I'm working with has Ethiopian Public Health Institute has the FAME service is a biggest wing. So it has established based on the emergencies, like we have free toll call line, for example, that was established during COVID-19. The COC center or the center for this pandemic is active now. It is active, but there are some positive issues, but there are some problem like documentation, transferring that to other, and retaining the professionals in the institute, in the country. These are some problems. So for me, it is 50-50. There are problems, there are also opportunities. Thank you.
OK, merci beaucoup. Donc, pour la première question, je dirais que si j'étais dans une position de prise de décision et en fonction de ce qu'on a appris sur la COVID-19, je mettrais l'accent sur deux points principaux. Donc, améliorer la coordination de la réponse des activités, de la mise en place des activités de réponse sur le terrain. Parce qu'il faut dire que le manque de coordination ou la coordination dispersée pendant la réponse de cette COVID nous a fait perdre énormément de temps et nous a fait on a eu une difficulté à optimiser les ressources qui étaient disponibles, ce qui a fait que c'est un peu allé dans tous les sens. Donc, si on a une bonne coordination, je pense qu'on pourra avoir un bon résultat en termes de capitalisation et optimisation des ressources. Et le deuxième point, c'est de mettre l'accent sur la communication et l'engagement communautaire, parce qu'il faudrait mettre la communauté au centre de la lutte contre les épidémies et les pandémies, je pense. Et puis, ce sera plus facile d'entrer dans la population, de lutter contre la fausse information ou les infodémies afin d'agir. Concernant la deuxième question, est-ce que mon pays est prêt? Je vais dire comme les autres, non. Mais je pense qu'on a beaucoup appris. On a beaucoup appris en termes de procédures, en termes de guides. On a gagné en infrastructure. On a gagné en renforcement de capacité. Mais je pense que dire qu'on est prêt sans connaître qui est l'ennemi, ça va être c'est très osé, optimiste. Mais je pense qu'on a gagné beaucoup, mais je ne pourrais pas dire qu'on est prêt pour une prochaine pandémie. Merci.
D'accord. Yeah, thank you. So any questions from colleagues here? So maybe we have 5 minutes if someone would like to ask any questions, any clarification. Yeah, please, Nyacha.
Right, thank you for the excellent presentations on the studies. So mine is more of food for thought. I'm sure it is clear in all our contexts that the COVID-19 pandemic response was taken over by politicians instead of multidisciplinary public health practitioners. And a lot of things happened that were not supposed to happen the way they did if it had been left to the experts in those areas. So I don't know if there are any thoughts about advocacy or generation of evidence that if we should be in a similar situation, how do we get our politicians to keep in their lane and leave these things to people who know about them? Thank you.
So do you address your questions to any specific?
No, this is to everyone.
Yeah.
Everyone in the room.
Yeah. Okay. Who can share insights, thoughts about this? Yeah, please, Jane.
Thank you, Komanyash. I agree with you, and I want to also maybe offer a little bit of a different perspective. Do you really need to, when it's a pandemic like that, do you need the government to shy away, or rather it's a collaborative approach? And I think maybe the question we should be asking ourselves is, with the evidence that is emanating from research, how do we ensure that we can influence the government, and so that when we future pandemics comes, then we are in a better we have a better understanding of how this can be done in a collaborative and I think integrated approach. And I think vaccine hesitance was there before even COVID. This is some of the things that he's saying, and it will probably be there with us, as long as we are alive. So the question is, how do you minimize that? When it's an urgent situation, I was privy to be sitting in the meetings. In fact, we were the secretariat during the COVID, when in the meeting there will always be, and there were like 10, 4 meetings, whatever, how many meetings in a day, and they would go midnight, name it. But if Strive Masiwa was the special envoy for COVID, Afrex Bank, the president, our executive secretary there was Vera, would have Africa CDC, then was John. Who else? And then of course we brought in partners as needed. But what you saw there, and then of course even these aspects of having the heads of states coming with the 60% of vaccines, we were all influencing behind the scenes. But what you saw there, I don't think government could do it by itself, neither also the expertise or the private sector could do it by themselves. We saw more of a collaborative approach. we didn't have information, but as information and evidence came in, you saw, our leaders starting to make the right decisions. You saw them, those who did not have money, we were facilitating with the World Bank for member countries to get, money so that they could have vaccines. Even when the vaccines were there, big countries like even Nigeria, I don't want to say this, but we had orders, because then we actually would call member states by member states, 1, 2, 3, to say, okay, what do you need? Do you need money? Even Strive Masiwa, I remember facilitating for Zimbabwe to get vaccines because of the issue that we're not getting money, and then eventually we got money as a grant and all those kind of things. My question, without necessarily going into details, is just to say, I don't know whether you need the government in the place, but you need the government to be informed with the right information so that they can play their respective part in making an enabling environment, because they are the government, they have the capacity and the machinery when in pandemics like that. At the same time, the professionals also needs to be there to inform and do their part, among others. So I would rather, advocate for a collaborative approach, so to say. Over.
Yeah, thank you, Jane. Thank you. Yes, please, Emmanuel.
Thank you very much for your contributions and for your questions, sir. And I think it resonates with me, because when there was Ebola, Nigeria had a template. We implemented a template that was public health focused. And to the surprise of the world, Ebola didn't overwhelm Nigeria as it were. But when COVID-19 came, the politicians took the forefront. And then we had all these stories that we can tell. Therefore, I think that going forward, it's always good for people to be on their lane. Then we can have collaboration, partnership, and all that. But when politicians, because they have the money or they have access to the authorities, and then the expertise becomes a second fiddle, that's where the first difficulties come. And I think that going for advocacy is evidence-based advocacy. Sir, as the president, as the minister, these are what we know: public health, science. Then you can come with your policy positions that are based on what we inform you. I think this is the way we can drive change going forward. Thank you very much.
Thank you, Emmanuel. So maybe the last person, please, if you would like to add something. No? Yeah. Yeah, please, John.
Yeah. I think these food for thoughts are all very important.
Yes.
It comes to the issue of what are we doing as a continent in terms of emergency preparedness and security, health security in our various countries. And as the speakers have spoken, the issue is we have to learn lessons from this COVID-19 and put systems in place. I told you when I was making presentation that Ghana, we are still collecting COVID-19 levy. It was instituted and government has not removed it, even though COVID-19 has been declared as not a recent, but we are still collecting the money. People are advocating that, look, can you change this into a health levy and use this money to prepare and put the systems in place? Like my friend is saying, he's not saying that politicians should come in, but everybody should know, like they have all collaborated. If the system is in place, like he said, there was a template for Ebola. If the system is in place, it's a template. When it hits, everybody knows what to do. But if one sector holds the money, and that's where the power is, they can direct anyhow, where you should go. And they made promises to health workers that you are going to get these allowances. Or if you do ABC, they do it, the money is not coming, and people are fatigued, are discouraged. So systems need to be put in place and prepare for future pandemics.
Yes, right. Yeah, thank you for this insightful sessions. Thank you, colleagues. Thank you, everyone, for your thoughts and for sharing your insight regarding this topic. Maybe, Danny, can you give us some instruction for the next? So We are on time, yeah? It's 2:30. Yeah. Lunch.
Yes. Thank you very much. And can we put our hands together for them? Yeah. Great job. I thank you so much, Rua and the team. Today I've been really relaxed. I don't even know. Yes, because I know we are all in good hands. So at this point, the program as we have it, looks like the time is not really very good. Time management is not really very good. Not because the time managers didn't manage the time well, but because of the way we started it. Didn't really start early. So at this point, I will urge us to go for some lunch and re-energize ourselves and come back for the last session. It's 2:33 or 34 there about now. So let's aim to do this in the next 45 minutes. Please, let's try our best so that we can close in time and perhaps go downtown and find some one or two things to leave Nigeria with. Thank you so much. 30, so that's good. And so as we try to wrap up today's agenda and possibly the Ecova conference, we are now going to do our final but one session. And at this point, I would like to welcome Professor James Akazili to help us with the next session. Let's put our hands together for Prof.
Thank you very much, Danny. There's a saying that it's not how you start, but how you end. So if we start well, then let's end well. I know after lunch it's not always easy, but when we start with a lot of energy, and this is the last session. So let's end with the same energy. When you run a race and you start. Oh, okay. Yes. So when you run a race and you start 100 meters and I get to the end, if you don't start energy, then what you have done in the beginning goes to waste. So let's have that energy to finish hard. Thank you. So we'll have a short presentation and then a panel discussion. So the presentation we'll have will be by Dr. Jane Kuroja. I hope I got the name right. Karoja. Karonga. That's my husband. I don't know. I hope you understand what I say, our husband, because Mugabe married from Ghana and the country was doing well. When the woman died, the country started doing badly. So we have a presentation by Jane, 20 minutes or less. And after that, we will have a panel discussion. So I'll call on Jane to have her presentation. Thank you very much.
Good afternoon. Everybody's still managing lunch. I think I need to move past this slide. I promise the PowerPoint is not for this Zimbabwe dialogue. He told me to change my presentation today, so I was working on, then I forgot to change this part. But some of the slides, of course, comes from that as well. So I think everybody knows my name by now. I'm Jane Karonga. I'm an economist for ECA, Economic Commission for Africa in Addis. My presentation is on the health and economic growth nexus. And I want to start off by giving us sort of like an umbrella, picture in terms of where we are on the continent, some of the guiding frameworks on the continent, and how they're scaling down, coming from continental level, regional level, and then of course national level, as the member states, the African countries. And within an economy, of course, there are different sectors. The health is part of that, so that at least maybe we can look at this in a more holistic manner. And I think, as we have all said, that the purpose of this research is, of course, to inform policy making and implementation, so that we'll be prepared for future pandemics, but also to make sure that we strengthen our health system, among others. So at the continental level, of course, we have the Agenda 2063. That is what it's dubbed the Africa we want, where it talks about, issues of peace and security, issues of health, issues of industrialization, name it. That's the main framework that at the continental level, it's guiding the continent. How the AU works is that you have the AU Commission in Addis Ababa. That's the political muscle of the continent. They discuss everything, and they're guided by the Agenda 2063. And they meet twice every year, in January, end of January into February, where they discuss issues in terms of progress of what kind of recommendation they would have, declaration they would have made, where are the issues. And then in June, at any member states, if they invite them or they go back to Addis. But in between, they can also call for extraordinary, heads of state summit if there are issues that are going. And then, of course, that's at the continental level. You have also your regional commissions. That's like here in West Africa, you have ECOWAS. In Africa, in Southern Africa, SADC. North, you have ONU, among others. I'm just trying to say this so that we're all in the context. And then among that, of course, global world, you have the SDG. I work for UN, so I have to mention that because that's what we do. We try to work towards achieving the SDGs, Sustainable Development Agenda. You have under the Agenda 2063, you have different flagship agendas, and one of them is the African Continental Free Trade Area. They have the secretariat in Ghana now, and I happen to be working with one of who is now contesting as a independent president. I don't know whether he's going to make it, but we were working on this AFCFTA. I remember Alan going to one member states after another, knocking before the heads of states could adopt it in 2012. You have the PIDA, that's the infrastructure framework. The reason why I'm saying this is because I'm going to relate to all this in my presentation. And then, of course, you have the SATAM, which is the single. We are talking of free movement. In AFCFTA, we're talking of free movement of goods, services, and business people. The SATAM is free movement in the air. That's the single African transport market, SATAM. You have the 3DI. It talks about industrialization, and it talks about what do you call special economic zones. The CAPS is the same thing on agriculture. And then, of course, you have the minimum integration for industrialization, among others. I just want to put that in context as we talk about the health, and you see how it all fits, and that's at the continental level. Wow. Okay. Okay. Can you do the clicking for me? Because somehow. Okay. All right. Now we are going. Okay. And because we work for ECA, ECA is the, the UN, the way it's structured. You have the HQ in New York,
and we have the Regional Economic Commission for each continent. So for Africa, the Regional Economic Commission for Africa is of course ECA, the Economic Commission for Africa. You have Economic Commission for Europe, Economic Commission for Latin America, and our mandate is basically to support economic and social development for that continent, for in our case is of course Africa, and we do this in 5 strategic areas. We advocate for policy recommendation. We formulate. We like to think of ourselves as a think tank, and then of course we integrate some of our policies into regional and national frameworks. Okay, now coming to the matter of this meeting, we have heard, I think, from our conversation that, you know, coming to the topic of this this meeting, that is, of course, there is vaccine hesitance. It was there before. We have heard that we need to mitigate issues of misinformation. We have had issues or recommendations of targeted education, sensitizing of the population, effective communication. That vaccine hesitance, you know, is affected by human behavior, so it's a complex. You know, we need to move beyond the generic recommendations to be targeted. The issues of data, the issues of course, research, and we are talking of sustainability. And we are saying, okay, we are put at the back of the queue, but then what do we do as a continent? And there's also a recommendation for vaccines, you know, production and medicines in general. And I carry good news because, you know, the heads of states during the COVID, they came up with a decision that 60% of vaccines that are consumed on the continent must be produced within the continent, and they are doing, you know, work towards that, and you see it in my presentation. But before we go there, why is health so important in terms of economic growth? We know that it has impact on labor productivity. If you're not healthy, of course, you cannot work. You know, they've reduced, you know, and if you're healthy, of course, you know, there's the issues of absenteeism, name it, among others. But according to ECA, because like I said, most of our work, we are a think tank, so most of our research in health and economic growth, these are some of the findings that we came up with, that there is a considerable link between health outcomes and economic growth. And some of the indicators that are influenced by that is, of course, your child expectancy rate at birth, child mortality, maternal and mortality cases, all that are affected by GATP. So there's a nexus. And also, according to WHO, investing an additional average of $21 to 30, from $21 to 36, it influences per capita over 5 years in Africa. You can save lives. So of course you save lives. When you have lives, of course, you know, people have income. When they work, they have income. It contributes to GDP, among others. And also economic gains in 5 years can be up to 100 billion from additional health investments in the economy. So so understanding that there is a link, and of course, you know, what happened between COVID and economic growth, most of the African countries, their GDP went down, but that's also globally because they could not trade, they could not produce. The manufacturing companies were shut down. And then, as we all know, that, you know, disease knows boundaries. So everybody, you know, were keeping to themselves so that, you know, you either stay alive, or if you have it, you know, you don't pass it on. And that had, of course, impact on the GDP, our gross domestic product, among others. And so with that understanding that there's a link between health and economic growth, I think what I'm asking all of us to look this in a holistic manner, so that when we address these issues, we also look at what are the linkages with other sectors, but also the economy as a large. So when we're looking at the prevailing macroeconomic status within the continent, we know that there is public crisis that is ongoing, the lingering effects of the COVID-19, the Ukraine and Russia war, the climate, threats that are happening. All this is constraining the physical space that most of our government have, because there is competing interests, right? If the president or the minister of finance, you have to think of, okay, how do I mitigate the situation in terms of the climate issues in Zimbabwe, just coming from drought. And now we had rains, and some of those rains that came out, I was one of the people who were affected. They took off the roof of my chicken run, among others, but it happens to all of us, Ukraine war, then, of course, the impact is on food high prices and oil and all, among others, even bread. And I was like, oh, we have so much land, but this is the effects of Ukraine and Russia war, among others. The countries, because, in response to COVID, they had to borrow, and they are now, being affected by high government debts and servicing those debts. So those are lingering effects of COVID that is still ongoing. We have also a huge debate of the current status of who we are as countries and as a region vis-a-vis Agenda 2063, which is the SDGs, or the Agenda 2063 that is at AU level. Most of the GDP in our countries, like I said, they've declined from in 2023 it was 2.8, and now it is expected to be 3.5 in 2024. It's increasing as the economies are. You want me to? Oh, okay. As the economies are, getting back to their self, recovering from COVID, among others, and it will be expected to be 2.1 in 2025. But like I said, most of the countries, and this is not new only to Africa, but the rest of the world, they responded to COVID by borrowing. So now we are suffering from high African debt in most of our African countries. So in general, our debt increased to about by 183% since 2010 rather, and that's roughly 4 times higher than its growth rate of GDP in dollar terms. And in terms of we're talking about implementation recommendations, they need to be implemented in tax finance, and we're talking about the financing gap between where we are in Africa and to reach the SDG. It is estimated to be about 200 billion to 1.3 trillion. So when we talk about how our government sometimes are not able to meet the health expenditures, you can understand where it's coming from. The economy as in general, there are high debts, they have to service those debts. In most of our countries, I think about 37 of them, they are considered in debt distress, or they're actually going through that. Okay. And this is just a pictorial picture of what I've said in terms of debt as a percentage of the GDP. And you can see here where most of our countries are, because I didn't disaggregate it to countries, but you can see it's in regions where Southern Africa, Zimbabwe, where we are is, and that's in orange. You can see it's almost relatively the same at about -0.4 for Zimbabwe, for Southern Africa, where Zimbabwe is part of, and you can see also for other regions. So what does it entail, this in terms of our health sector, and coming specifically to the vaccines? And as I've said, when heads of states make a decision to say now 60% of vaccines must be produced on the continent, it means that it has to be translated into the countries, because they're the one who implement. But then you go to the countries, this is the physical space of where they're operating from, high government debts, competing objectives because of various issues that every country is facing, and political interest also. Most of our countries, like I've said, is debt to vulnerability. Their debt to GDP ratio is about 64%. This means they are constrained, and African countries surpass the number of African countries that surpass WHO recommended threshold of out-of-pocket health spending. It's about 37%, 37 countries actually out of 45 because of data. So you can see that it's high out of expenditure. Most of it can actually push a household into poverty. Imagine if it's one household and the father or whoever mother is working, and you have to pay high out of pocket, and most of our household will actually go into poverty because of that, because then there's just no money. And then the government expenditure on health in all but 2 countries is less than 5% of the GDP as per the declaration. So you see why these are situations that most of our governments are operating from. And it's translating, of course, to the health outcomes and even the weak health systems on the continent. So when we talk of a continent in terms of the health sector in particular, so to speak, I already mentioned that there is a nexus between health and economic growth. You need healthy people so that they can produce. And of course, it will curtail absenteeism. And if you are healthy, you can pursue your dreams, but also you can earn income. Income will contribute to the GDP. So what does the continent entails? We already know about the high disease burden of 25%. And while we produce, if it's pharmaceutical, it's about 2% of what we are consuming. This vaccine is 1%, which means 99% we import vaccines on the continent. So there's that mismatch of demand and supply. You have a population of 1.4 billion, and we only produce 1% of our vaccine that we consume. It's not sustainable, and we know what it entails when we in issues of pandemic where we hoard and issues of equity comes into question. I've already talked about this the landscape of the health sector in terms of poor quality medicines, because when you import, you cannot control the quality sometimes, or sometimes they expire on the way. Supply insecurity, stock out. Basically, you're importing a lot. Of course, medicine consume about 45 to 60% of national health budgets. So if the Minister of Health get a budget, 45 to 60% goes to health budget. Again, it takes away from other things that the ministry has to undertake. Lost productivity. If you are sick, of course, you cannot work, among others, and that translates to reduced income, but also GDP. Then I've already talked about the out of pocket, which is high. 70 to 90% of household spending is spent on medicines and products. That's unsustainable. And then, of course, the use of smaller economy. We have had some countries, they are very small, and it makes it, they don't have the bargaining power, so they import. They are basically at the, it becomes sort of like a seller's market rather than a buyer's market. Okay. But also from the research, you can turn those challenges into opportunities. Africa, like I said, it imports about 75%, and it's totaling about 14.5 billion a year. So if you are importing, that means you're not manufacturing. When you are manufacturing and then you can export out, to translate that, it's about 60 million jobs that we are missing out. And we need jobs. Our African population, mostly youth, they don't have jobs. So if you translate that, instead of importing, you export, rather you manufacture, then you create jobs, among others. And Africa healthcare sector is estimated to make about 14% of all business opportunities, only second to North America, which is about 21%. So there you go. And then here, the last figure here, just talking about the health financing gap. If you look at that, when there's a financing gap, then also, again, it's an opportunity for private sector to come in and fill the gap. You can see that these challenges or tend to opportunities are enormous, and most of our member countries, they cannot do it by themselves. So you need the private sector to come in also and play their role, because the cake or the challenges of this, is big. You have the private sector doing their part, the public sector doing their part, and partnership is also needed. Here is just a graph, again, a replication of what I've said, so I'll skip. Here, we are trying to say what are the lessons from COVID. I don't know why it's not going down, but basically here you can see that, looking again at the data, general countries with higher disease burden also have lower GDP per capita. You see where that relationship is coming in again. And look at some of our countries here. I don't know whether this pointer is working, but you can see that here, this is daily per thousand, and then this is the GDP. And look at the countries here that is high disease burden, and look at their GDP is quite very low. So there's a correlation there between disease burden and GDP. Okay. Here again, if you look at the what the data is also showing us is that most of the island countries, the North African countries, tend to have more resources and lower dialysis than other countries that have on the continent. So you see that the more you have, you have your high GDP, the less disease burden you have, and the opposite is true as well. Okay. Okay, and let's see of what is happening to other regions. So compared to other regions, see in other regions, the non-regional countries that have experienced large outbreak of COVID have also high availability of skilled labor. Actually, there was another slide before. I don't know where it is, but here we are talking of skilled, skilled workforce. The more you have skilled workforce here, you then see that they were, they experienced, what does he say? Non-regional countries that have experienced large outbreaks of COVID-19 have higher availability of skilled workforce. Okay, so this one is just talking about the skilled workforce, but there was one that was, I think I didn't put it, there was one that was talking about also that you have higher GDP and also high skilled workforce, but that's, I have the wrong one, but I can skip on this one. So we are coming here to now vaccines as a business opportunity. I spoke earlier on to say that, we already have a declaration at the head of state that we need to manufacture on the continent. We already know what happened to, was it Aspen during the COVID when they finally got, the technology transfer from Johnson & Johnson and, all the drama that comes onto it. But we want to avoid those kind of, I guess, as my brother says, sometimes political interference that doesn't make sometimes a business case. But so how do we look at vaccines as a business opportunity? Because like I said, the government sector, besides you don't want the government manufacturing the vaccines anyway, they should be, their job is to make an enabling environment for private sector to thrive. So the private sector has to come in and we have to understand that, we need to change our thinking to say if healthcare is an investment, and we should sell it so that we understand that when private sector comes in, they're looking there as an investment, but of course it needs to be a little bit of a mixed basket because also private sector, they're all about profits. So if you don't manage them, then you have what happens to the vulnerable people, among others. So you need that mixed basket, so to speak. So Africa represents about 43% of the global vaccine market that's data in 2018. And the supply security issues persist. 32% of vaccines having fewer than about 4 suppliers, it doesn't make sense. 63 of those 2 or fewer pre-qualified products. Again, you see what are the issues are. So if you look at this, you can say, okay, fine, we have a huge problem, but you can look at that this is an opportunity for private sector to come in and fill the gap, isn't it? You have issues of demographic dividend. We have issues of urbanization. We have this is the only continent where countries are moving to be middle income countries where there's a lot of untapped resources. So all these things, of course, then you have the double burden of disease among others. So these are all things that you say, okay, fine. There's a declaration here, there's a political will. If somebody says there's a political will, and now how do you go in and and take advantage of the situation? Countries like Rwanda, for example, the government is quite proactive. Now we know that there is a vaccine manufacturing company that is happening there. We already have Aspen in South Africa. It just needs a little bit of support. North Africa, they have also some activity going on, Morocco, among others. I don't know whether I put a slide here, but there's a slide that we did a landscaping research on the continent. So who is who producing what? But I think, I don't think I have it out. It would have been good to show what is on the continent, but anyway, next time. And also some of the research that came out from the initiative that we're initiating in ECA and now is transitioning to the Africa CDC on food procurement. Some of the outcomes in terms of the local production and food procurement. You see, in Ethiopia, for example, food procurement initiative saved up to about 22%, which translates to 550 million procurement budget when you do food procurement. SADC, the same thing in terms of savings, among others. But another interesting part was in Kenya, for example, in terms of local production, local pharmaceutical products were 30% cheaper than imports and higher availability, of course, when it's being produced on the continent. So I guess the point what I'm trying to push forward is in terms of, vaccines or pharmaceutical as a business, it makes sense. You have on the demand side, the population now, which is one single market, like I talked about in terms of the AFCFTA. And then, and so then the manufacturer or the private sector can see that if I produce for Ghana, for example, then it can go for the rest of the continent, among others. And we have what other countries are doing and what are the outcomes, for example, what is happening in Kenya. Uh-oh. Okay, we can skip this one because I've already talked about in terms of reliance on importation, among others. So some of the recommendations that we have been pushing at the continental level, because in Addis, we like to think of ourselves, like I said, as one of the think tank for the continent, and you have African Union Commission, they have the political muscle, and then of course you have the African Development Bank or Afrexim Bank, they have the financial muscle. So some of the recommendations that we have been pushing on the continent to the heads of states or through our workshops or when we have meetings within countries, what are we saying in terms of the health and economic nexus, and what are the member states they need to do, including the private sector. So I spoke earlier on when I talked about the African Continental Free Trade Area, where we are talking of free movement of goods and services. And we are saying that, and it comes with, it's a framework, so it comes with different protocols. So one of the protocols that it has is what we call rules of origin. Rules of origin is basically made in Africa in terms of what constitutes made in Africa, good in Africa, or pharmaceutical or vaccine in Africa. It means that most of the inputs, or if there is a waiver, they must come from the continent so that we can kickstart industrialization. Otherwise, we open up this market for other, countries to come in and doesn't benefit African people. So implementation of that, the AFCFTA, means that we have vaccines that are produced on the continent. And of course, as a people, as consumers, we need also to have change of mindset, because we think that things that are produced out of the country, out of the continent, are better than inside the continent. So, but implementation of the AFCFTA, which means we can kickstart industrialization, we can have jobs, but we can have availability of our pharmaceuticals, including vaccines, on the continent, is things that we need to do. And implementation, of course, can happen only at the country level, and also at continental level. Because most of the issues that the private sector have been talking about is also the lack of harmonization of regulatory policies. And the heads of states, again, through AUC, have established what they call African Medicine Agency, and it's now housed in Rwanda, which is basically going to bring in the harmonization of regulatory policies so that when the private sector produces, it doesn't have to move from one country to another registering, but rather register in one country, and that's enough for the rest of the continent, because they are following the standards, protocol standards that will be then be agreed upon in the African Continental Free Trade Area. And then there's the issue of comparative advantage that comes when each country is focusing on things that they do best. Because you agree with me that the production of vaccines or medicines is a very complex affair, and so every country will focus on what they need to do best. So it can be a value chain approach. So other countries can learn to plug it into the value chain, whether some will do the tail end in terms of packaging, some will do research, some will be the skills, some will be doing the actual production. And then because there's, with free trade, it comes, the AFCFTA comes with free movement of goods and business people. So your education is now recognized. If you're a doctor in Nigeria, you can be accredited in Egypt, for example, because that process will allow you to do that recognition of education skills, among others. And then with that also technological innovation comes in. So those are the benefits. That's why we are saying member states they've already agreed to it. They've ratified. When heads of states agree on a agenda like that, like the AFCFTA, they have to rectify means that they go back to their countries and look at their legal system and what does it tell on a protocol of free movement, protocol on trading goods or services. Then they have to change the rules within the country so that they can uptake and be able to implement that framework. So they've already ratified it. And now at the Secretariat, which is ASO Secretariat in Ghana, they're doing what they call a pilot initiative where member countries, they are handle them, because the business people sometimes we talk about this framework, they don't know what it entails. So they're actually going to the person on the ground to say, okay, you are producing yogurt here in Nigeria and you want to import that to Ethiopia. What does it do? Ethiopia is ratified. Okay. And, so what is the best way to go in terms of transportation? They'll help them and just handle them. And those kind of deals are happening. And there's the trade fair that they are doing. So also to make sure that, the African private sector can exhibit their products and understand what is there. There's a portal that comes with it, and I'll talk about the operating framework of the AFCFTA. Establishing a pool procurement. A pool procurement, as we all know, that, some of our smaller countries, which, have no bargaining power, but if now they, order their goods, include that with Nigeria or Ethiopia, you can manage the bargaining power that you're going to do. And so then, of course, it comes in of access, increased access and affordability. But also more importantly is now it gives an indication, it shapes the market to the private sector. Said, oh, if I produce my Tylenol, now I have an order that is coming from 10 African countries that is guaranteed, then it gives the incentives and the production will kickstart as well. So that's some of the recommendations we are asking member states to implement. And also, like I did tell you about in terms of the AFCFTA, we need healthcare. It is already a priority in terms of sectors that they think that you can kickstart the fourth industrialization on the continent. So you have healthcare, you have automotive, you have agriculture, you have there are about 5 sectors that they've chosen, and pharmaceuticals and healthcare is one of them. And we want them to be solely in the terms of the protocol in the AFCFTA protocols and services. They should take on board issues of healthcare because it's complex among others. Okay. This is just exactly what I've been explaining in terms of rules of origin, the FCS protocols to harmonize private sector environment. We do have protocols now that member states, again, when I say member states, I'm taking African countries that have adopted, which is a protocol on investment, a protocol on IP, intellectual property, a protocol on women and youth, and all those things tell us now if you're a private sector, what does it entail, in terms of my investment protocol, so that all member countries must have a conducive investment, environment for the private sector, and it will be, standard in the whole of the continent. Okay, I have talked about this. We can skip. All right. I talked about the AFCFTA, some of these operative tools, because it's a big agenda, but for it to work, I talked about the rules of origin, which is made in Africa. I also talked about the non-tariff barriers, because we know that movement of goods or services or business from one country to another is difficult because of transportation, but also issues of at the border, among others. So there's a non-tariff barrier mechanism that member states can, or even private sector, or anybody for business people can actually report. It's online. You can report that I faced a BCD problem, and it goes to the secretariat, but also it goes to the country that you're reporting to, and then the mechanism has been established so that they can be addressed. It also, I talked about the guided trade, which is I'm talking about the hand-handling member countries so that they can trade among each other. Why do we talk of trading within Africa without necessarily, of course, there's trading outside Africa? When we looked at data, I didn't bring it up here. Trading in Africa, it enhances industrialization, because if you look at the kind of goods we trade among each other, it's finished goods, and that's what we want, because then we have added value, we have created jobs. But when we are trading with the rest of the world, we are sending raw materials, and we all know the story of raw materials. The AFCFTA also comes with the Pan-African settlement system. We know the issues of currencies, and this is being taken by Afreximbank, which basically means you can pay a product with your currency, and the Afreximbank, which is headquartered in Egypt, will do the mathematics, and they make your payment for you. So it makes it easier to to do intra-African trade, but also to buy and purchase within the continent. There is also elements of automotive fund, because we want to produce on the continent, and one of the sectors that they also chose in terms of kickstarting, industrializing, creating jobs, and achieving our goals in Agenda 2063 or 2030 is also automotive sector. They've come up with the automotive fund for those who want to manufacture cars. You can apply there, among others. Okay, this part I think I can skip because we've talked about it as well. Yeah, and then I want to talk about, because this is all research, and in ECA we translate our ideas into action. So prior to COVID, we came up with an initiative that we call the AFCFTA Anchored Farmer Initiative that had 3 pillars of food procurement, local production, and regulatory harmonization. And it's in 10 pilot countries of Djibouti, Eritrea, Comoros, Ethiopia, Kenya, Madagascar, Mauritius, Rwanda, Seychelles, and Sudan. That's why you saw some of the data that we had for different countries. We did a feasibility study. And again, the idea was to say, if we are talking of the AFCFTA with this so much potential, can we test it? So that's the pilot we're trying to test now. Now we bring these 10 countries as one market. Can we implement food procurement of medicines in this country? Can we talk about local production in this country? Can we talk of harmonization of regulatory policy in this country? That's exactly what we are doing. So we carried out a feasibility study, and it identified up to 117 medicines that can be procured. And out of that, 10 are the one that we are piloting, and it's in maternal and child healthcare products. And we have already done the food procurement mechanism technical design. And we are about to ready to test it. And then the heads of states early this year in February gave a mandate to Africa CDC to say they should lead this food procurement at a continental level. So we are transitioning now to Africa CDC, and now they're adding in the food procurement vaccines and also additional other countries, including Nigeria. And we will be reporting to the heads of states in February in terms of what we think the technical design should look like, and also the feedback from member countries, among others. So it is, again, I talked about the advantages of food procurement, affordability, increased access, but also it shapes the market in terms of local production. And then, of course, all these challenges we're talking about in terms of stock out, quality, we can take care of that when we are producing on the continent. And then, of course, not everybody is doing it, so it has the regional value aspect of it. The local production, we talked about it. We published 2 expressions of interest asking for African manufacturers who could produce those products. And they went through the technical and GMP inspection. And the reports from them, depending what is their kind of specific capacity building initiative that they needed, we then link them to the relevant technical capacities. Those who needed funds, you have your African Development Bank, Afrexim Bank, to take care of that. Those who needed some trainings, those who needed some skills, we are working with university to make sure that the whole full value chain approach is taken care of so that production can happen on the continent. We even have I think Ruto, I don't know, he's our local production champion, and health financing is Kagame. So you have those kind of heads of state champion, those specific areas. And of course, in Kenya, there's a lot of production of pharmaceuticals on the continent in Kenya, and health financing. We all know what is happening to Rwanda. There is the technology fund from African Development Bank is there. You have the African Medicine Agency is there. You have the IVM, the International Vaccine Institute is there. You have this company that is BioVac doing vaccines. So, he's doing what is needed to do. And then, of course, regulatory harmonization is going to happen there because the chief executive for the AMA is being recruited as I speak. So I wanted just to bring the news that, these are some of the things that we are doing at ECA, and all those countries, plus in addition to other countries, will be part of the food procurement. So I think that's where my my presentation ends. But I just want to say that there is a nexus between health and economic growth, and we look at it. We need to look at it in that context, and we need to look at health as an investment, so that the private sector can come in and support the government because they cannot do it by themselves. We need research. We need to work together, and we need to produce on the continent. I think we can do it. Thank you.
Go ahead. She took more than 20 minutes. She took 40 minutes. But I won't show her the paper because that's exactly. I won't tell you. We're enjoying it. Yeah. So before we go to the panel discussion, I'm sure we have enjoyed this presentation. Very intriguing. You see, the statistics is so is mind-boggling. Look at statistics like African having 25% of global disease burden, whilst we manufacture 2% of our medicines. But the issue is even that, even the 2% we are manufacturing, when you go to the pharmacies, people don't want to buy the locally manufactured medicine. I have gone there and I say, I want paracetamol. The first thing they do is that they give me a foreign paracetamol. And they think that that is better than the locally produced one. So if we don't also work on our mentality that things produced in our countries can be better, then we may end up thinking about that manufacturing in locally and we won't get the market. So I'll open up for questions so that before we go into the panel discussions. So if you have questions, clarifications, you want to add, but before you, let me ask my question first. Yes. Okay.
On the practical aspect of things. Africa has been known to engage in all these grand plans, even right from the formation of the old OAU. There were very grand plans in terms of what OAU stood for. And of course, after some time, the continent decided that it was not fit for purpose and rechristened it the AU. So my point is that gathering together initiatives have been have been a part of Africa, and it didn't start today. But of course, we know the story of the continent all too well. My question, also my worry, is just to ask you from a vantage point. You are the ECA. In fact, let me just say this also. I know I attended an ECA conference some years ago, and it's really pained me when top policymakers in Africa had even given up on our African Development Bank. And they said to our face that we actually are not the owners of African Development Bank. They were actually advocating, though I'm not talking about in a formal thing, it was just by the side, to my hearing, that actually, because of course, some of the big shareholders of African Development Bank are not African, by the way. So they were advocating for a new multilateral development institution that Africa owned. These were policymakers even within the framework of an ECA thing. So my question is, how feasible do you think all these initiatives are? Especially given in Africa, because I'm very worried that countries are getting insolvent, but all these things require resources. And I just wonder when we are even going to sunset many of these externally that we are using to support our health system abilities, which is what ODM, whether it's whatever of a technical, of a policy advisor, basically. When do you think that these things are very realistic actually to achieve? Thank you.
Yes, thank you very much. I think he has swallowed my question, but mine had to do more with vaccines vaccine manufacturing, that this big chunk, shouldn't we reduce it a little bit such that we can manage in terms of maybe regional manufacturing versus now it's a whole Africa thing. Thank you.
Right. I just wanted also to reiterate what Chijioke said. There were manufacturing companies in Zimbabwe, like I said during my presentation and panel talk yesterday, that used to do many essential medicines and IV fluids and all sorts of things, who got bankrupted by the government not paying. So that's a very important question to say, because now I know, for example, the 99% of the essential medicines in our medical stores are bought by partners. But for partners to buy those, they buy from pre-certified manufacturers, WHO pre-certified manufacturers, and it costs 5 million for you to have your plant pre-certified. And who is willing to take that risk? And of course, this is all by design. That's the boomerang effect of aid, to say, I'm gonna give you money to buy medicines, but you buy from him and not anybody else. So I think we need more clarity on the pragmatism of these initiatives.
My concern is also, you talked about COVID-19, the Russia-Ukraine war, and that led to governments borrowing so much. But if you check, governments are also using that to kind of misbehave with the borrowed money, issues of efficiency, issues of waste. Is it possible that you guys can able to engage governments? I know you may not have the gavel to strike government to say do the right thing, but to name and shame, because they borrow this money, what are they using the money for? Because I know my country, for instance, they borrow so much, but we cannot just understand where the money went to. And when you ask, I mean, all the problems we're having is COVID-19, Russia-Ukraine war. So as an organization, is there plans or a decent mechanism to hold governments responsible for the waste, the inefficiencies, and all that? Thank you very much.
Okay. So if I know the answers to all this, then our problems are solved, isn't it? So that means I don't know, but I'll try my level best. As UN, we are owned by everybody, right? All the members in Africa, the African countries, and the rest of the world, they established UN. Now the effective of UN is another, debate. But I just want to put it out there. But you spoke about all these regional initiatives, the practicality of it, and how sometimes, I think you said you came to our meeting and there were policymakers saying what they have to say, but it's like being here, right? So people can say whatever they want to do, because I think, when we are having this debate, people need to be honest and say their feelings. But for your information, ECA is the one that, advocated or conceived the idea of the African Development Bank. And even up to now, it's like we gave birth to them, and the baby becomes too powerful than the mother. It's okay with us. We don't have a problem with that, because we understand the need for the African-based institution that finance the African development agenda, isn't it? You also have the African Bank, which does the trade aspect and among other regional banks. So I think we work well with African Development Bank, and I don't think we have an issue. Of course, member countries can have problems with the African Development Bank if they are not,
because they are members of, their members is constituted of the African members and what they call non-regionals. And non-regionals, some of them, they've the one that, have biggest share because they pay more to the African Development Bank. So they have more influence, how these things work. So maybe when African Development Bank goes to a certain country, it gives them conditions what they don't want, or they tell them you need to do A, B, C, D, and then they come to our meetings because as each year we report to the African Ministers of Finance. And they are the one who give us the mandate to say, okay, this year you should focus on ABCD. And so each year when we meet them in March, we report to them to say, this is what we have done, this is what you told us to do, this is what we have done, and this is our proposed work plan, and we have that kind of debate. And then also we propose anything depending on what is happening on the continent, then we debate on those issues. So you might have come to those meetings and you hear member come and say that it's allowed, but doesn't mean that that's an ECA perception. Yeah. So in terms of initiatives, whether they are feasible, I told you before that, if I by one way we should all stop, having this meeting, we should just implement. Implementation is a big issue on the continent. We do not implement. We like to talk, and come up with decision. At AU level now, with this agenda 2030, they've come up with a monitoring mechanism. And they also, the heads of state, they've actually given a mandate to AU to now start tracking the over 6,000 decision making they've done since they've been, in existence, and see what have been implemented, that has not been implemented. They are also coming up with reforms, but remember, AU is a policy institution. Implementation doesn't happen in the country, and they don't have a, enforcing mechanism. This is why the regional integration agenda on the continent is suffering a little bit, because number one, if you look at AU, even who finances, most of the money comes from development partners, except, programs, money comes from development partners. Member states don't want to pay. And so they don't also have the enforcing power. You see issues of peace and security that is coming up with that. But what we do from an ECA point of view, we do sort of what they call positive encouragement. Those countries that are doing well, we give the highlight, whenever we have our meetings, a certain president will highlight certain things that are doing so well, so that it gives, it exposes its lessons learned. And those who are not so doing well, we meet them also in their corridors and we talk to them nicely. And sometimes here and there we put it in our reports, and then they challenge us. They say, what are you doing? And all those kind of things. So we do that, and we meet our member states. Feasibility, like for example, I like to talk about this new baby on the AFCFTA, frameworks. Implementation is happening. Goods from Kenya, they are going to Ghana, they are going to Egypt. I was in Cameroon 3 months ago. We went to the port. They were exporting goods to Egypt, and they were importing inputs from Nigeria. All those kind of things. So things have started happening, but it's a small scale. But it has to start from somewhere. And also, we have to, like you were saying, we have to change our mentality of made in Africa, because we still think that anything that comes out of the continent is better than ours. So it's also all the onus on us. So it's happening. Resource mobilization, implementation needs money. And I think that's one of the issues that we have on the continent. I think there's a lot, we need to come up with innovative financing mechanism, domestic resource mobilization, because you cannot develop a continent by aid. That's not going to happen. So we need to find a way to, of course, better mechanism of taxation and utilization of ineffectiveness. Issues of illicit financing flows, tax mispricing, corruption, name it, all those kind of things. On illicit financing flows, we are losing about 100 billion a year by all these deals that we don't need. So, issues of remittance, we need to figure out how to mitigate. So there's so many ways, resources, if we add value, and of course, efficient that is talking about that, we can have, we can finance our own development. You talked about vaccine manufacturing, the regional aspects. Yes, I don't know whether you remember the discourse during COVID and immediately after COVID, almost every country was saying, I'm producing this and then I'm having this vaccine. Well, it didn't happen. Number one, is complex. Second thing, we also, in AU in particular, started talking to these member countries and realized that it's not feasible. We have 1.4 billion. So if everybody's going to manufacture, and that's what even saying that, of course, we can export, but then it oversupply. So it's not going to happen. And there's that discussion ongoing. So we have that kind of regional manufacturing hubs. Manufacturing in Zimbabwe. Yes, I hear you, Nkoma, but you know, there are certain countries, since I'm Zimbabwean, I can talk openly. There are certain countries, there are certain situations, you know, that, you know, it happens. I think Zimbabwe is a unique one, an outlier. We can't say what is happening in Zimbabwe is what is happening in the rest of the continent. We are a special country, which is going through special and unique challenges. We know them. You know, and it's a shame that we are where we are. Yeah, it is a shame, but let's just put it, it's an outlier. Come on, we all know that. It's an outlier. We can't say, you know, because Zimbabwe did not pay, so the rest of the countries are not paying, so manufacturing has gone in. So we'll leave it there because I still need to go back home, you know. So, yeah. Another issue that in general also that we should not fear away from talking about is corruption, efficiency and corruption, you know, and governance issues. I think we do have governance issues, and we do have some governance index that we have in ECA that we monitor. And you know, again, you know, when these results are that bad, we talk to these countries in, you know, in their corners and say, hey, let's do this and that. So we do our part. I don't think, and I can say this, I don't think there's any African country doesn't know what to do in terms of research that we have done specifically for their countries and what needs to be done. They're just not doing it. And then there was a question on, what did my wife say? What did you all say? Efficiency, yeah, it was issues of efficiency. I know, we all know. I mean, you know, most of our governments sometimes they like these. You know, we're just not efficient. If you look at sometimes when the head of state or a minister is coming to a meeting, they come with a big entourage. You know, if they were just coming with, even if there's an embassy, why do you need an entourage from the capital? The embassy and the economic policy officer who is there can help, and that money can go the hospital, that money can go to a certain school, that money can go into the refuse collection, that money can take off the water and all those kind of things. So really, you know, more than anything else, we have governance issues, corruption, but we don't have confidence in ourselves as a people. And I don't know whether, now I'm talking as an African, not as an ECA member, I'm talking as an African, and you know, that I don't know whether we love ourselves, because why are we so mean to each other sometimes? But I mean, that's something out there, but like I said, I presented the figures into who we are and the nexus, and I think I've answered all the questions. It doesn't mean that it's right, because I told you if I know the answer, then I'm a little God, so I did my part.
What's the point of clarification? I didn't mean that it was ECA people that.
Yeah, the policymakers, yeah.
It was just people, you know, policymakers.
Yeah.
So they were just talking about the pessimism.
Yeah.
On the highest level. Not that it is ECA.
Yeah, but that's the environment we're operating in. And when it's any debate, you know, when it's a think tank, we allow everybody to be open to say what they want to. And then hopefully we hope that the evidence can influence their thinking, and hopefully they can change, and then they can, you know, practice it.
Yeah, maybe just to add on to that, I was looking at the WHO, you know, there's this.
For the GMP, yeah, I'll talk to that.
The target is to raise $7.1 billion for emergency preparedness. And I was looking at the list of countries that have confirmed their pledges. And, you know, the biggest funders are your Bill and Melinda Gates, 40 million and so forth, and others, and European countries. You know, I looked at some African countries, $6,000, and the fund is at 1.5 billion. Yet it's supposed to get to 7.1 billion. But when the epidemic or pandemic starts, we cry the loudest.
Nkoma, you are right. I was talking to my sister there when I was saying, you know, very practical terms, like you have your house and I have my house. Now, can I give you money, your house, can I give your household money to the point that you do better than me? It's not going to happen, you know, and we cannot develop by aid, really. And statistics have been saying that for every dollar that we get on the coin, 70 cents goes back. So you're getting 30%, 30 cents. So if aid was that effective, why are we where we are? Besides that, I think that we have talked about, whether it's your corruption or something like that. So it's never going to happen. And then, during COVID, yes, we were at the back of the queue, even when we got money, because like I told you, I was privy to some of these meetings and discussion. We are still down there. But let's be honest, I know it sounds, if we had a pandemic like ours, are you gonna go ahead and start give Africa without giving your people first? It's just, I mean, it's selfish, but it's just what it is. So, and I think it was a necessary wake-up call in its own. And you are right, now we're talking of preparedness and we're not pledging. And when, may God forbid, when something happens, then we cry again. Hey, Africa, my beloved country and continent. So.
Yes. So you realize that if we want to talk about African problems, we need a whole week. But we have seen the numbers. Yes, we've seen the numbers. Let's start thinking about them, because we are importing about 16 billion worth of medicines, and we are only exporting 1.4 billion, and that's even 2022. And the numbers were there. Okay, so we are not, time is not our friend here, but we have a last session, not a last, but another very important session. I think this is like a summary. We've done all the nice presentations and discussion, and we are bringing all that to conclude. And Jane did a good job by presenting this. So this session dovetails into that. And what is it? We'll have a panel discussion, which will look at leveraging the COVID-19 lessons to strengthen African vaccine systems and manufacturing landscape for current and future outbreaks. How can Africa achieve the 2040 manufacturing vision? It's a mouthful. So we'll have about 4 people to do justice to this topic, but we'll break it down to 1, strengthening vaccine systems for future outbreaks. Strengthening vaccine systems for future outbreaks. And we had the COVID-19 presentations and all that. COVID-19 is now part of us, normal. Why are we still doing it? We are doing it because of future outbreaks, because we know that outbreaks come and we don't know when they come. So once this has come, we need to learn lessons from it to prepare ourselves for future outbreaks. And that's why this panel discussion is very important. And we've gotten people who can do justice to this topic. So the first break is strengthening the vaccine system for future outbreaks. From there, we'll go into achieving the 2040 vaccine manufacturing vision. So the panel members who will be doing justice to this, no in particular order, is 1, my husband, Jane. Please. Sarah. What's the name? Zunya. Zonyi. Is that it? Online. Okay, it's online. Okay. I have the other one. Okay. Professor Chijoke. Give her a hand. And then the last but not the least is Dr. Chikezie Efenya. So with your permission, I will pose the questions to them. Permission granted? Good. All right. Good. Chicho, you are starting. Yeah, yes. Yes, you're on the line. So the first question to you is, is it on? Can you put it on? Tingo? I think you can put it off. When I finish, then you can put it on. The feedback. So the first question is, trust and misinformation came up as a key enablers of vaccine hesitancy and barriers to uptake during the course of these conference discussions. How can Africa improve community trust in vaccines and reduce vaccine hesitancy to enhance uptake during future outbreaks?
Okay, thank you very much. I mean, that's a very pertinent question. So if we have been following the Ecova project, we'll see that vaccine hesitancy has been at the core of the results that have come in. And of course, we know it was a big problem because, of course, initially, African countries didn't have access to the vaccines. But then as we have learned, later, when the vaccines became available, then the issue of vaccine hesitancy then came up because of lack of trust being one of them. So how can African governments address this? I mean, there is no one size shoe fits all, but especially given the insights that have come out of a ton of research on this, I think that we can do few things well. Number one, we need to be proactive in messaging. I think one thing that we all agree that research has shown is that many of our countries were reactive. We allowed social media to dictate, first of all, how people viewed the virus and then the vaccines. And especially where I work, there is something that has actually intrigued me. There's a way you can become proactive. There is a unit that engages in what they call social listening. So it's not just about COVID. It's about, they just go to social media and make use of big data analysis techniques and look at exactly what people are talking about on social media spaces. They scrape the data, and now they can virtually, almost in real time, know how perceptions are, and then know what kind of messaging to pass if they need to counteract some negative sentiments. So this is something that African governments should build into their health systems going forward. Proactive messaging, social listening skills. That's a very important way to counteract these myths. Another is education and training, especially for health workers. I mean, we saw today from some of the presentations that many health workers were not even willing to take the vaccines, even though they were the midwives of the vaccination, the vaccination program. So there must be, we cannot now assume, I mean, as well as Dr. Layinka mentioned today, we cannot just assume that because you're a nurse, you're a doctor, that you will go out with the right messaging. There has to be training. There has to be that conscious interaction with healthcare workers, for them to communicate effectively with the people. But finally, because I don't want to hog the mic for long, the issue of using what I might call trusted publics, like community leaders. There's some research that showed that actually people became willing to take the vaccine when people in their communities that they trusted, be it the local chiefs or be it religious leaders, took the vaccine or encouraged them to take it. And everything I've said here is not just saying anything. It's just not just saying what comes into my mind. It is backed by solid research. So these are some of the ways that the continent, that the African governments can try to fight against this monster of misinformation, disinformation, and vaccine hesitancy. Thank you. Okay, this is good, and you realize that these issues that, as Chijoke said, have been picked up bit and pieces during our discussions, and you have put it together now. You have put it together beautifully. So let's move on to Chikezie on how governments and stakeholders apply lessons from COVID-19 and integrate pandemic preparedness into broader health system strengthening.
Thank you very much, Prof. Yeah, before I go to my question, I would like to add a little bit to what my brother just said. So one thing is the trust on the vaccine. Another thing is also the trust on the system itself. Yeah, so of course, because of the Ecova project, a lot of things came out, and it's one of the issues that actually was highlighted during the study. You know, the mistrust on government interventions. Of course, it is through the government health system that these vaccines are delivered. So it's just for us to actually think of targeted, like Chijoke mentioned, targeted information that is contextual to the community to ensure that actually they take up these vaccines, or drawing back their trust to the system itself. Yeah, so that brings me to my question. So in a phrase, just having a resilient and responsive health systems, I look drawing across the health system components, and I think I like the fact that Nigeria added 2 more components to theirs, community participation, and of course, partnership and research. So you can't do without these community gatekeepers. So incorporating them into the system as part of the system actually goes a long way to ensure that, of course, people actually take this vaccine. And of course, the question is, how many countries in Africa have contingency plans for outbreaks and epidemics? If this kind of thing exists, I'm sure that it would, be running helter-skelter when this kind of thing comes up. Thank you.
Yeah, don't give that, just a follow-up. Yes, you are saying that governments, you don't know how many African countries are prepared to fight any other pandemic or future pandemic. Is that what you're saying? Okay. Yeah. As I said earlier, in Ghana, we are prepared. We are still collecting our public taxes. And that's the way we're preparing. But anyway, you will see that we are often fighting quenching fire. Or wait until the thing happens and then we quench fire. And so this question is so relevant. And what Chikezie has said is very good. Now let me go to my husband, Jane. Are there findings from this Ecova project that you have listened to in the vaccine manufacturing or delivery environment across Africa? Alternatively, have there been any notable example of how the project findings are feeding into policy or practice that you can mention? I know in your presentation you mentioned here and there, but you can make it clearer with this question.
Thank you, wife. You are doing very well. Yes, these past 2 days, we have had a lot of recommendations stretching from the causes of vaccine hesitance and what can be done. So I think what has been established that the vaccine hesitance is with us. It was there before and it was there during COVID and is there now. And you know that the heads of states, like I said, they have a declaration that by 2040, 60% of the vaccines must be that are consumed on the continent must be produced or manufactured on the here on the continent. So I guess what it means is that, you know, knowing that there's already vaccine hesitance, we don't need to stop. We need to continue this targeted communications, apply some of these recommendations that are emanating from this Ecova conference in terms of targeted information, communications, getting influencers, people that can influence the discourse. We need to come up with how to also take care of our health worker communities. Issues of infrastructure, we need to take care of that. We need to take the lessons of COVID and what is emanating from now and apply it. And I know it's already happening. I don't know whether you saw me coming out earlier on. I was talking to a colleague who is championing this Africa Food Procurement Mechanism. And I told them that I was in Nigeria. He says, oh, we're here last week. And they met with the ministers of health, among others. And they were telling them that vaccine manufacturing is happening. So what do we need to do? Of course, Nigeria is one of the biggest market. And they you know, if Nigeria agrees with us, you know, the continent is agreeing with us, so they needed to convince them. So the advocacy is already starting, and I think we need to scale it up as such. Local production, we already know that Rwanda is doing that. Here in Nigeria, Afrexim Bank is just given some funding last year to a Nigerian who is doing some vaccines here in Nigeria. We have some of course, Aspen is up and running. So it's happening. And we have Morocco doing something as well. So the local manufacturing is happening. We already have, of course, Senegal, IPD. So, you know, so we do have some pockets of manufacturing. It's how do we scale them and which vaccines are they producing so that there is no competition among each other, but there's complementarities.
Holding the mic. Are there lessons from this project? When I say project, the whole Ecova project that can be applied to, let's say, this Mpox disease.
Okay. Okay. Yes. If you look again at some of the communications and perception that people are saying the causes of Mpox and how it transfer to one another, you know, you can tell there's also information gaps. So we need to, of course, to ensure that people are educated adequately. The past, is it 2-3 months? The Africa CDC, you could hardly find them in Addis. They were in these countries, and of course, the most targeted one is DRC. They've been going there, and they say that they have a handoff. This is what they're telling us, but the issue is always health financing. Most of our countries, they're not, they have fiscal constraints, so to speak. So these vaccines, they're available, but they're coming from developing partners. So of course, the issues are the same. And we need to do better. The research is telling us that we need to produce on the continent. The research is telling us that we need to educate our workers. The research is telling us that we need to have influential figures helping us. The research is telling us also things that we need, and we can apply that. Actually, as I'm thinking now, we do have an Africa Business Forum that is coming on the margins of the state in end of January into August, and we do have a side event on pharmaceuticals. Maybe we should try and see how we can get some of this research, and maybe if one of you guys, make a presentation there, and there will be heads of states, and let's see if it gets to the, to the decision maker, if it can be implemented.
Thank you.
I'll try. Okay, so thank you, Jenny, for that highlight. I just want to add to that. So, if we're looking at collaborative way of addressing issues, yeah, specifically from the study COVID-19, Ecova project. Yeah, so it's a lot of mention that collaborative mechanisms actually went a long way to address COVID-19. What I mean is, the Ministry of Information, what are they supposed to do? The airport authority, what are they supposed to do? The CSOs, what are their roles? Even the community gatekeepers, what are their roles? We bring all this together. I mean, of course, from the study, it goes a long way to ensure that the issue of COVID-19 was addressed. Thank you.
All right. Thank you very much. You can note down your issues, things troubling you. I may give you a chance to come in. Now let's go to Sarah. Is Sarah with us online? Is there? Okay.
I'm here.
Okay. So this is your question. Are there some notable innovations and practices from the pandemic responses that Africa could learn from and perhaps institutionalize for future pandemics? Let me take the question again. Are there some notable innovations and practices from the pandemic response that Africa could learn from and perhaps institutionalize for future pandemics?
Thank you. Thank you for the question. I just want to check, can I be heard properly?
Yes, you're audible, loud and clear.
Great, thank you. So yeah, I think that's a great question. First, I just want to preface it by giving an example of a criticism on the initial COVID outbreak and the response to it, that there were quite a number of people who pointed to the experience of West Africa and the lessons learned from the Ebola outbreak in 2015, and a lot of criticisms asking why did the global community at that time not apply a lot of those important lessons that came out of the West African experience. So I think one thing to emphasize here is the importance of understanding or thinking critically about whose experiences and whose knowledge do we value and do we prioritize when we're thinking about what we can learn. Really what I'm trying to say here is it's really important to look at what are the homegrown innovations and best practices that could be applied and scaled across Africa. So I've heard, a lot of great examples from South Africa, from Rwanda, from Kenya as well. So that's one thing I think that should be prioritized is the South-South learning and adopting innovations from countries across the global South. One notable innovation I think I can highlight is digital health solutions. This became increasingly important during the COVID-19 pandemic and has actually kind of changed the face of healthcare. Things like telemedicine, mobile health solutions, online health data systems. These are becoming increasingly important in order to both strengthen our health systems, but also to better prepare for pandemics. AI solutions or artificial solutions, of course, there are pros and cons of anything. So for AI to be used and implemented well, we need also strong regulatory frameworks for how it can be implemented in countries and of course not to be used for bad. I'll just give one example here. IDRC supports a program called Artificial Intelligence for Global Health, which is implementing new and novel solutions on how AI can be used for pandemic preparedness and response. And we have wonderful projects across Asia, Africa, Latin America, and even the Middle East and North Africa. So a lot of really important lessons learned, you know, in terms of implementation challenges and success are coming out of this. And then another innovation, I think that's really important to note. You know, Jane, I really appreciated your presentation earlier when you spoke about the economic and health nexus. I think also the environment and health nexus has to be also considered quite strongly. So one approach is called the One Health approach, which is the integration of human, animal, and environmental health in terms of how we you know, implement surveillance systems and implement also our response systems. So, you know, with climate change and changing environmental conditions, it's more likely to have increased disease spillover from animals to humans. So it's really important to have strong surveillance systems that, you know, are not artificially bounded human health, environmental health, animal health, but to have people working together. And for example, IDRC supports community-based surveillance systems. I mean, outbreaks happen at the community level, so you have to be able to detect. And this is what allows for early response and then containment to be done. So there needs to be also the vertical integration with the different levels of government from the community. And then lastly, just we need to reflect also on the broader impacts of the pandemic. So for example, how vulnerable groups were affected, you know, women, children, marginalized communities. And so when we're thinking of building back better new policies, really thinking about how we strengthen the social protection systems, our economic systems, and then this allows also for the health systems and then any pandemic response to also be stronger.
Thank you, Sarah, for this comprehensive response. Sarah's response brings to the end of the first component of our panel discussion, and which is strengthening vaccine systems for future outbreaks. So if there's somebody who has a burning clarification to make, you can I can allow the person to. Any hand? All right. Very good. It means that my panel members are doing a fantastic job. Great. So we go to the next or the second component, which is achieving the 2040 vaccine manufacturing vision. And the staggering figure that Jane mentioned was the fact that currently we are doing only 2%. We are doing only 2%. And it's not good. I know this COVID-19, when the vaccines started coming, they had all kinds of names. Some coming from China, India, and everywhere. And so there was discrimination. Those coming from China were discriminated because we all know China products. It's like they're fake. So, and people are now saying, why are these advocates taking this vaccine and we are taking this? So these are issues. But if we are manufacturing in Africa, we'll give it one name. And that should be, but another problem is, do we believe in ourselves? Do we not believe in ourselves and what we manufacture? These are all issues. But be it as it may, we want to achieve 60% of manufacturing 2040, by 2040. And I will ask our panel members to clarify some of these issues. So Jane, what are the key priorities and critical enablers for Africa to achieve the goal of manufacturing 60% of its vaccines locally by 2040? I know you said bits and pieces in your presentation, but it's an opportunity for you to put it together and re-emphasize. Thanks.
Thank you, wife, for keeping it in the house. Yes, the key enablers for 60% manufacturing by 2040. Of course, you need research, R&D, you need a skilled workforce, you need GMP inspection, because we African standards are also global standards. Human African life is the same as life anywhere, so we need to keep in with the standards. You need the technical expertise, you need the health infrastructure that goes along with it, you need energy. So these are all, of course, you need the harmonization of policies. We did talk about, the process of manufacturing is a huge financial outlay. You need financial health financing, you need the funding. And if you ask the private sector, they'll tell you, you need to have, of course, it needs to make a business case for them. So I think it's important to look at healthcare as an investment case. And it's important to notice that, those to achieve that, the private sector needs to play their part, and government needs an enabling environment. So what is happening, because it is happening, what is happening right now on the continent is that, a company like Aspen, for example, which is already manufacturing vaccines, what they need is, of course, the uptake for government. Some of the local procurement laws need to be changed so that we can, governments can buy from our African manufacturers. We also need our own people, consumers, we need to change our mindset. We need to buy made in Africa. And that confidence, which means then the issues of standards needs to come in. We need to make sure that our medicines are of standards. And we have the African Medicine Agency that is being operationalized in Rwanda. It's exactly going to do that. We know that it's a huge, financial outlay to have GMP inspection. But we are ensuring that the private sector gets the necessary funding they need. WHO is also UN like us. So we are talking with them to see how they can make this GMP inspection attainable in Africa and in the rest of the countries. You have other standards, FDA. I mean, in America, they don't have GMP, they have their own standards, but I'm not saying we should have the American, what I'm saying, basically we should have standards. And the outer NEPAD is working with WHO, also come with, I don't want to say this, but to come up with standards, which is the same as the GMP standards. That's why I was saying African standards is not different from GMP standards. So these are things that are already happening on the continent. I told you about the food procurement that is happening. We'll be reporting to the heads of state this February in terms of what kind of food procurement mechanism, what should it look like, the structure, the institutional arrangements of it. We know the countries that have already agreed to be the pilot countries, and Nigeria is one of them. We know that it will focus on maternal and child health products and plus vaccines. And so then, if you do that, the private sector will know that, that will shape the market. Now I can produce because they have the order, isn't it? It's all about the order and profitability of the private sector. So these are things that is happening. In terms of skills, the PAVAM, this PAVAM initiative, or the new public health order, comes up with about 7 aspects, the whole ecosystems in terms of vaccine manufacturing, but the pharmaceuticals. It talks about what needs to be done in terms of skills development. They are doing some trainings for existing manufacturers and those who want to go into different kind of areas of vaccine or medicine manufacturing. And there is that partnership that is happening in terms of financing. African Development Bank, they're doing that. And you have the fund in Rwanda and people can apply to this. So there's a whole lot of things that is happening. And I'll stop here, otherwise I will not stop.
Yes, my husband has answered the second question. But the one key thing he mentioned that I want to follow up is changing our perception to want to consume what we produce in Africa. I know when it comes to some food stuff, for instance, rice, that is changing, that people want to consume local rice as against foreign rice. But when it comes to medicine, how do we do that? How do we change that perception that our local medicine is better than foreign medicine? Because our local medicine sometimes is 5 cedis. The foreign paracetamol, for instance, is 20 cedis. And people think that the higher the price, the better the medicine.
So I think he wants to take it. I'll breathe while here.
Look, as I keep saying that there is no one way to do these things, but I think that one key thing that is likely to work is I like the idea of the joint regulatory mechanism, because when citizens have been, conscientized to know that this product that they are looking at has gone through a rigorous validation and regulatory system, I think that perceptions might begin to change. But it's not going to happen overnight because, to be honest, to be fair to the population, they have had to contend with fake products for quite a long time. So you cannot do it overnight. But we can start from somewhere, and I'm really excited with all these continental initiatives. So I think it's for policymakers, for leaders to redouble efforts in terms of making sure that whatever is put in the market in the name of Africa goes through a rigorous regulatory regime in terms of quality assurance before authorization is given, and that whole system that the citizens are taken along as we transition from one stage to the other of the production of the entire value chain. I think that will help to change mindsets. Thank you.
Perceptions. How can we change perceptions?
I'm not actually looking at perceptions, yes, but just as he was talking, something came into my head. Regulation is very good, really, but what I laughed was having people to monitor regulators also is another issue. I'll tell you why I said that. I went to buy fuel some time back. So I bumped into this, what do they call them? Those that regulate pumping price and all that. Immediately walked in, the manager of the filling station diverted the man and gave him some money, and nothing was done. So it's not only in that space, also in, of course, our health systems. There are a lot of corruptions happening there. So if there are people to checkmate what the regulators are doing, it will also go a long way to bring us to where we want to be. Thank you.
I think they've said it all. Regulatory mechanism, strong mechanism, curb corruption, but we can also put some mechanism to see how we can manage that. And of course, strengthen our health systems. Maybe use of technology, as Sarah has said, should also come into it. And I think, as we get better, and I don't think, when we manufacture this product, I don't think we want to kill our people. So I think we will get there. Yeah.
Thank you very much. Sarah, are you still with us?
I'm here.
Yes, when Jim was presenting, he talked about domestic funding, that if we want to do things on our own sustainable way, we must rely on domestic funding. But the truth must be told that mobilizing domestic funding is not easy, especially in the largely informal sector like our economies. So the question I pose to you is, how can the global community, especially donor organizations, development partners, and developed countries support Africa to ensure that they have fair access to financing, technology transfer, and supply chains for African vaccine manufacturers?
Thank you for that question. Yeah, it's a very loaded one. There's a lot of things in there, and I am speaking from the perspective of research funding organizations, I have to say that we recognize very clearly that you know, there's a lot of vested interests in this space, many of which are outside of our spheres of influence. But even though we still have a role to play in helping to support the pathways to change. So I think that one thing from a research funding side, I think one very specific thing we can do is to continue to support the implementation research. You know, as has been mentioned, a lot of these you know, continent-wide mechanisms such as the Africa Pooled Procurement Mechanism, new initiatives such as the Africa Medicines Agency is kickstarting some of its work. So one way that we can support is funding implementation research that, you know, looks at what is working, what is not working, and to provide some actionable evidence to help to scale. The other thing that I think needs to be done is continuing to, like, generally the global donor organizations and development partners to continue investing in strengthening the scientific and research ecosystem of countries. I mean, this is so foundational to making sure that we have an enabling environment to help the vaccine manufacturing industry alongside others. So, you know, investing in science, technology, innovation, supporting the national and regional governance mechanisms. Like IDRC has as part of a multi-funder initiative for many, many years, we've been doing supporting the Science Granting Councils initiative in Africa. And this is very foundational work, but we know that it helps to create that enabling environment, so to say. You know, continuing to invest in very targeted capacity building, strengthening technical training. You know, it can be through scholarships, fellowships, training programs to help build, you know, the very specialized workforce that's needed for vaccine manufacturing. And of course, we have a role to play also in terms of helping to advocate for equity in, you know, global financing dialogues and mechanisms. And I think as well, donor agencies and development partners, we also have to do a better job of coordinating across each other and make sure that we're not doing small, you know, initiatives that maybe don't speak to each other or are not complementary, but to really work on doing coordinated efforts to support, whether it's in terms of financing or technology transfer. But the last point I will make, and I don't want to take up time, is it's been mentioned a lot, but we can work on the supply side, but if we're not working on the demand side as well, then all of those, you know, all of that work and that effort will kind of fall flat. So addressing vaccine hesitancy, addressing, you know, public mistrust. This is not an issue that's, you know, unique to Africa. It's global. You know, the anti-science movement, anti-vaccine is now growing globally. So really, you know, also concentrating efforts on public health messaging, on education, and then that wider health system strengthening and improving government trust will ensure that there is actually demand and a market for investors from the private sector or even from the government side to actually invest in the vaccine manufacturing industry.
All right, thank you very much, Sarah. Good. So, is there anybody who wants to add anything to what Sarah said? Do you want to add anything? Okay. So I'm going to my final question, and this will go to Chijoke and then Chikezia. Chikezia. Okay, correct. How can Africa balance short-term needs for outbreak response with long-term goals for manufacturing independence? Because we are hammering on this manufacturing because it's so important. And this conference is so important. And all what we are saying here may go into policy at a higher level. So we're asking, how can Africa balance short-term needs for outbreak response with long-term goals for manufacturing independence?
Okay, let me give it a first stab and then pass over to you. Thank you. I mean, this is a very important question because unfortunately, we know that we are in the era of pandemics. Ebola happened, COVID came, and now Mpox. And we don't know what will come, subsequently. So whether we like it or not, however religious or whatever we are, this is unfortunately the era of pandemics. But as you rightly asked, there are short-term and long-term considerations. I think the first thing in terms of the short term is to think about health system strengthening. Health system strengthening in order to mount an effective pandemic response, pandemic control response. Things like building real capacity for the type of health worker cadres, especially that are important in or that are essential in fighting a pandemic. Things like your field epidemiologists. These are very, very important. And Africa is really lagging behind in that context. So these are some of the short-term initiatives that can be implemented, boosting the capacity. And I'm very, very excited that Africa CDC is at the forefront of this idea of crafting a health compact for Africa, which involves thinking about how do we meet the needs, the health worker needs of the continent, among other things. And one of them might involve creating centralized training institutions, because one of the presenters correctly noted today that some countries, I don't know whether it was Jane, some countries are very small, and you cannot really expect them with current reality, in the face of current realities, to train all the health workers that they need across all the cadres that they need. So things like food training facilities, centralized training facilities can help. Another, if we talk about a longer term issue of vaccine manufacturing, I mean, we have spoken a lot today, especially Jane has spoken a lot about vaccine manufacturing. Maybe this question should have actually been directed to her. I'm joking, but it's very, very important as a continent that we redouble efforts, those efforts that began with COVID-19. If you think about something like AVAT, I think the African Vaccine Acquisition Trust, which involves, Africa CDC, UNECA, I think Afrexim Bank, and some other actors. So these are wonderful initiatives. And why did I mention this and not some of the others? Is that you can see that most of the actors are homegrown, so there is a higher likelihood of sustainability and also saying that this is our own. And I liked the whole arrangement that Jane mentioned today, which will involve local production, which will involve food purchasing or food purchasing arrangements, local production, continental-wide regulation. So these are very, very important in the medium to longer term to ensure that we have locally manufactured vaccines, because these initiatives are from us. But I must sound a note of warning. Yes, we are talking about locally manufactured vaccines, and this is really the way to go. But this should not be an avenue for anything goes. We saw during COVID that some countries came up with, we have something to cure COVID, right? And even in your research, one of the informants said, I won't mention any country, that this country manufactures something, but the WHO did not accept it because it came from Africa. No, but we have to be honest with ourselves to say that
much as we are championing African locally manufactured vaccines and pharmaceuticals, it's not just anything that an African does that we are going to allow to get into the market. And we have to be rigorous. And when we are rigorous, it's even over time that our market can even expand beyond Africa into other regions. So I believe that in the longer term, we should strengthen these institutions. We should seriously look at pooled purchasing arrangements, purchasing arrangements, and issue of regulation. I keep mentioning it, regulation and other things continent-wide. Thank you very much.
I'm wondering if there is any other thing to add. However, yeah, so there's no way I like Chizuke's perspective when it comes to how to actually go about this. You know, there's no best way, or there's no, one way to go about this, really. But if you're looking at the two perspective, of course, you must have to think about the health systems. Right, he mentioned strengthening the health systems. If you're looking at the health system, you're looking at, trying to improve each aspect of the health systems. He mentioned capacity building and all that. Capacity building has to do with, of course, health workforce. Every aspect, commodity, blah, 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 it has to do with health commodities, vaccines, and all that. Right? If you're looking at it in a short-term perspective, and of course in the long term, for me, what makes more economic sense? That's where I look at it. Of course, local production actually, of course, in terms of financial savings, which Jenny presented, financial gains and all that, the long-term perspective actually goes a long way to speak to that. Then, of course, what about the time savings? So for me, there's no particular way to go about it, but I look at it, from economic sense. Thank you.
And health financing, implementation needs money. So I think we need to, come up with innovative domestic resource mobilization of efficiency. We can tap into remittances. We can curb, illicit financial flows. There's and taxation, improve on taxation and how to tax the formal sectors. And examples are there, what Ethiopia has done or Rwanda is doing. So we can learn into all those things. And if we want to come up with local production, how did countries like China, for example, how did they do it? The experiences are there. So we need to tap onto those on technology transfers, among others.
Great. Yeah, so this is the end of this work, but Sarah, are you still with us? Sarah, are you still with us?
I am here.
Great. So do you have any final words or message for us?
My only message and words are thank you to all of you. I've been listening in as much as I could, and this has been a very frank, open, and insightful discussion, and I'm very excited to see what comes out from this. So thank you, everyone.
Thank you, too. You will agree with me that, first, I've considered the panel very well. Gender balance, 2 male, 2 female. You will also agree with me that my panel members did a very good job, and they will expect nothing but a hand clap. If anybody has a burning clarification or question to ask, I will allow. No, great. That means everybody is very, very clear. All right. So in wrapping up, I think this is a very important subject. And you will, if you look at the discussion, it summarizes all what we did for these past 2 days in terms of presenting and putting it together, and these panel members wrapping it with all this key information, answering these questions that tends to summarize what we are here for. I mean, strengthening vaccine system for future pandemics and see how we can have our own manufacturing systems here. And I can't put it any better than what Professor Chijoke said. Regulations, making sure we don't rush it, making sure we do things properly so that at the end of the day it can be sustainable. On this note, since we have abused the time so much, I will not go further. I will leave it here. And I will still insist that you clap for my panel members. Thank you very much.
Yes. Can we put our hands together for them again? Thank you so much, Prof. Kazili and the team. I think it's really been exciting right from the start of this event. And unfortunately, all too soon, we are almost getting to the tail end of an insightful discussion for the past 2 days. So some quick announcements before we put this to close. I want to thank all of you for the beautiful presentations, the beautiful questions, and all the reactions to the questions and all the discussion. And also to inform you that we have plans to compile all the presentations, all the top the papers that were presented here into an abstract book and publish that on our website. And so if by anybody has a challenge or has a problem with his or her abstract being included in the abstract book for publication, please kindly indicate to us in writing and we can exclude that. Otherwise, we are going to put all that we have presented here, the abstract, at least the abstract, not the presentations for now. We are going to put the abstracts into an abstract book and publish that. The second thing is to let you also know that we also have, as part of this program, plan to present to you certificates of participation, certificates of presentation. I know I've also done some presentations before, and sometimes this becomes handy for one or two things, reasons. So we are going to share that with you electronically. We have all your details. We actually plan to present physical ones here, but the designs were not complete in time. And so be informed that you will receive certificates of presentation and participation at the end of the day. Another thing as we are about to close it, for those of you who travel from different parts of Africa for this event, I understand most of you will be leaving tomorrow. And so for those who will be leaving early, around 10 a.m. by tomorrow, we have information that the shuttle will be around by 7:30 because the airport is a bit far from town, from where we are. They'll be coming around 7:30 for us to get to the airport in time and board our flights. For those leaving at 10 a.m., so 10 a.m., 10 in the morning. So for those leaving at 10 and 10:30, the shuttle will be here at 7:30. 10 and 10:30, the time difference is not great. So we just want to put that together. So by 7:30, get ready and get in the shuttle and get to the airport, please. And then for those leaving at 1 p.m., the shuttle will be here at 10 a.m. So also get ready around 10 a.m. and then join the shuttle to the airport. Last but not the least, it's been great knowing all of you. Unfortunately, we did not get the opportunity to introduce ourselves, but my friend Riwa did a very great job, turned the introduction into game, and it was really fantastic. So can we put our hands together for her? Yes, I really like that session. But all the same, I'm not sure if everybody got the opportunity to do the introduction. So I would like us to quickly do introductions. Quick one, your name, the country you're coming from, perhaps the organization you work for, at least. And then once you leave here, try to get a colleague to chat with. Who knows, something big may come out of that chat, please. I will start with Nyasha, and let's go around quickly, please.
Thank you, Danny. My name is Nyasha Masuka. I'm a specialist public health physician. I am a member of the Zimbabwe College of Public Health Physicians and the East Central Southern Africa College of Public Health Physicians. Thank you.
And my name is James Akazili. I'm the Dean of the School of Public Health in one of these universities in Ghana. Thank you. The name of the university is a mouthful. CKT, University of Technology and Applied Sciences.
Okay.
Right.
My name is Sanait Alamayo. I'm health economics. I'm working in affair consultant and the project coordinator.
We didn't hear you. We didn't hear.
We didn't hear you. Yes. Give Doc some water.
Yeah. My name is Sanait Alamayo. I am from Ethiopia, working a project coordinator in the consultant affair.
Good evening. I'm Paineto Masengere from Uganda. I work with Makerere University School of Public Health.
Je m'appelle Koudouzoro Olivier. Je suis économique chercheur à l'université d'Abidjan-Cocody. Voilà.
Hello, everyone. My name is Tom Siddi. Come from Cameroon. I'm technical advisor to USAID, MTAPS, Medicine, Technology and Pharmaceutical Sciences program. Thank you.
My name is Mba Cleopas Katida. I am a doctor of veterinary medicine with a master in public health, and I am senior operations specialist for the same project as MTOM, the MTAPS project funded by USAID. I'm from Cameroon.
Hello, everyone. I'm Clarice Ngomwe Mba from Cameroon. I'm a research officer at the Ministry of Scientific Research and Innovation. Yeah, precisely a medical microbiologist and parasitologist. Thank you.
So the micro is not working. So I'm Riwa Khalife. I'm from Lebanon, but it has been 5 years that I'm in Ethiopia, and I work as a consultant with UNECA.
Not working, that's not what. Give me. Give.
So I'm Riwa Khalife. I'm from Lebanon, but it has been 5 years that I'm in Ethiopia and Addis Ababa. and I'm working as a consultant with UNECA, and I hold a PhD in public health.
I'm Jane Karonga. I work for ECA as an economist. Thank you. Oh, I'm from Zimbabwe. I'm from Zimbabwe.
Good evening, everyone. I'm Chinyere Okeke from University of Nigeria. I'm a medical doctor and also have a PhD in health systems and policy. Thank you.
Good evening, all. My name is Chikeze Fanichuku. One of your hosts from Nigeria. I'm a health economist. I was happy when I saw Professor John working. I'm a teacher, but I teach in the university. Yeah, thank you.
All right, good evening, everyone. My name is Dr. Tosin Olushola. I'm also an health economist. I lecture at the Department of Economics, Veritas University here in Abuja. I'm also a member, I'm a researcher at the Health Systems and Development Research Group, also here in Veritas. Thank you.
Good afternoon, colleagues. I am John Takanelo. So I'm based at the University of Botswana, the Faculty of Medicine. I am a public health physician and a health economist. So I work as a lecturer and assistant program director. Thanks.
Good afternoon, everyone. This is Tesfaye from Ethiopia. I work as researcher for evidence synthesis at the Ethiopian Public Health Institute. I used to be an instructor at one university in Ethiopia. I specialize in health system, the policy. Thank you.
Thank you. Genèse Lobukulu, come from DRC. I work at Kinshasa School of Public Health at University of Kinshasa. I'm a medical doctor, public health, and also health economics. And in this project, I'm a consultant for DRC. Thank you.
Hello, everyone. My name is Olainka Badmos. I'm a physician, public health professional. I work for USAID-funded Breakthrough Action under the John Hopkins Center for Communication Program.
I am Maulom Kweteo from Ghana. I'm a researcher. I have a master's in epidemiology and disease control.
My name is Chiji Okenwusu. I'm a health economist, originally from Nigeria, but I'm based in South Africa. I'm also a teacher.
My name is John Apuye. I'm from Nigeria and I'm the repertoire for this event. Thank you.
Hi, everyone. I'm Grace Njeri from Affairs Secretary, and I'm from Kenya.
I wanted.
Okay. Hello, everybody. My name is Deborah Ejay. I'm the Finance and Administrative Assistant at AFIA, and I'm from Accra, Ghana. Thank you.
Let me go before. And my name is Daniel Malik Achala. You can call me Danny. I'm from Ghana. Work with Deborah, Grace, and one other colleague called Elizabeth, and then another colleague, Gloria. And we are really grateful for making time to attend this event. And I leave this to my Oga.
Bonjour à tous. I'll do French, then I'll do English. So at least to get a balance. Bonjour à tous. Je suis John Atagoba, originaire du Nigeria. Je habite au Canada. Je suis économiste de santé. What else again do I add? Director executive do AFIA. Do AFIA. So it's a pleasure to have all of you here. My name is John Ataguba. I'm an economist originally from Nigeria, currently live in Canada, and I'm the executive director of AFIA. So pleasure to have you all. Thanks.
Thank you so much. Yes. So quickly to encourage you, as I said, to get to talk to one another after this meeting, and then possibly the next big collaboration could come out of your conversation. And the last one, somebody? Yes. Oh, yeah. The last one before I go to the closing session is to apologize to everybody. We don't know, maybe you may have faced one or two challenges during the course of these 2 days. I want to say sorry. We apologize for that, and we encourage you to forgive us if we may have caused any inconvenience in one way or the other. And hopefully we can have bigger events that you can always be happy with. And so at this stage, we would like to go to the closing session. I'm happy that we have our executive director here. I was a bit not sure if really he will come in to meet us in time. And so before he comes, I would like to inform you that we will have the group picture just after the last speech for this session. So I'll invite John to give the closing remarks.
Thank you so much. I must start by apologizing. Je suis vraiment désolé. I should have been here pretty much earlier, but I got too busy, too occupé, très occupé. So I'm so happy that this happened, even though it's coming at the end of our the grant for Ecova. I'm excited and thrilled that people really committed to this research. And the outputs that are coming from this research will be enormous in terms of changing policy. And that's what we hope. We know we cannot change everything, but the little we can move, we move them. You can only 1 inch closer to victory is better than 1 inch further from victory. So let's make that move in terms of policy. There are also things that might have come out of the research, which were not things you expected, but they also give you opportunities for further research to change the landscape. One big problem, which I didn't hear coming out, is we know there's what we call option demand in economics, something related to what we're doing. Option demand in the sense that there are some things that need to be there, even though we know we're not going to need them. And it happens a lot in the health sector. The health sector will have beds there. Whether there's anyone who will be admitted or not, the beds must be there. A health facility might keep anti-snake venom hanging somewhere there. Whether someone will be bitten by a snake or not, it will be there. But if you go to the general market where you buy things, if no one is going to buy tomatoes, nobody would stock tomatoes. If no one is going to buy fish, no sensible person will stock fish. But in the health sector, that option demand carries on again to the vaccine issues we're dealing with here. vaccines that we're looking at are things that deal with uncertainty. We don't even know when the next pandemic is coming. And even if the next pandemic comes, do we think that the technologies, whether it's RNA or whatever the technologies we have developed now, will be the technologies that will help us to develop the vaccines for the next pandemic? We don't know. So these are uncertainties that we really need to bear in mind. However, that is not to cast kind of cloud on the fact that we need to continue to do research and make sure that our populations are ready to be immunized or vaccinated for any next pandemic. And lastly, one thing that really, really pains me in the international arena is the fact that even if Africa develops its own, manufactures its own drugs and vaccines, will they be acceptable outside the continent? We learned a lot of lessons from COVID. Before you could travel to, well, Canada, Europe, anywhere, and you say, well, I received a vaccine manufactured in Kolebu Teaching Hospital. You know exactly what's going to happen to you. No one is accepting you to that country. Even if that vaccine manufactured at Kolebu Teaching Hospital in Ghana is the best ever on earth, no one would ever take it. It would accept you in. They will ask you to tick whether it's J&J, whether it's whether, I mean, if it's not on that list, you're not allowed in. So that's another big issue, whilst you find so many hesitancies because people feel like, why should I then trust this vaccine? You know, why should I trust it? What is in it that they are really mandating that it must be that, not the one that we know that was manufactured in our place? Then the other issue is the other layer, that vaccines are manufactured on the continent, but we don't value what is on the continent. Well, they usually say prophet is not recognizing in his or a prophetess in his or her own town. So perhaps that's a problem we need to deal with. Again, to thank everyone who's participated all through the workshop. Even though I was flying, I was participating in absentia. My spirit was hovering here anyway. So I'm happy that this came to a good end. And I also really want to thank the facilitators, the consultants, and everybody who participated in ensuring that this workshop, or not just the workshop, the research and everything that led up until this workshop came to fruition. And as you travel back to your respective countries, and whether you stay in Nigeria or outside, I wish you a safe trip. But keep the spirit of Ecova with you in terms of any avenue you have within government, within policy-making space. You have the results that came out of your research, put it in there. Who knows where changes will occur. We can also, we don't have to wait for grandeur changes. Changes can happen within countries, districts, regions, where we are. It's like saying you light the candle wherever you are. You don't need to wait to light the candle on top of a tower. Wherever you light a candle, it really illuminates and shines. So I want you to be ambassadors of Ecova. And with that, I want to hand this over again to my able chair or moderator, or I don't know his current role now. Thank you so much. My pleasure.
Thank you so much. And one more applause for him. You know, yesterday I said something, when your landlord speaks. Okay, so at this point, therefore, I would like to invite Dr. Tosin Olushola to give us the closing remarks and to eventually bring this event to an end for us.
Thank you. All right. Mr. Daniel just mentioned that after your landlord has spoken, your host has spoken, you don't have any right? But in my local dialect, it's always said that it is the person that sends you an errand that you fear.
you don't fear who you are going to deliver the message to, because after all, you said, they said I should tell you. In civil service, they say, I've been directed to. So I'm not standing here in my own stead. I just need to say that. I'm giving this closing remark on behalf of our Vice Chancellor, Reverend Father Professor Hyacinth Ichoku. He wanted to be here. His spirit is also hovering in this hall as well, but then is physically present in Kenya. So I bring you greetings from Professor Hyacinth Ichoku. He's very delighted that this is happening. And as a university, we're very glad to receive you in Abuja. We hope you've had a very excellent stay. We are also very delighted at the robust engagement and conversations that have taken place, at this conference. And I want to say very amazing and a very big thank you to the AFIA team. Excellent hosting, marvelous coordination, good, I think they deserve a very huge round of applause. Thank you very much. Yeah. Yes, in every environment, you have hitches here and there, unforeseen or unplanned things that do happen. But as far as human, involvement and human preparation and human commitment is concerned, I think this team have done an excellent job. They have done us proud, and we are so glad, as a university to be associated with this kind of, excellent-minded team. What we want to wish you is that as you go back to your various countries, your various institutions, we wish you a very safe journey. Like it has been said already, we hope you continue to keep the flag of this projects going and flying high in your various countries and institutions. And above all, Veritas University Abuja is committed always to collaborating with any of the institutions represented here in future projects and research endeavors. So please do not hesitate to reach out to us whenever you have any need, or you have a program you're doing in Abuja that requires institutional support. We're always here, to provide that partnership for you. Once again, on behalf of our Vice Chancellor, I want to wish you a very safe trip back home, and I want to use that mandate to declare, this event officially closed. Thank you very much.
The group photo. I don't want to speak again, no.